But that diabetes drug also addresses issues about blood pressure, weight, and kidney function. It might be reasonable for you to try to attack all these organs at the same time, not just in addressing glycemic control, but all the other extra glycemic benefits that the drugs could, deliver. In so doing, what you might find is that you'll be needing less and less of the other drugs for the other conditions, because the diabetes drug, which is attacking the glycemia, has also got all these extra glycemic benefits. And another way of addressing this is to think about non-adherence in two parts. First, at the point of initiating the drug, and the second, at the point of intensifying the drug for diabetes control. When it comes to initiating the drug, address non-adherence in primary care. Actually, on discussion with the patient, you could agree on starting a medication that they only have to take less frequently. For example, if you've got a once weekly medication, it's counterintuitive to think of the fact that one that you'll be taking once a week will be a better option for the patient to consider than one that they'll be taking daily. From a qualitative study, this is a statement from one of the patients. I don't have to take, if I don't have to take the drug every day, I might as well, start taking it, because I'm only having to take it once a week. And so it's a lot easier for them to take. Similarly, when you control your glycemia and the A1C target is not achieved and you want to intensify treatment, it's a lot easier for you to give a drug that they only have to take once a day than one that have to take multiple times a day, which leads me into the story about fixed dose combination. Fixed dose combination of treatment is not something that is popular in the United Kingdom for all sorts of reasons. But if you got a drug that, a tablet that contains two medications at the same time, it makes it easier for you to intensify rather than adding an extra pill. The patient would say something like, well, I might as well agree to intensify treatment if I don't have to take an extra tablet, because that extra tablet is already built in a combined pill. And so it's easier for them to take. The other way of addressing, non-adherence is, even if it's taking single dose medications, it's important to consider options that they have to take once a day as opposed to one that they have to take several times a day. This is a study that looks at the odds of adherence to medications with their 95% confidence intervals. Those that they are taking once a day are more likely to be, taking than those that they have to take twice a day or even 3 times a day. Right. So moving on, there are a lot of other barriers that we haven't got time to go into detail, but things like hypoglycemia, I'll talk about side effects, quality of life of the patient, hypoglycemia, lack of time, financial restrictions, patient beliefs, insurance claims, and risk to other, patient comorbidities and complex regimes. All of these, play a very complex constellation of reasons on the healthcare professional at the front line in primary care, and for that matter, they will be unlikely to prescribe these medications. The other big issue is inertia. Therapeutic inertia is a huge factor in primary care. What we do in primary care is to start, diagnose a patient and put them on lifestyle modification, and the A1C comes down, but soon afterwards it goes up again, and then you add metformin, the A1C comes down again, and then it goes up again because of dwindling beta function from time after the diagnosis, or indeed because the patient becomes non-adherent, or for whatever reason, the A1C goes up again, and then you add another medication, and so on and so forth. So you get this stepwise approach, or seesaw of fluctuation A1Cs. Now, this is what is contributing to a high risk of cardiovascular disease. Patients who are, taking, medications that bring A1C down and then allow the A1C to go up again are likely to have fluctuation in the A1C, which contributes to high cardiovascular disease. And so the idea is to probably consider keeping the A1C flat from diagnosis and keep it as low as possible for as long as possible. Initially, you get microvascular benefits, and later on, you get the macrovascular benefits. So at the moment, what is happening is sorry, my slides are playing up. Just let me sort these slides up now. Yeah. So at the moment, what is happening is that with a stepwise approach, we have baseline A1C at somewhere around 8% or even more in some cases for a long time. What we need to do is to get primary care colleagues to push this curve all the way down and leave it there for as long as possible. This way we can achieve a flatter, smooth A1C without fluctuations and prevent those complications. And then finally, the biggest, one of the biggest challenge that we have in primary care is that there is no co-production of these guidelines. So this is a study that we published a couple of years ago now, looking at all diabetes articles published and diabetes articles on diabetes, randomized control articles in diabetes published. And then we compare that to all diabetes articles published and diabetes randomized control trials published in primary care. And as you can see from this curve, over the past 20 years, there has been an exponential rise in all the diabetes articles published. And indeed, for diabetes articles in randomized control trials has been rising as well. You compare those two curves to the corresponding curves in primary care, and you can see that over the past 20 years, that has been flat. So investment in primary care research has been lacking behind that of specialist centers. And so you don't have primary care academics getting involved and generating these guidelines. And so the guidelines that are normally generated are not suitable for them. They are not fit for the purpose in primary care. And so they are less likely to adhere to them. So one way, another most effective way of implementing guidelines in primary care is actually to translate these guidelines into clinical pathways. So a few years ago, what we did was we looked at this case of non-adherence to guidelines in primary care setting and labeled it as the enemy of evidence-based medication. And in that publication, we suggested that clinical pathways, which we define as a structure multidisciplinary care plans, which detail essential steps in the care of patients with specific clinical problems, and that they needed to be, based on local structures and systems and timeframes that address the recommendations in the guidelines. And so basically what you're doing is taking the guideline and translating it into local structures and systems and timeframes that will address specific recommendations in those guidelines. And these pathways normally, an example of how this has worked very well is what we have in Leicester. So we have our guidelines in the United Kingdom in managing type 2 diabetes. But over the years, we've known that these guidelines are not implemented locally properly. So what we did in Leicester was got all the stakeholders around the table and decided to reorganize the diabetes pathway in the city in such a way that very complex patients will be taken out of the equation and managed only in specialist centers in the pink box or red box. So these patients will be those with complex type 2 diabetes, complex type 1 diabetes, children, pregnancy, insulin pumps, renal patients, and diabetes feet or inpatients, all these patients under specialist care. Everybody else was managed in primary care. And we do appreciate that in primary care, not all the GPs will be interested in diabetes. Some might have an interest in dermatology or musculoskeletal medicine, and it will be impossible for them to get interested in diabetes and manage patients with diabetes. And so in primary care, we had two groups of practices. Those who were interested in diabetes, who had an enhanced service provided to their patients, and those who were not interested in diabetes and they only provided core service. Now, these practices were supported by diabetes specialists from specialist centers to provide a similar standard care across the whole city. And these practices implemented locally developed pathways based on the guidelines. And as a result of that, we're able to see benefits. The Leicester Diabetes Center is a huge unit with over 150 researchers in one building, sharing our research output and supported by our education team called the EDIN, Effective Diabetes Education Now. The EDIN team is able to develop educational models based on the research output, generated from the Diabetes Center. And with that, we're able to produce the outcomes that we are seeing in the city. To do this, you don't only rely on GPs in primary care. You need your specialist support, you need your podiatrists, you need your pharmacists, you need your healthcare professionals from all walks of life, all around the table to develop these interventions. And it's only when you do this at the same time that you can get benefits in glycemic control. And so in this paper that we published in Diabetes Research and Clinical Practice a few years ago, we're able to demonstrate that multifaceted professional interventions were more effective than single interventions targeting single primary care or community care professionals in improving glycemic control. And so I conclude by putting it in this table. So you have your patients with diabetes in the middle, the general practitioner, the diabetes specialist, the pharmacist, healthcare assistants, all of these primary care specialists work around the patient, to determine the patient's goals and then support the patient to achieve those goals. And of course, these primary care teams were supported by their specialist colleagues, the nephrologists, the diabetologists, psychologists, podiatrists, and the cardiologists. So in conclusion, diabetes is now mainly managed in primary care, and there is a huge efficacy gap. And that can be addressed through tackling multimorbidity, adherence, avoiding inertia, and enhancing research in primary care. Thank you very much.
Thank you very much, Dr. Samuel, for that very lucid presentation and highlighting the very important points about the lack of guidelines adherence by the general practitioner. And you rightly said about the importance of taking care of the primary care, who are basically managing lots of diabetes patients. And the very few publications for the primary care was one of the highlighting point that you really drove at. So thank you very much for your lucid presentation. And I think we can go to the next one, please. Do we have the, I think it's all pre-recorded, Dr. Rutul? Next is Dr. Kose. Do we have the introduction, a CV on Dr. Kose?
Technical team, please load the CV of second speaker.
Dr. Francesc Kose. Pratap, as I understand, these are all three pre-recorded sessions.
Yes.
Arshit, please upload the CV. Arshit.
Who is from technical team there?
Yes, sir. Just a second.
Yes.
Okay, no problem.
It's okay. Take your time. I must compliment Bansi, especially because the primary care is not something which we really discuss. In fact, that is one of the most important things. If you really want to come to the target of many patients achieving A1C less than 7%. So this is really, it's a very, very important point that we are being driven at. And this is also something which we as clinicians and consultants should really understand and play our own role, So
thank you for inviting me to provide this lecture at Diabetes India.
Okay, so the next speaker is Dr. Francesc Kose. He's from Spain. He's a director of Center RT Primary Health Center, Barcelona, and he's a member of the Primary Care Diabetes Research Network. And he's going to talk on integrating precision medicine into primary diabetes care, a new paradigm of the known concept. Dr. Kose, please.
Technical team, please start video now.
Yes, sir. Yes.
Pre-recorded. Yes.
Yes, sir.
This India conference. My name is Xavier Cos. I'm a primary care physician working in the city of Barcelona, and I'm also working part-time as an innovation officer in the Catalonian Health Institute. Also, I'm the chairman of Primary Care Diabetes Europe. Today, my talk initially would like to share with you about precise medicine and diabetes and primary care. I explore the domain, I explore the topic, and to be honest, there's not so much information relevant that could be, in my opinion, from the primary care perspective, something it could be like providing added value till the amount of information we have at the moment. I think cancer and other disciplines are where probably the precision medicine is more advanced. But that not means that in the diabetes field, ESD, ADA already provide a position statement on precision medicine, and we are going to hear about this discipline a lot in the next coming years. Probably adjusting what is the more appropriate strategy and medication for each situation. For this reason, I decide probably moving from integrated precise medicine to integrating personalized medicine, integrated care into primary care diabetes, a new paradigm of a known concept. And I think this new paradigm, it comes through the times we are living at the moment. We are under this pandemic, and this makes and twist and remove and earthquake all the healthcare arena. For this reason, I want to share with you what I would like to introduce in the next minutes, and is this agenda. I think that the concept of primary care, personalized, and diabetes is something that is really collapse everything together. And I think due is very important because primary healthcare professionals are really connected with patients and citizens, but of course that requires action. And this is the action I try to share with you in the next minutes. I think this is my outline, and I think COVID-19 pandemic impacted to diabetes management. I'm going to show you from Catalonian data that is already at the moment not published, and that it provides details about how we are providing care in that times. Also, it's clear that primary care systems are under a stress test, and also try to provide my comments on that. Also about the individualized and personalized care in diabetes, the new ways for medical encounters, new formulas that are already providing some evidence, and we have probably to introduce in the appropriate manner that could be probably adjustable and acceptable for citizens, for those persons living with a chronic disease as diabetes, and of course for healthcare providers and professionals. Also telemedicine as one of these areas that I think it will be really important and has been boosted these past months due to the difficulties we had with the face-to-face encounters during the pandemic times, and also some ideas about the future. So I think that, first of all, I want to introduce some data about the COVID-19 and the pandemic. I know that in the next lecture, my colleague, Professor Kamlesh Kunti, is going to provide a good summary and a good overview about this data, but I would like to take this opportunity to share with you data from the group I'm working here in Catalonia that is involving this number of centers. And in that publication released last year, we would like to share what has been the impact of COVID-19 on the control of quality measurements in our citizens that we are controlling in our centers. I would like to share with you the data related to some aspects related to diabetes management. Here, blood pressure, you can see A1C, screening for diabetic foot, and also retinopathy screening. You see in these different two lines, the 2019 data and the 2020. And you see this decrease from the beginning of the pandemic, and that it has been really complex to recover over the year 2020. Also, this is the number of face-to-face encounters and what is the actual situation at the moment. We move from 60 mean daily weekly contacts with healthcare professionals for each healthcare professional to 16 face-to-face encounters in this line. You see from April and almost that last till the middle of September, October. But you see that at the moment, now we are far from the 60 face-to-face contacts we had before the pandemic time. So of course, it's a big change. And also we see here in that perspective, and you see here the results provided during that times, you see the dramatic decrease in terms of the standards of quality, this EQA. You can see the decrease of the standards of quality that of course are related to this small and reduction in terms of face-to-face contacts that provides that consequences in terms of follow-up. Also, I think it's important to know that in terms of type 2 diabetes management, and as we see data till this year, 2021, we see that we start observing some recovering in January and February in terms of indicators of those persons on hemoglobin A1C below 8, and also diabetic foot examination also have a trend of recovery. Some data that is not shown here, but it's also now into analysis is, of course, what is the impact of providing face-to-face contacts or not to our citizens in our area. And we are observing differences because there's not same rhythm of offering that kind of contacts to all the around 250 centers in Catalonia. And we are starting observing that those centers that are trying to maintain or try to recover the rhythm of face-to-face contacts have better results compared to those ones that are remaining on a more virtual or hybrid manner. Okay, so let's move to the second point I would like to share with you. And that's clear that this pandemic has been an important stress test for the healthcare system. Here in Spain, we are working together in the primary care, a GP, together with a nurse as a team, and we are responsible to coach persons living and also those that are attending primary care. Also, we see that in primary care is a big team with other professionals that are also working together. But besides this, we have also the potential possibility to contact with other specialists we have around us in a shared care manner: cardiologists, internal medicine, ophthalmologists, endocrinologists, nephrologists. And that is according to a model of achieving an integration of care. And I think this is a really good approach. But this pandemic time also illustrates that this normal kind of contacts we have normally with our specialists at hospital level has been not possible due to the barriers or to the difficulties during the pandemic time. And also that involves a lot of problems during that time. Of course, it was a limited and poor accessibility for care systems in terms of patient. Also, it was a fear for COVID-19, and their patients decides not to attend to and not to come to the centers. It was a loss of follow-up in regular visits, and also a lot of adherence to lifestyle and some of the medication. And this is also aspects that we've been observing thanks to the big data analysis. Of course, if we move to the individualized care, I think it's important, and this probably it makes and have now play a big relevance. If we have available some tools, some indicators that allow those healthcare professionals probably to stratify those individuals that have most benefit in terms of having or prioritizing a face-to-face contact or some kind of context or intensifying context. And I think that different projects like this one that has been published last year from the UK, it tries to show that thanks to the electronic health records, we can stratify the severity of type 2 diabetic persons, and that allow us to probably have an attitude, a different attitude according to that risk. And this is, I think, a better approach. We can going to provide those intensity or those more strong and more qualified force and to those subjects, to those persons and citizens that require more attention according to their risk. Also, this is also illustrated in that project that has been run in Canada, where also that it shows that risk stratification in primary care also provides an importance, and I think here also illustrates and have resonance that it has been also before published in the UK, here in other countries also are trying to study and to implement risk stratification strategies in the primary care setting. Here in Catalonia, we have we had these two different systems, one coming from the C3M company, where provide a kind of clusters that it depends of the cluster where the patient was located, the intensity of care or how we have to probably to consider the approach for those persons was one or other. And also now we have a new classification, GMA, that tries also to stratify persons. And as you see here in the pyramid, according to the different levels we have in that stratification, it's probably a model suggested in terms to approach and to invite persons for different kind of context. So I think that is important in terms how we are organizing our healthcare centers in terms to provide the adjusted quality and kind of contact according to the complexity we have to face. But of course, that also requires new ways of medical encounters. We are moving from an era where we were in a face-to-face contact, visiting our healthcare professionals, nurses, GPs, and we've been forced to a new ways of contact. So we moved to these office contacts of home contacts to a virtual context, telephone contacts, video calls, emails, text messages, and also in some cases, the use of applications. Of course, there's some evidence that is supporting these different perspectives. Here is a project where it tries to study the benefit of a mobile phone-based interventions, and it was done in this project because it's trying to investigate about prescribing primary prevention on cardiovascular disease adults. And I think this other project also tries to explore what is the profile of an owner of a mobile according to also the applications they have, and then also allow us to understand if maybe all citizens, and when this project was published in 2019, probably are capable to be considering these different schemes. And here, as you see here, you can observe that, of course, in hypertensive persons and non-hypertensive patients is a difference. And you see that in non-hypertensive persons, it was a higher use of these devices. But of course, when you move to categories, in terms of age categories, it's clear that according to an older categories, the use of these technologies, of these digital technologies are poorer, are lower. So that it means that when we are considering to prescribe some kind of contacts or encounters or applications, we have to take into account how familiar is those person we have in front of us with that technology, and if this person is going to be adherent and connected and feel comfortable with that kind of interface. So of course,
although, and this is the remark from that project published in 2019, that there's an increasing number of persons using smartphones, tablets, etc., etc. When we try to test this in hypertensive and non-hypertensive patients, we observe that, of course, there's an area of improvement, an area to take into account that age is still playing an important role in terms that also that is important to consider when we are probably considering to recommend or to prescribe that kind of solutions. Also, in terms of the use of mobile health technology and management in diabetes, and I think these also we have here in that publication, what could be the different technologies and the approaches in terms of prevention and management using mobile health technology, wearables, applications, smartphones. And this document tried to illustrate on that way. Also, I think these new ways of medical encounters are really important to consider. The idea that probably at the moment is little known about what is the effectiveness. We have different projects, many observational trials, but in terms of randomized controlled trials, and probably comparing with a face-to-face, what is the effectiveness of the mHealth modalities is probably an area that is going to be an emerging number of publications on that perspective. Also, for this thing, we need good quality design, randomized controlled trial designs, large samples, also study cohorts that allow us to have this robust evidence, that allow us to probably have a strong position in terms of what we are recommending, and not just by tradition or by because we have like we wish that this kind of context could be beneficial. So it's clear that more work is needed to try to identify what is the real role of the mHealth nowadays. So I think that according to these ways of new medical encounters, probably it's important to know that there are different aspects that must to be considered as a potential barriers, and some of them could be the cost, could be that digital gap in some ages, also the sustainability, also probably if the healthcare systems are prepared to prescribe, healthcare professionals are prepared to prescribe these things because they are familiar and they know how to integrate that technology or that new ways of encounters in their clinics. And also, of course, that requires that in the future, diabetes probably should also not just also being focused on medication. Also, I think in other areas that in this digital side that help us in terms of adhering and of course to medication and adhering to lifestyle modifications. And I think that probably that devices, there are also some evidence that are supporting that these devices could be helpful in terms to coach those persons to be more adherent to that attitudes. So what's the role then of telemedicine in diabetes in COVID times? And I think that, and this is two publications from my country, and probably I know that others in other countries that try to put on the arena and available to the community documents that help healthcare professionals in the primary care setting how to understand, how to manage, or how to prioritize patients in that new ways of context. And I know that later on, Professor Kunti also is going to provide more details about the stratification and about this kind of context. And I think this is an example, and sorry, that's in Spanish, that allow to understand that every period of time, it's important to know some specific actions must to be done. And I think that this is also repeated in this other document, but I think that the summary is, besides there are Spanish documents, there are also in the international arena other documents at the ADA, also in Diabetes Canada, also in the Desmond. They develop a new app, a new virtual helpful tool called My Desmond that helps diabetic persons to be connected with a good advice, a good education that is complementary of what has been known in the past from that program, Latikis Desmond in the UK. So what's the future then? What's the future? And I think the future is we have new tools. We have now reasons probably to shake how we are providing care in primary care to diabetic persons. And probably one key aspect is, although we have these things available and some of them still require for probably more evidence behind, but we have to move for actions and to implement, not just providing guidelines, position statements, etc. We need to go for actions. And this document that is already probably a known document published 7 years ago, try to emphasize that when whatever action you want to implement is just not being targeted at one specific level. It's a multi-level approach, and that it works for any kind of intervention you want to perform. But in that case, we have to be introducing new ways of contact, new technologies, new aspects. I think politicians, community factors, institutional factors, how we are providing care in our clinic is not the same to be providing a face-to-face contact that a virtual contact, telephone contact, email contact. So all of these, what we can, the style of each kind of contact is very important. So all the different actors, stakeholders in the ecosystem must to be familiar how to be more trained, more fit on this kind of new strategies. So, and here we have also in that scheme, in terms of quality results and number of centers, and see how this could be understood in terms that time to time we have to be referring that this scheme is showing now what has been the quality of care provided and what is the scheme. For example, in that cases, in the green bars is showing face-to-face contacts. In the red bars is showing the percentage in that centers on emergency contacts facilities. So it means those centers that have more face-to-face contacts, continuity of care with their own patients, and try to reduce the number of consultations, emergency consultations in their practices, tries to provide a more direct contact to their own patients. That, seen from Catalonian perspective, it shows a benefit in terms of what is shown in the acts. It was the quality of care. So as much as quality, and this is divided in peptides, so in 7 categories. So that bars that are more to your left are showing that as much higher is the green line, is better quality of care, and it is connected with a face-to-face contact with your own GP or your own diabetic nurse or your own healthcare professional. Of course, as I said you before, more work must to be done, but we have here that telemedicine is a responsibility, and that it's overcoming now. Many trials are now ongoing, and I think this is something we have to wait for results from that. So as a summary of my presentation, I think it's important the impact of COVID-19 in primary care. That of course that requires that we have to move to a more personalized approach in diabetes management. Of course, this idea of precise medicine is also in the cloud, that probably in the future also is going to have a strong impact in diabetes in primary care. And also these new ways of contact and new ways of encounters. And of course, the telemedicine plays a key role, and also in these COVID times, and of course in the future. But we have to be that healthcare professionals must be under review of how we are providing care. And of course, that is requiring for more evidence, and the trials that now are ongoing in telemedicine and other areas are going to provide that information in the future. Thank you very much for your attention.
Thank you very much, Dr. Coase. It was a very lucid presentation. Really, you highlighted the paradigm shift, and the sentence which you say that virtual care is integral to the future diabetes management, and you cannot agree more on that. the telemedicine is a new way to go, and especially in this pandemic, all of us have realized the power of telemedicine. And so I think the paradigm is getting shifted, not just in the Western world, but in India as well. So you really highlighted all very good points, and I'm sure that this is what we are going to see, the new normal, as I would say, the virtual context. So thank you once again for a very, very lucid presentation. And now we can go to the third speaker, please. The next speaker is a very well-known Dr. Kamlesh Khunti from UK. Well, he's a professor of primary care, diabetes and vascular medicine at the University of Leicester, UK. He's a co-director of Leicester Diabetes Centre. His work has influenced national and international guidelines on screening and management of people with diabetes. He's also director of UK National Institute of Health Research, Collaboration for Leadership in Applied Health Research and Care East Midlands, and director of the Real World Evidence Unit. He's also NIHR senior investigator and principal investigator on several major national and international studies. He has published more than 500 articles. So we have a Dr. Khunti of great eminence, and he's the right person to talk to us on a global burden of hypoglycemia.
Hello, thank you for this invitation to Diabetes India. As usual, as you know, I love coming to these meetings. However, unfortunately, in view of the pandemic, I'm sorry I cannot be with you. Today, I've been asked to give a presentation on primary care for people with type 2 diabetes in the COVID-19 pandemic era. These are my disclosures. As you can imagine, there's a lot to go through, so I will touch on some of these topics over the next 20-minute or so presentation. In terms of the background, this is a really nice review if you haven't read it. COVID-19 and diabetes, a collision of two diseases, the perfect storm. So on the left-hand side, we see the pathophysiological mechanisms in COVID-19, the acute cytokine storm with inflammatory response, acute tissue damage with AKI and cardiac injury, hypoglycemic surges, hypercoagulability, endothelial dysfunction and fibrosis. On the right-hand side, the same mechanisms for diabetes, but in this case, we have chronic low-grade inflammatory response and insulin resistance. Certainly when these two together, they do make a perfect storm. In terms of the epidemiology, this is early work using the biobank data from Yogini in our group. We looked at the most commonly occurring chronic diseases and multimorbidity who tested positive for COVID. As you can see, diabetes is probably the most prevalent condition with hypertension and diabetes, the two commonest chronic comorbidities. We early on conducted this meta-analysis of 18 studies with over 14,000 individuals. This is with AK Singh in India. And what we see is that there are certain comorbidities that coexist in people who are admitted with COVID-19. So about 23% had hypertension, 11.5% diabetes, and about 10% cardiovascular disease. Some studies have recently shown, including ours, that up to 30% of people admitted to hospital with COVID-19 have diabetes. We also looked at the estimated pool risk ratios for getting severe COVID-19. This was hospitalization, intensive care unit admission, and mortality. As you can see, with hypertension, diabetes, cardiovascular disease, COPD, and chronic kidney disease, there are increased association with these severe outcomes, ranging from a 66% increase to a 4-fold increase in people with CKD. This is also data we looked at 61 million people, the whole of England database, and that's one thing we're very fortunate with in the UK, that we have really good databases. So we looked at association between diabetes and COVID-19 related hospital death rates. So first of all, in people with type 1 diabetes, this is associated with about a 3-fold increased risk of in-hospital death compared to those without diabetes. And in people with type 2 diabetes, there's about a 2-fold increased risk of in-hospital death compared to those without diabetes. As you can see on the left-hand side, the risk seems to increase exponentially from the age of around 50, with people over the age of 70 having very, very high rates. In a linked study, we looked at everyone in the UK with diabetes. This is about 98% of the population in England with diabetes. So at the top, we see about 264,000 people with type 2 diabetes. At the bottom, 2.8 million people with type 2 diabetes. And we looked at the association of risk of severe COVID, and this was COVID-related mortality. And we see that the risk increases above an HbA1c of 86 millimoles per mole for people with type 1 diabetes, but the risks seem to increase at a lower HbA1c of above around 7.5% for type 2 diabetes, and the risks are much higher with higher HbA1cs. In terms of the guidelines and recommendations, there have been a number of guidelines that have been published, especially early on in the pandemic. This was one of them that I was fortunate enough to be involved with. And here we looked at all the therapies and gave recommendations what should be done in people who are being managed during the pandemic, and also people who are admitted with COVID-19. And you'll see some of these recommendations are pretty straightforward, and many recommendations repeated these, such as caution with premature discontinuation of established therapies that we're using in clinical practice, stopping SGLT2 inhibitors and metformin in people with COVID who are admitted to hospital because of the various risks associated, such as dehydration, lactic acidosis, and DKA. In terms of therapies in COVID-19, really early on, this was one of the best reviews that was published by Dan Drucker of diabetes therapies in COVID-19, going through each therapy in detail about the potential mechanism by which they may cause either harms or advantages in people with diabetes. There's been consistent results with metformin with a lower association with mortality risk. This is a meta-analysis of 5 studies with 8,000 patients showing that metformin, pre-admission metformin, is associated with a 38% relative risk reduction in mortality risk. This is the largest database study. We published this about a month ago using our 2.8 million patient database of people with type 2 diabetes. And in this study, we looked at all the therapies, as you can see on the left-hand side, compared to those who weren't on those therapies. And first of all, the thing to note is the rates difference between the therapies is very, very small. So you see some therapies, for example, DPP-4 inhibitors showing a 7% increased hazards for COVID-19 mortality, but the difference in absolute rates is very small, 8.5 per thousand to 9.1 per thousand. The rates for insulin are much higher, 42% increased association, but again, this has been well known with any epidemiological study. We've seen that people on insulin always have worse outcomes because they have more chronic diseases, they've had longer duration of diabetes, and they have many other micro and microvascular complications. As you can see, rates for metformin in this study also showing lower rates and lower hazards. SGLT2 inhibitor and sulfonylureas slightly lower hazards. But overall, our conclusions from this study were that there is no need to change therapy during the pandemic. Most of these differences are because of the confounding by indication in terms of how we prescribe these therapies. For example, DPP-4 inhibitors will prescribe them in the elderly, frail populations, and we didn't have a measure for frailty in this study. We looked at associations. We stratified by age, previous cardiovascular disease, and EGFR for insulin and metformin. As you can see, there's still consistent results for increased hazards with insulin and reduced hazards with metformin. The only way you can tell whether a therapy is beneficial or harmful in people who get COVID is by randomized controlled trials. And these are some of the ongoing randomized controlled trials with the well-known therapies. The SGLT2 one that you see there with dapagliflozin, the DARE-19 trial, has already given top-line results, which showed that there was no, they did not meet the primary outcome, although there didn't seem to be any harms. And we're awaiting the full trial results to be reported soon. In terms of the future management of people with diabetes, this is where I'd like to spend a bit more time. First of all, disruptions in care. This is a really nice thesis. I couldn't find a publication as a paper from this, just as a thesis of effect of natural disasters. And this was based on natural disasters of earthquakes, cyclones, extreme temperatures, hurricanes, tsunamis, volcanoes. And what we are facing is an obvious natural disaster. And when one has a natural disasters, there are institutional disruptions and individual disruptions. The institutional disruptions are services, staff, medications, equipment, networks. And the individuals, there's temporary shelters. People are having problems with payments for their treatments, etc. This means that treatment is interrupted. The diabetes and other chronic diseases are compromised in terms of their management. And so you lead to exacerbations of their condition with worse outcomes. So initially you get worse control of glycemic control and risk factors such as blood pressure and lipid management. And then in the medium term, you do get the nephropathy, diabetic ketoacidosis, and possibly mortality. There have been good publications from other natural disasters, such as Hurricane Katrina, showing the impact of natural disasters on risk factor management, and then obviously outcomes as well. So this is what we have in a public health crisis, both the direct and indirect effects, as I mentioned. There's the indirect effects of the emotional and behavioral changes that occur in people with diabetes because of the psychosocial impact, high levels of anxiety, high levels of depression. This obviously affects physical activity, the diet people are having, affects adherence as well. There's reduced access to diabetes care and management, as we've seen as well. All of this worsening adherence on the right-hand top, as you can see, which then will lead to worse outcomes at the top left-hand. Jamie Hartman-Boyce and many of us came with early recommendations about contacting and healthcare professionals in the community and self-management programs. And we early on said we should be using telehealthcare, and this has been used in every country. We also recommended that face-to-face urgent consultation should occur for certain conditions such as ophthalmology. On the right-hand side, real emphasis on community-based educational programs supporting the stress and diabetes-related distress and mental health issues as well. Also encouraging physical activity and taking to the isolation constraints. This is again Yogini. She did a global survey of which chronic diseases and comorbidities have been impaired the most. This was a healthcare professional survey. As you can see, left-hand side, diabetes seems to be the one condition that has been impacted the most in terms of reductions in care globally. On the right-hand side, diabetes and hypertension, the two commonest occurring conditions, which I showed you early, are also where the disruptions have affected the most. This is data from the UK, a large database study looking at the reductions in consultations for certain conditions. I'm just showing you two here, one on the left-hand side showing diabetes emergencies, on the right-hand side, depression. And as you can see in the blue lines are the averages for 2017 to 19 pre-pandemic, and on the red, the averages for 2020 during the pandemic. As you can see, huge reductions in consultations for diabetic emergencies and depression. I haven't shown you all the data, but all of these are going to lead to worse outcomes because patients aren't coming forward for management of their diabetes emergency. They're not coming management for their depressions and other chronic diseases as well. And so there's been disruptions with reductions in HbA1c testing, reductions in risk factor control. And we're seeing already in clinics that HbA1cs have increased because we haven't seen many of these patients, or even when we've called them in, they haven't come in because they're shielding or afraid to come out. But previous pre-pandemic studies on the left-hand side, our study of inertia, just a 1-year delay in getting HbA1c to target is associated with increased myocardial infarction, heart failure, stroke, and composite cardiovascular events. On the right-hand side, you see the short delays in HbA1c control lead to nephropathy, neuropathy, and retinopathy risk. And there's also data showing that even short delays lead to mortality risk by inertia and not getting to target. So there's been a lot of recommendations. What should we be doing? Well, the recommendations are, now that we are coming out of the pandemic, or even during pandemic, we should be red flagging our patients. This is one method of risk stratification from Primary Care Diabetes Society in the UK. And here they've opted for a traffic light system, red, amber, or green. People who red should be seen urgently within 3 months. People amber should be seen priority within 6 months, and the green could be seen routinely within 12 months. But as you can see, these are pretty straightforward. HbA1c is very high, above 86 millimoles per mole. Should be seen urgently in terms of blood pressure, high blood pressure, if people have diabetes complications, retinopathy, foot disease, CKD, people with cardiovascular disease, heart failure, and stroke, high BMI above 40. These are all red flags, and they should be seen early within 3 months. But if people have a number of amber flags, 2 or 3 amber flags, then these should be moved to a red category. This is just one example. There are a number of others that are available globally. Whatever is available, one should be using that to risk stratify and see these people early, and not to wait so long with long delays in risk factor management. There's a lot of interest in new onset diabetes, a number of publications coming out on this. Our group and many others are looking at this at the moment. This is a systematic review just published recently, looking at people who were admitted to hospital, and they estimated that the proportion of people with newly diagnosed patients with COVID-19 is about 14%, which seems relatively high. Now, new diagnosis of diabetes during acute illness is not new. We've seen that previously in other infectious during, for example, MERS and SARS-CoV-1. We've also seen them in acute admissions with myocardial infarctions, really good data, as you all know. But whether there is a new phenomenon with COVID-19, we're not sure. Some of the hypotheses that are being looked at is whether SARS-CoV-2 attacks the ACE2 receptor, where it binds in the pancreatic cells and potentially destroying the beta cells. But we are awaiting some of these studies. This is a study we conducted looking at over 40,000 people hospitalized with COVID with matched controls. These were patients who were then discharged. So we have a number of patients who obviously die in hospital, which varies from anything from 10 to 30%. But from those who were discharged alive, at 138 40 days follow-up, about 30% were readmitted and 12% had died. If you look at on the left-hand side, the readmission rates, higher rates compared to the control population for new diabetes, major cardiovascular event outcomes, CKD, and chronic liver disease. So these people are getting a number of chronic diseases, but this is particularly seems to be in people who've been admitted to hospital, less data on people who've been managed in the community. New diabetes, as I said, is a very interesting phenomenon, and Francesco Rubino and many others, even from India, we've set a new diabetes COVID registry. You can see on the right-hand side the website. If you do want to contribute, please do to help us get some more additional data in this interesting phenomenon. Post-COVID syndrome or long COVID is something that's really important, and we will need to take care of as patients come out of hospital or they've had COVID in hospital. And this is a complex phenomenon with a number of potential clusters. And it may not be one disease itself. There are symptoms, for example, anxiety and depression, fatigue, chest pains, cognition has been damaged, affected, but also there's damage to end organs, as I showed you previously, cardiac, renal, pancreatic, liver, and kidney damage. And we will need to see these people more urgently, make sure their risk factors are controlled, and keep monitoring them in the longer term. So in summary, first of all, I haven't shown you data, but we're not sure whether people with diabetes are more likely to get COVID-19. But we do know that COVID-19 is associated with worse outcomes in people with diabetes. There's also association with hyperglycemia and COVID-19 outcomes, particularly for type 2 diabetes. And COVID-19 also contributes to worse diabetes outcomes due to disruptions in care caused by the pandemic. The indirect number of disruptions and deaths is likely to be higher than the direct effect of COVID itself. These are the kind of things that we should be considering even during lockdown. As we come out of lockdown, the inpatient diabetes care should obviously continue. People who need urgent care, foot disease, eye care, acute diabetes care, they should be continuing to be seen. Routine diabetes care, virtually or face-to-face, should continue. Food services and pregnancy services should be continuing. If we haven't seen these patients for a while, we could stratify and do the blood tests and screening such as retinopathy. And we will need to follow these patients up with new onset diabetes and long COVID to see what their outcomes are like, but at the same time also ensure that their risk factors are controlled. We also need to make sure that COVID vaccination is available for people with diabetes and their carers. And I know, and I'm sorry to hear that there is such a shortage of vaccination in India, and I really hope that this will be available for the whole of India soon. Mental health, I think, is really, really important in people with and without COVID. The indirect effects are huge. And this is something that we need to be looking at in people, especially now that we can get remote consultations. And there are a number of apps giving self-management education programs. And we should be ensuring that our patients do get access to these. Thank you very much for listening.
Thank you very much, Dr. Kunti, for a very lucid presentation. And what was the highlight was a very big volume data. And we have heard a lot about what actually we have experienced in the COVID patients, but some of the things were very interesting from the presentation that he gave was the increased mortality with insulin, and metformin patients were actually had less mortality, which came as a big surprise to us. We also liked the risk stratification of amber, red, and green. I think this is one thing which we can also implement in our practice, because that is a good way of making our patients aware. Another interesting part which I felt was a new onset diabetes. It was not that the people who were on steroid and had a temporary hyperglycemia, or people who were pre-diabetic got converted into diabetes. There was a theory that he talked about the pancreatic cells getting involved and the beta cells getting affected, and the patients developing diabetes. I think it's a very, very interesting area. We'll listen more and more. And another point, which of course we knew about the diabetes patients, having problems of having high mortality, but the diabetic patients getting high number of readmission was also something which was a very revealing factor. So Dr. Kunti, it was a very elegant, and I think a lot of things we learned. So all the three speakers did a wonderful job about highlighting what is most important in diabetes management is primary care. And I'm very happy to see Dr. Topserver back. Welcome.
And Dr. Saidu is here, and Dr. Kos is going to be with us in a second.
Okay.
For question and answer.
And we have five minutes more to discuss the question. If we have any question in the chat box, we may address the question, or we can discuss.
Yeah, I think I personally don't see any questions.
Okay.
So is Dr. Samuel there? Okay. Can I ask a question, Dr.
Yes, he
Samuel?
is there. He is there.
Dr. Saidu is here, yes.
Yeah, yeah. You really discussed about a very important point about a very late publication on a primary care in diabetes. So what exactly can we do about it?
So the sort of things that we can do to help primary care adopt guidelines and improve outcomes in diabetes are basically to develop local leadership, because the guidelines as they are normally based on randomized controlled trials and designed for national or international levels. But in each area that you work, there are local circumstances that can prevent you implementing these guidelines the best way you want to. And those hindrances can be things like, structures, availability of resources, human resources, funding, so many other things, including the cost of drugs. So what you need is to get these guidelines and transform them into pathways. And like I said in my presentation, the pathway takes into consideration the local hindrances, the local structures, but you need a local leadership, okay, to get a flow chart so that various aspects of those pathways will address different interventions in the guidelines. And I think if you do it that way, primary care is more likely to adopt these guidelines.
Yeah, I think that's a very, very, very valid point that you said. And one more thing is about the non-adherence. You said 50% in 1 year. I think that number would be very high in India, and we don't have the data. But I was surprised that this number is also very high in the UK as well.
Yes, yes. So 50% for chronic diseases, 50% of who will stop taking their medication before 1 year. I won't be surprised if it's a lot higher in India. And
Sure.
I mean, you can understand why. I mean, if you don't have a chronic illness and you just get an acute illness, like a chest infection or some sort, and they give you antibiotics to take for 1 week, normally after 3 days, if you are feeling better, you stop.
You stop.
Now, if you imagine somebody with diabetes or hypertension who hasn't got symptoms, and then you expect them to take these medications for the rest of their life.
True, very true.
No, it's not surprising. It's
Very
not
true,
surprising.
very true. That's the main reason. You're absolutely right. Absence of symptoms is what is making diabetes management a big challenge. One
So
more
we
question
have
to
Dr.
Dr.
Kos
Kos,
also
please.
here.
I'm
Yeah.
sorry. Yeah, go ahead. Go ahead.
May I ask a question to Dr. Kos?
Please.
Dear Dr. Kos, I have a question about your views for the future in primary care, follow-up of the post-COVID patients in primary care with, new technologies, or what's your view? What are your suggestions?
I think that COVID-19 already is very important in many countries. And I see that COVID-19 makes a big transformation on how we are delivering care. Incorporating digital solutions in our contacts and exploring new ways of contacts is crucial. And I think that it means that healthcare professionals and patients and society must be very aligned and with that needs, and also to be trained how to understand these new ways of contact, because they could be very strange to have visits through an application, or maybe through a telephone or video call or whatever, or email consultation. So I think it's important that everybody consider the importance of these new ways of contacting are arriving, are here, but not just to live, to remain in some point. And we have to make that digestible for everybody. It's not the same when you have in front of you a type 2 diabetic patient and then when you have to call him. For example, I had an experience this week and I have a video call with a patient. When I have the video call with a patient, I can appreciate the verbal communication and the non-verbal communication. I was talking about adherence to lifestyle, and I saw in the video call, I saw the patient. But of course, that if you are going to work adherence, if you want to work something, of course, video call, I think, is preferable than a telephone call, for example. That's clear. But I think these new formulas are going to be incorporated. Also, how devices are informing GPs or healthcare professionals about parameters. We are still we have the Free Libre, we have the CGM technology, we have also blood pressure monitoring with Bluetooth systems. So I think all of this kind of technology is going to be incorporating, avoiding low value contacts. I think we have to move for high value contacts, prioritizing them, and also try to provide that kind of high value contacts to those persons that are more needs to have the contacts, those more complex patients. So we have to elaborate agendas or patient journeys according to their complexity. And I think this is a very important exercise. And many systems already have data that allow to identify who are the more complex patients that require this special attention.
Can I just come in, Dr. Kos here? I just want to ask you a question that the telemedicine was there, but do you think that there is a difference in the acceptance of telemedicine or the use of telemedicine pre versus post-COVID era?
I think yes, because I think, don't you think that COVID as a sociological point of view makes everybody completely aligned in a common objective? Don't you think, for example, as an example, that all the agendas were all together in a hospital, diabetologists, ophthalmologists, everybody thinks we have to work together, and we leave out our personal agendas. So here, the important is how we're going to explain that new momentum to everybody. It's important that this new way of communication is very helpful, is supportive, is a way we can distill a lot of benefits, and we have to avoid low value contacts. It's not, I mean, we have to also, but this must be to be projected with tangible things. Yep. When you are and also we have, I think this is going to be a multi approach for multi stakeholders, citizens, healthcare professionals, authorities, media. Everybody must understand that this is not something that is here for a transient period of time. That's here to change how we are operating, how we are dealing with health. And this is very important, I think. And I think telemedicine, we have to not to provide telemedicine for low value contacts, because that it will be, we are biasing and we are putting telemedicine for low value things and face-to-face for high value. I think when it's a low value contact, it's a contact that maybe we have to avoid. Telemedicine or face-to-face. So we can have amazing high value contacts in a telemedicine approach. So we have to distill what we are doing. That it means also for as a healthcare professional to do an internal exercise, how I'm operating, how I'm dealing my daily clinic, and what I can improve, and also then how I can incorporate telemedicine as a new tool in my communication.
True. Very true. Very true. So I think Rutul, yeah, sorry, go ahead.
If there were Professor Kunti here, I would have loved to ask him what he thinks about the long COVID patients and the approach to that new syndrome in the future, especially in primary care. But as Kamlesh is not around, I would like to ask this to Dr. Seydoux and Dr. Kos.
First, Sam.
You're muted, Sam.
The syndrome of long COVID is going to increase the workload in primary care. I think at the moment we are struggling with chronic diseases, diabetes, hypertension, mental health, Now, with long COVID, first of all, the diagnosis is a bit critical. People are, having COVID symptoms 6 months after the initial diagnosis, and God knows how long it's even going to last. And we don't even have any interventions in place yet. And so all this is going to land on the doorsteps of GPs who haven't got the resources to handle these patients. So I could see more workload coming the way of primary care.
Yes, fully agree with what's said by Sam. I'm doing practice. I see now long COVID patients. There's a lot of long COVID initiatives in research as well. And we still have to clear how to diagnose this disease. And this is an important thing. But what we are seeing in our clinic is a lot of demands according to persons that have this disease. And we don't know how to provide as a solution. There are some off-label actions that some countries or some people is trying to do. So, and I think there are many studies running at the moment. So I think we have to be very updated. I mean, we know that there are a lot of resources allocated in long COVID, okay? But of course, there are many uncertainties. But just as a main thing, that is going to be a workload increase in the primary care setting. And we have to keep the society and also the primary healthcare professionals really well informed about to understand the syndrome and what is at the moment available to provide some solutions or some actions. Also, in some hospitals, there are long COVID units in some hospitals, mainly in the pulmonary clinics. But of course, long COVID is not just for a pulmonary long COVID symptoms. There are others, like in the neurological system and in other ones, in other areas, in other systems. So let's see, but it's a complex thing at the moment.
So we are, thank you very much, everyone. We are already running late. And for the next session, I would like to hand over to Dr. Payal Gupta from Mumbai. And we can discuss this in chat box if anyone is more interested.
Thank you. Thank you, everybody.
Thank you. Bye-bye.
Bye-bye.
Good night. Bye-bye. Bye-bye.
Bye-bye.
Bye.
Hello, good afternoon, everybody. Myself, Dr. Payal Gupta, and we are today going to discuss the Indo-UK Symposium. And it is my great honor and privilege to invite the chairpersons, Dr. Vasant Kumar, who is MD, Senior Consultant Physician, Apollo Hospital, Hyderabad, and current President-elect of RSSDI. And Dr. M.V. Ram Mohan, MD, DM Consultant, Endocrinologist and Diabetologist, Andhra Pradesh. Over to you, sir.
Thank you, Dr. Payal. It's my pleasure to chair this session along with my colleague, Dr. Ram Mohan. This is another important session. Recording in progress. We are naming it Indo-UK Symposium, and we have eminent speakers who are going to address the topics that are allotted. The first speaker would be none other than Dr. Parth Kar, who is well known to us, especially those of us who are in India, although he's in the United Kingdom. We do invite him, and he always obliges us being here with us. As you know, he's a consultant in diabetes and endocrinology at Portsmouth Hospital's NHS Trust of the United Kingdom. And he's with us many times to speak to us on many important topics. He's an eminent researcher and a clinician and has special interest in type 1 diabetes, which he has always been addressing to us many times. May I request Dr. Parth to speak to us on the topic allotted, that is the role of the peer support. Do we need to do more? Thank you.
So thank you very much. First of all, I would probably start by just saying thank you to all of you, as ever, for the kind invite. Thank you for the lovely introduction And of course, no such occasion goes without thanking Banshi for all the effort he puts in for all these such a big events. And as I said to him yesterday, this is all very lovely, but we're really, really hoping to see each other face to face soon, because I think that's what we're all hoping to do. So I will share my screen and hopefully that plan works. And there, so hopefully that can be seen okay.
Yes.
Okay. So I've been asked to talk about peer support. So it's more of a concepts and stuff. And what is peer support? How does it fit in? What are we doing in the UK space? And what should we look at? Because it's Indo-UK Symposium. Some of you know that we are working quite closely together on some of the type 1 diabetes space. Again, thank you to all colleagues who have come forward to help with that. Very much appreciated. So here are some sort of basic concepts that we talk about. And of course, at the end, very happy to take any questions or anything that people might have. So for me, I think type 1 diabetes or type 2 diabetes, or if you think about any chronic disease management, right? You talk about heart failure, rheumatoid arthritis, COPD, anything. They bank on three things. You try and improve people's self-management because they're at home most of the time or looking after themselves, getting on with their lives. The second one is peer support, which is what I'll talk about. And the third one is the tricky one, access to trained professionals, which is even more difficult nowadays with COVID and everything else. So we're always struggling to how do we get the access at the right time? And also the trained professionals bit is quite important, because as some of you, or most of you will know in this call, there are many people who would also claim to be experts in X, Y, and Z. And then you will review their case and go like, well, maybe their training isn't up to that level, which doesn't help the patient. So you have always that sort of discrepancy that you sort of play around with. Now, I always raise this number, and I think this is an important number to bear in mind for us as clinicians. And this is based on a simple mathematics, which is, let's say you take a patient, UC, and you see them, let's say, 4 times a year, okay, in your practice. And every appointment is worth half an hour. And I'm being very generous, knowing the way it works in India, having seen my dad work, etc., and my mum work, I know exactly that it's very not easy to give half an hour per patient. Well, let's just say it's half an hour per patient, and you've had 4 appointments with your patient. So you have actually given them, if you think of it, 2 hours in the whole day to 2 hours in a whole year to them. So 2 hours in a year is actually 0.02% of that person's life. So just think about that. 99.98 or 99% of their life, they're living with their condition all the time, waiting for that appointment to see a professional who is really struggling in present times. So you can see how much of that time is actually spent on their own, which is why the importance of not only self-management, also peer support. So our appointments that we have that with our patient has to be very crucial, that we give them maximal support that we can do in that very tiny portion of their life that we're actually able to see them. And here is some data. I'm sorry the slide doesn't come out clearly, but this is from January 21. And why is it important? Is because look at this, 7.83 billion people in the world. Look at the number of people who use the internet, 4.6 billion. Look at the number of people who use mobile, and look at the number of people who use social media. And what happens, as we all know, how do we keep in touch with our loved ones and friends and everything nowadays? We keep in touch with them with all these means. And people with diabetes or type 1 diabetes or any form of diabetes are no different. That's exactly what people are doing. In the absence of being able to go and catch up with somebody else, they're banking on each other to try and help each other out, because you can't always get hold of the professional due to many, many reasons. Why is that relevant? As I said, patients talk to each other. In the absence of healthcare professionals, need to find other sources of support and information, a lived experience. Of course, if you have type 1 or type 2 diabetes or any other type of diabetes, you're probably in a space where you're a bit more comfortable about, well, actually try this or try that, or no, that doesn't really work with the high dose. So that sort of personal experience is quite useful. And it also helps healthcare professionals, because I think if you're seeing those patients without any support, and then if you flip it around and they've managed to get some support from each other, then your job is also much more easier. And I think having that control not centered around healthcare professional does help. And that's the point I make. And I think there's a lot of worry, understandably, about less worried about wrong information. That's what I would say, is that there is a belief that people pass on wrong information. If any of you do take time to look into some of the work being done around the peer support groups in India at the present moment, then you will see that a lot of these organizations actually give quite good information. They're very keen to work with us as healthcare professionals to make sure that the right information is given out. So it's worthwhile, just to make our lives much more easier as well, is try and work with them so that you ensure that the right information is being passed around, but at least it's being done in peer support groups. And during this time of the pandemic, at least in the UK for sure, and also I've seen in parts of India, you have very clearly seen the people banking on each other quite a lot, people talking to each other, people doing sessions, etc., which have been very, very useful and powerful. Social media. I always give an example of why do I, as a healthcare professional, do a lot of social media. I mean, talk about education, you could talk about interacting with colleagues like yourselves. Information gathering. It's a really good place to gather information. Some may be true, some may be not true, fake news, etc. But, you know, that's part of the information gathering. Bit of fun as well. But I think that's also quite important, interacting with those living with diabetes, because you tend to pick up how they are. And that's why I'm a big believer in peer support. You see the interactions between individuals when they're struggling. It is a massive part of how people coexist. As I said, think about it, 99.99%, they're on their own. So who do they go to? So rather than go to some unknown source on Google, which you're not sure about, you're better off them liaising with each other with the right information behind. Makes your life easier, makes their life easier, something to champion. So pros and cons, it's a tool for good. It also can be a tool for divisiveness when you talk about social media. It's expressive, it's emotional, silos, bubbles. And those of you in India will very well know the impact of social media, some positive, lots of negatives. But people need to accept that not all will get along. And it's appreciation of its strengths and weakness and what it can provide via peer support. So here are some personal views. I think the world is changing at pace, and COVID-19 will have changed the world quite significantly from the virtual contacts people make. We are not the only ones talking to each other by online. People are all the time. As I made the point, lots of people are using phones, internet, you know, and as I said, better to have information which is much more relevant rather than pick up from an unknown source. Social media can be a gateway to peer support, and avoid the trap of making the good a bit better. We're always worried about the perfection. We need to get everything perfect. But I always go back and say, does that mean that we as healthcare professionals get it right all the time with our information or medications? You will all know the present crises, not crises, I wouldn't say crises, the present worry that is there around, let's say, black fungus, etc. And we do know as doctors the impact of inappropriate use of steroids, which has precipitated that to those sort of issues. And there are many diabetologists in this call, and otherwise we're sitting there going like very frustrated at some of the medications that have been used, which have made lives difficult for yourselves because you've had to pick up their care as you've gone along. So professionals need to step up or be left behind, because I can assure you patients do and are talking to each other all the time. And again, that's where our role can be as a guide, not a gatekeeper, not saying that don't do it, by saying if it's happening, let's try and guide people so it's done in the right manner, so that people can bank on each other and you're less worried. And as I said, make your life much more easier as well. I'm going to show you some studies that we have just done, and it's going to come out in a paper. This is what happened from January 2019 till September 2020. Obviously, there's a pandemic time. And look at what happened, and some of the graphs here. This is type 1 diabetes, and have a look about how that big spike is obviously when COVID-19 hit. So when we are in this position whereby we know that diabetes gives you extra risk with COVID-19, it becomes even more important, I think, for all of us to ensure that people have the right information amongst themselves. Because in the absence of getting hold of healthcare professionals, guess what? They are banking on each other. So let's just make sure that we have the right information. And I think there are organizations in, for example, the world of type 1 diabetes, such as Diabesties, Blue Circle. They work with Banshi himself, they work with Dr. Mohan. And it's fantastic to see that collaboration taking things forward, because that's how you try and protect and look after people with diabetes as well. What about type 2 diabetes? Here is something. Diet stayed right at the top of the tree, and it continued throughout the pandemic. What do I do about the most relevant diet in type 2 diabetes? And as you can see, we as doctors talk a lot about medications, etc., etc., etc. But if you look at it, for patients with type 2 diabetes, top of the tree has been diet. So what are we trying to do in the UK setting? What we're trying to say is that every person with diabetes has access to peer support locally or otherwise, and we're going to try and make that happen. We have set up a group of people with type 1 diabetes. We have got the patient charities, which are JDRF and Diabetes UK in our country. And we, from a central position in my national role, we're trying to make sure that wherever you are in the country, if you have a diagnosis, you should be able to access another peer support group, whether it's online, whether it's face-to-face, but you should have that option on the table. That should be part of an offering that healthcare professionals should do. And it goes back to the point I make about the planks of care, self-management, whether it's with better education, better support, better technology, whatever be the case. But I think peer support is really under-recognized and the strengths it can bring. And I think that's very, very important to bear in mind. As I said, Diabetes UK, and there are some huge lessons from the HIV community, which in the 80s and 90s, very, very hugely stigmatized, but how they turned it around, how were the medical community, for example, stigmatized, and how they looked after each other, how they drove research, how they drove policies, and huge, huge benefits over the course of time as to what the HIV community has achieved. So I go back to this slide because I just wanted to, again, re-emphasize the issue around these three things. And I ask everybody who's listening to think about whenever people talk about a drug or a technology, think about how these three things are addressed. That's the way we will try and hopefully get slightly better where we are with diabetes control. Is the intervention you're giving, is it going to make their self-management better? Is it going to have the access to trained professionals better or worse? And I think that's quite important. And that middle bit, the peer support, I once again emphasize, being the guide, trying to stop it from happening is not going to stop it from any way happening. The number of people who go to Google is not insignificant. So why not do it in a much more manner in which you are comfortable, we are comfortable, they are comfortable, guide, help, and try and make sure that peer support is in place. I go back again to the number as a reminder for everybody as to how important the number is, 0.02%. I cannot emphasize this enough. And this is on a very generous amount of time. I have calculated that based on the fact that, we see a patient 4 times a year, 30 minutes each time, that's just 2 hours. 99.98%. I mean, just think of that. And I think I'll probably end, because I'm quite keen to take some questions. I always talk about one thing. If you turn it around and if you had type 1 diabetes and you are doctors, what would you like? I think that's a very important question. I tell you what we would like. We wouldn't be aware of what's the best thing around, right? Because we read and we have connections and we have access to colleagues who are experts in type 1 diabetes. We will know what's the best thing. But what you would also appreciate is somebody else with type 1 and you sit down and you're having a meal or a drink or etc. So for example, the relevance of, let's say you got type 1 diabetes and you haven't been given the education around, what's in the Coke that's been served to you or the Pepsi. And somebody else who's been experienced goes like, hey, listen, you shouldn't probably have that because it's got lots of sugar in it. Try that because it's going to spike your blood sugars up. These are the little things which I think a peer can give so much. And now you could turn around and say, but that's our job too. Of course it is. But we don't have the time on our hands because one thing that the world really, really struggles with is healthcare professionals' time. We don't have enough of them. What are we doing nowadays? We're all trying to poach from each other's countries. And the reason for that is we just do not have enough time. And in that little time we have, a lot of time is spent on trying to find the right drug. You're trying to sort of work around the financial difficulties, what you can do. So try and bank on peer support. Makes your life easier. That's all I can say. And that I will, from my personal experience, I've been a consultant for nearly 14 years, and I cannot emphasize the relevance of peer support, which has helped us so much make our clinical life easier. And I'll finish with one last example about a paper that is coming out. We have assessed every single diabetic ketoacidosis admissions in this country over the pandemic period. And we spent a lot of time trying to encourage peer support in type 1 diabetes. Guess what happened with DKA rates in type 1 diabetes? It actually went down. It's a combination of peer support, lack of going to university, lack of parties, etc., whatever you want to say. A lot of things played its part. Type 2 diabetes, however, went up. And that's because there's a big debate going on about what the impact of the virus is on type 2 diabetes existing where they really accelerates your glucose irregularity and putting you into decay state. So those are some interesting findings. And I think it's not, I wouldn't say causation, it's probably more association, but it's important to bear in mind that the impact it can have. And I finish with this quote because I think different shades of life make the painting more beautiful. So I think we need to move away from the fact that we can solve everything for the person with diabetes. I don't think we can. Not because we are not capable of it, but because we don't have the time. We just don't have the headspace to look after. I mean, and think of every clinic you do. When you finish off, you go home and think, you know what, I could have done better if I had more time. And there's so many people we go home thinking about it simply because we don't. So I'll leave it there, and I will take any questions you might have. Thank you very much again for the invite and everything. An absolute pleasure as ever.
Thank you, Dr. Partha. I think it was a beautiful presentation. I mean, you made many important points which make it easy for a type 1 diabetic kid. Especially about the support from the peers is one thing that quite often we tend to ignore or forget. Even in Indian scenario, if you see, many of us socially, the children don't want to say that they are diabetes, whether they're young children or young adults. So I think that's one of the very important points, apart from many other points that you have mentioned.
I think you make an absolutely important point, which I didn't touch upon, that's stigma. People are more comfortable talking to somebody else. And you can see they can open up, they can talk without the fear of stigma. I mean, we have been through this right now in India with people saying, they can cure it with yoga and stuff. You can see the stigma associated with it, and that's a problem. So if you put a child with type 1 diabetes, you can imagine the freedom they have in talking to another child and going like, okay. So, that's a very different space. And I think we should encourage more and more of that, I would say.
Thank you. Dr. Rammohan, you want to add anything?
Yeah, absolutely.
Dr. Partha, I have a question.
Yeah, please carry on.
Yeah, so this is Dr. Meena Chabra from Delhi. So we started a peer picnic sort of a thing, which was me, Dr. Anju Virmani, and Dr. Ganesh. But it was not successful because in India, your clothes, your food, everything reflects on who you are.
Yeah.
So we had 3 groups of patients. So mine were the educated middle class, and then you had the extremely rich patients from Apollo Hospital, and you had the very poor. So when we had, we saw how they injected, how they disposed of their sharps. We saw everything. They were happy. Yeah. But when we said, okay, now let's all open up our tiffin boxes and have lunch, those who were poor refused.
100%. 100%.
Yeah, peer is important and group medical practice, but beyond a point, I think social and economic status, we have to be sensitive.
Couldn't agree more. Could not agree more. I think we have a very similar. So there is a belief. A lot of people believe in India that in UK everybody's well off, and no, it's not. So you go to. We have the same cultural and class divides in the UK. I can assure you that, right? And you can see that it's a world phenomena. And I think, we can talk about big society changes, but I think that's where our role sits, because we'll recognize that. And we can say, so if we create a support group, what can we do so it doesn't fall apart, right? So what can we do to get the right kids together and mingle and mix so that they can benefit from that experience? And you don't get into a situation where you're uncomfortable and you don't want to talk to somebody because, as you said, you come from a much more poorer background. You don't want to open your tiffin box and show them what you're about to eat while somebody has got, X, Y, and you're thinking, nahi, humko nahi kholna hai tiffin box. I just don't want to show them what I'm having. So that is so important and such a relevant point. And I think we ignore these things. And I think those are the little things that make a difference, massive difference to us. And I think I was talking to somebody else recently who wants to do a session with me on diet. And she's saying, but what we need to do is eat less. And I said, you are from Calcutta. I'm from Calcutta. I can tell you that eating less habit, you first of all need to change a cultural thing. So if I go to the Durga Pujas and I say I'm not going to eat sweets, that's basically disrespect to your elders. So you have to change that level. So whether they feel comfortable. So there's lots of things to sort of wrap around it, I say. So no, I agree. I completely.
Thank you, Dr. Partha.
Absolutely, Dr. Partha. It was a very nice informational session. Thank you so much.
Can you take over the next session, Saramon?
Yeah, yes. Yeah, now I'll welcome Dr. Richard Holt. He is the Chief Scientific Officer for EASD, Editor-in-Chief General Diabetic Medicine, immediate past chair, Diabetes UK Council of Health Professionals, Professor in Diabetes and Endocrinology within Medicine at University of Southampton. He'll be talking about improving mental well-being of people with diabetes. Richard Holt, I welcome you to Diabetes India 2021. It was indeed a very important session because most of the patients with type 2 diabetes or type 1 diabetes have so many mental disabilities or difficulties in their life. To have financial, to have social, to have family well-being is most important in type 2 diabetic patients. Richard, take the session forward.
Dr. Mohan, thank you very much for that very kind introduction and also for the invitation to take part in Diabetes India. I think I would echo what Partha said earlier on, that it would be absolutely lovely if we'd been able to join you face to face to meet in person, but I guess we're all getting very much used to living in this virtual world. I'm afraid I am going to have to just correct you before I start. I'm not, in fact, the Chief Scientific Officer of the ASD. Sadly, that post had to be put on hold as a result of the COVID pandemic. But you never know. Perhaps in a future meeting, I will be able to take that particular title. I am, however, chairing a group for the ADA and ESD around a consensus report for type 1 diabetes. We know that the type 2 diabetes consensus report has been highly influential, and we are in the process of creating a type 1 diabetes consensus report, and the draft of that will be presented at the ADA in a couple of weeks' time. So anyway, I ought to get on to the business of today and talk about the topic that I've been asked to talk about. So I will share my screen. Absolutely. And hope that you can all see the slides. So we'll make a start. So ladies and gentlemen, I think as you have heard from Dr. Mohan, this is a particularly important topic to think about the mental well-being of people with diabetes. And I think you will also have heard through the course of some of the previous talks this morning about how the COVID pandemic has affected the mental health as well as the physical health of people with diabetes. And so I think this talk is particularly pertinent, although in the interest of time, I'm not going to be talking specifically about the impacts of COVID on mental health, although we could also do that during the question time. My conflicts of interest are shown at the bottom of this slide. So what I'm going to do over the 20 minutes really is to consider what's missing in the care that we currently provide for people with diabetes, and to think about the ways in which we might improve mental well-being. And then I'm going to discuss very briefly the breadth of mental health issues that affect people with diabetes. And given that there is only 20 minutes for the talk, I cannot cover all of those topics. And so I'm just going to use depression as an exemplar about how there is this interaction between diabetes and mental health, and why it's important for us as healthcare professionals working with diabetes to consider that this is really important. Then in the latter part of the talk, I'm going to give you some take-home clinical messages about the ways in which we might be able to put some of this into practice. And then finally, I'm going to just move beyond mental illness and think about improving well-being rather than just taking away mental illness. So, ladies and gentlemen, I think we would all agree that over the last 20 years or so, we've had a revolution in the treatment of diabetes. We've had many new therapies, whether those be new oral therapies, whether they be new injectable therapies, whether they be changes in technology through things like continuous glucose monitoring and better devices for administering insulin and GLP-1 receptor agonists. And of course, our august bodies have taken into account all of this development and provided us with guidelines about how we should be using these treatments most effectively. And it is probably true to say that we've also devoted more resources to managing diabetes than we have perhaps in the past. And so we would expect that as a result of all of this treatment change and all of these developments, that people with diabetes would be experiencing a much better quality of life than they may have done 20 or 30 years ago. And yet, despite that, we see that diabetes still has a very negative impact on many aspects of lives. Now, this study was undertaken some 8 years ago now, but it was a global study that included both the UK and also India, where people with diabetes were asked about how diabetes affected their health. And you can see that it isn't just an impact on their physical health, it also impacts their emotional well-being as well, with half of the participants reporting a negative effect on emotional well-being. And you can also see that it has effects beyond that into the social lives of those individuals, whether it be through changes in finances, ability to work, ability to undertake leisure activities, and also ability to form meaningful and stable long-term relationships. So you can see that diabetes is having this effect much more broadly than just on physical health. By the by, I should also probably say that this survey also asked people, family members of adults with diabetes, and also found very similar effects, that diabetes was having a negative impact on their quality of life as well as their relatives with diabetes. We also see that there are many people with diabetes who are not able to achieve the glucose levels that we need in order to prevent the long-term complications of diabetes. And here we have data from the UK National Diabetes Audit, actually suggesting that the proportion of people who are achieving an HbA1c of less than 7.5% really hasn't shifted very much for either people with type 1 or type 2 diabetes. So I think we really have to ask ourselves the question, what is it that we are missing that means that we're not translating these advances in therapy into better quality of life for our patients? And I think that you would probably expect from the title of the talk that I think that one of the reasons why we're not being able to translate this into better outcomes, or at least not significantly better outcomes, is that we are not taking enough impact of enough of notice of the psychosocial effects of diabetes. So I mentioned that there are many conditions where there is an association between diabetes and mental health. And these spread across a variety, from things like psychiatric illness, where we know that things like depression and anxiety are more common among people with diabetes, but also more severe psychiatric illnesses such as schizophrenia and bipolar illness, and also eating disorders are more common among people with diabetes than the background population. There are also a number of diabetes-related psychological problems, such as diabetes distress. Perhaps at some points of their life, most people will experience this to one degree or another, given the constant demands of living with diabetes and the constant demands of having to treat their illness. There are also specific fears and anxieties around the development of complications, the side effects of treatment, such as fear of hypoglycemia. And it was very interesting that actually a number of years ago, there was a study of people with type 1 diabetes when they were asked about what they particularly feared about diabetes, and fear of severe hypoglycemia rated as highly as the development of renal failure. Rarely there are needle phobias, and there are also a number of adjustment disorders that people experience at the point of diagnosis, which is effectively very similar to a grieving response, where those individuals are effectively mourning their previous good life, healthy life. Diabetes affects cognitive function, so both in the young and old, so it can affect school achievement, it increases the risk of dementia. And we also know that people who have learning disabilities have higher rates of diabetes. And as you will have heard from Partha's talk previously, there are also societal issues such as stigma and discrimination that affect people with diabetes as well. So in the interest of time, I'm not going to go through all of these, and I'm just going to use depression as an example about where we should be concentrating some of our efforts. Now, depression is an extraordinarily common condition affecting over 300 million people worldwide, and with a lifetime risk of about 1 in 6. So just by the play of chance, we would expect that people with diabetes that we will see people with diabetes who have both of these conditions. But it's actually clear from a number of different studies that the rates of depression are increased about twofold among people with diabetes, such that if you take a formal diagnostic approach, about 1 in 10 people will have a formal diagnosis of depression, but as much to a quarter or a third of individuals will have depressive symptoms that may not be enough to make that formal diagnosis, but nevertheless may still impact on life. So which of our patients are going to be at risk? Well, there are a number of risk factors within the general population for depression, things like getting older, being a woman, coming from lower socioeconomic classes, having childhood adversity, and all of these things actually apply for people with diabetes just as much as they do for the general population. Physical illness, chronic physical illness is also a risk factor for depression. So not only diabetes is associated with increased risk of depression, but also cancer, heart disease, rheumatoid arthritis, all increasing the risks of depression. But there are some specific diabetes-related issues that increase the risk of depression. So when an individual develops a diabetes-related complication, they're more likely to go on to develop depression. That occurs for people with both type 1 and type 2 diabetes. It also occurs for both the micro and macrovascular complications. But if there are two conditions that are most commonly associated with depression, I think I would pick out painful peripheral neuropathy. And it's interesting to think how we use an antidepressant to treat that when we think about duloxetine, and also sexual dysfunction. So if you see somebody who's recently developed a complication, consider whether this may be somebody who is also at risk of depression.
Please unmute.
There we go. I hope that wasn't a reflection on my talk that I was muted at that point, but anyway, we'll go on. So for people with type 2 diabetes, we know that individuals who move on to insulin are more likely to develop depression. I'm not saying that this is the insulin that's causing it. It may be something to do with the demands of treatment with insulin. It may be something to do with the fact that people have see this as being the end stage of treatment. It may be something to do with health beliefs, the fact that they may have seen relatives in the past using insulin who've developed complications and not seeing that as being a diabetes complication, but seeing that as being something related to the insulin therapy. We also know that hypoglycemia, a complication of insulin, is also a risk factor for depression. So why does this matter for us as healthcare professionals? Well, we know that people who have both of these conditions have poorer quality of life, where both conditions are additive. And if that isn't enough to convince you, we also know that those with depression are less able to manage their diabetes as they should. And you heard very much from Partha the importance of self-management. So we know that people with depression are less likely to monitor their glucose, less likely to exercise regularly, less likely to eat healthily. And it's perhaps therefore no wonder that those individuals who have depression are more likely to develop the diabetes-related complications, both micro and macrovascular complications, and ultimately are more likely to die prematurely. And this study from the United States showed an annual mortality rate of around 8%, which is higher than the number of cancers. So we need
the last 2 minutes for you.
Yeah, okay. So what we know is that people with diabetes and mental health problems are less likely to have good care, so they're less likely to have iron foot checks, less likely to be screened for HbA1c and cholesterol, less likely to receive diabetes education, less likely to receive cardiovascular medication, protective medication. And so it's perhaps no wonder that these are individuals who are likely to have worse outcomes. So what do we need to do? We need to think about preventing, we need to think about screening, and we need to think about treating those individuals in order to help them, support them through their journey of that depression. So just a very final thought. most of the guidelines are starting to recognize the issues relating to psychosocial issues, but most of this guidance actually just reflects problems, so treating mental health problems when they occur. But we should remember that, in fact, health is not just an absence of problems, not just an absence of mental illness, but it's a state of complete physical, mental, and social well-being. And we need to think about ways of promoting well-being among our patients in order to not only remove the mental health, mental illness when it occurs, but also promote well-being through promoting their self-esteem, responding to their individual needs, communicating with them better in order to help them to get the best possible outcomes. So I think at that point, I'm going to shut up and I'll be very happy to take questions if there are any.
Yeah, absolutely.
Thank you, Dr. Richard. Yes, Dr. Ramon, carry on.
Yeah, Richard, it was a fantastic talk. And every endocrinologist or a diabetologist should know the importance of sharing their patients with a psychiatrist so that they reach the consultation at the right time, so that their mental illness is not neglected. Yes.
Yeah, I mean, I think that there's a point that I'd just like to make about that. I mean, clearly we need to have good liaison, good communication with our psychiatric colleagues. But I think a lot of the things that will improve the mental health can be done by diabetes teams. And I know that many of us think, oh no, this is outside our remit. But actually, as diabetologists, we are very good at being multidisciplinary. So we look at people's eyes to think about retinopathy. We look in people's urine to think about their kidneys. We think about cardiovascular risks. And we're already moving into many, many different specialties. And I think we should take that same approach for mental health problems as well, to think that there are things that we can do, but clearly where we reach the limit of our abilities, as we do with, say, somebody with proliferative retinopathy, we need to then refer on to appropriate support with other specialties.
Absolutely, indeed. Thank you, Richard.
That's a pleasure.
Carry on, Dr. Ramon. Please invite Dr. Chitta.
Yeah.
Thank you, Dr. Richard.
Thank you.
We'll go with the next topic. Yeah. Now I welcome Dr. Jiten Vora. He is a professor at University of Liverpool and consultant physician at Royal Liverpool University Hospital, specializing in diabetes and endocrinology. He is a MEA, MD, FRCP. Professor Vora gained qualification from University of Cambridge, UK, before completing period work of Fulbright Senior Fellow at Oregon, and then his ongoing research interests include development, screening, treatment of diabetic retinopathy, renal hemodynamics, hypertension in diabetes, and he has published extensively in field of diabetes, and he served on many advisory panel, including NICE. So welcome to Diabetes India. Please take over the session, sir.
Thank you very much, Dr. Mohan. Thank you for inviting me. I'm trying to find my there we are. Can you see the screen now?
Yes.
Thank you very much for that very kind introduction, and also very kind invitation to be party to Diabetes India in these extremely testy times, difficult times for us. It is, of course, a great disappointment that we're not all together. Now,
you please share the screen, sir?
I thought I was sharing it.
No, sir. It's a green arrow.
Yeah, I've done that. It says I'm sharing it.
Vasan sir, are you able to see that?
Yes, I'm able to.
Not yet. Not yet. Maybe need to click on the share the slides. Technical team, can you advise, Doctor?
Yes, sir. No, sir, we can't see that. Sir, kindly go to the Zoom and click the green button, share screen button.
I've done that. I've done that.
So what is the on your screen, sir, right now?
I'm not sure what I'm doing different from before.
No, sir. First go to the Zoom only.
Yep, I'm in Zoom.
Okay. Then click on the green button, share screen button. Okay. Now you show the pop-up screen one. After the clicking on share screen.
So it's saying desktop 1, but I can't find it.
So at the background, your PPT is open, sir?
Yep.
So on this small pop-up window, you can't see your PPT right there.
So I can see Zoom now. I'm on Zoom. I've pressed the share screen,
Okay.
and then I can't see my.
So, sir, kindly scroll this that small window, pop-up window. Scroll. If in your background there are many screen open, so maybe it is possible that your PPT screen is go down. So kindly scroll on that.
Look, I don't know what I'm doing wrong here. Let me just try another way.
Yeah.
So, sir, once minimize your Zoom and then reopen your PPT and then open the Zoom. So you can see the first of your PPT in the pop-up screen.
Yeah, it's open. It's on the desktop. My PPT is open.
Yes, and then now go to the Zoom right now.
Okay. And I've done share screen and I don't see it.
Share screen, then press OK, sir. Confirm it, sir. Confirm.
So once you share your screen, let's see what is coming.
You select the desktop and then confirm.
Yeah, I've done that. I've done that, Dr. Mohan.
Sorry.
Let me try again in a different way. Oh, how disappointing.
It's okay, sir. It's okay. No problems. No hurries.
Cancel that. Take that.
Who I open? Okay. હા બોલો બીટામાં હું બાકી બે એક્સેસ માં છે એક થીટા ને ગામા નો
Harshit, your voice
you're going to have to tell me what to do because I've opened it twice. Here we go. The presentation is now open. Zoom is now open. I've pressed on share screen.
Sir, can you share me to my mail ID? Just a minute, I can share that for you. I am typing my mail ID in the chat box, sir. It takes. May take maybe half minute. I can share from my screen.
One suggestion, sir.
I will just wait for a couple of minutes. Maybe.
Yeah, you may log out and re-log in. That might be a problem with that thing. That might solve the problem.
Okay, I'll do that.
Or you can send to my mail, sir. I already typed my mail.
By the time, send also to email of Dr. Rama Mohan. So in case that doesn't work, he can share your presentation.
Okay, I've done it all again. Can you see it now?
No, sir.
Okay, I don't know what's not working.
You can share with me. I can present from my side, and you can speak on that.
Okay, have you I've already sent the presentation. Do you have it?
So in the chat box, I written my mail ID, so you can send to me. I'm waiting.
They've already got it. I've sent it to them already, Dr. Mohan.
Oh, sorry.
Harshit, do you have the slides?
Sir, just I'm checking, sir. Just 1 minute.
I sent it yesterday.
Okay.
How disappointing.
No problems. Watson, sir.
Yeah.
In the meantime, you can add some points about nephroprotective drugs.
I know, but we are expecting that our learned speaker may be able to take over. Sorry for this small technical glitch. It happens sometimes. Technology fails.
I have no idea. We've all been doing Zoom for many, many months now, and this is the first time it's not worked for me.
It can happen.
And it's the same computer and the same system. So, and I've tested it all. So I can only apologize.
We understand.
No worries.
So while Harshit is looking for it, let me just make some comments. So some preliminary comments. So over the last 20 years, there's been very little, or 15 years, there's been very little in nephroprotection since the days of ACE inhibition and blood pressure control. So, the standard of care from our perspective is straightforward. Good glucose control, good blood pressure control, control your lipids to reduce cardiovascular mortality, and also add ACE inhibition to reduce kidney protection. But for the last 15, 20 years, there's been really very little other progress to reduce the residual risk. And the epidemiology tells us that some 48 to 50% of our people with type 2 diabetes will develop renal impairment in some way, either in the sense of reduced eGFR or albuminuria, or a combination of both. So reduction of that as an early step in therapy is a vital therapeutic procedure that we should all be participating in. Any progress?
Yes, sir. I'm just sharing my screen. Yes, sir. Is visible to you?
You have no idea how good it is to see my own slides.
Good, nice, but you have to concise somehow. It will be challenging to.
Okay, so we've done the introductory bits. We've talked about the need, the residual risk, etc. So let's move on. Harshit, will you do the slides? Are you going to do the slides?
Next.
Thank you. So we're going to talk a little bit about GLP-1s. We're going to talk mainly about SGLT2s, and I'm then going to finish off with some new data on mineralocorticoids and mineralocorticoid receptor antagonism. So next one, please, Harshit. Whoa, that's very quick. So majority of the data around SGLT2 started with the cardiovascular safety trials, which also looked at renal endpoints. And here in the black blocks, you will see the three big trials that were conducted. The important thing here to recognize is that many of these patients were already in the normal renal functions situation. Next one, please, Harshit. All of these three cardiovascular safety trials demonstrated significant renal protection in a primary composite endpoint of renal endpoints, including cardiovascular death. And you see that there is a consistency in this, that approximately 40 to 50% reduction in the relative risk of developing this primary composite endpoint. But also remember that we're still talking about relatively normal renal function at the start. So this raises the concept that SGLT2s may be appropriate for renal protection prior to the development of kidney disease. So primary prevention. Harshit, next one, please. And this notion is further exemplified by looking at data from the DECLARE study. Now, the DECLARE study had 2/3 of the patients who do not have established cardiovascular disease. Harshit, next one, please. And you will see here on the left that their renal function was really very good with a GFR of 85. So no established disease, no established complications, very high normal eGFR at start, but even then we had a 50% reduction in the relative risk of developing a renal composite endpoint. So all of these two data talk about and emphasize the notion that SGLT2s are important in prevention of renal disease in type 2 diabetes. Next one, please, Harshit. And again, if you look at the data on predominantly in EMPA-REG and Canvas programs, you will see that there is an early benefit, although there is a benefit throughout the renal spectrum. Next one, please, Harshit. So moving on, let's have a look at the renal protective effect in terms of baseline renal function. And what we see here is we're going from the top downwards, from normal renal function to declining renal function, and you see that there is an improvement of approximately 40 to 50%, regardless of your baseline GFR. Next one, please, Harshit. And here, what we see here is that the same benefit is preserved regardless of baseline albumin excretion rates. So here we have deteriorating ACR as we go down the graph, and you will see that the hazard ratios still demonstrate the benefit regardless of what your baseline UACR are. So the protection of SGLT2s occurs early, is not dependent on baseline eGFR, is not dependent on baseline UACR, and additionally is not dependent on baseline HbA1c, nor baseline BMI, etc. Harshit, next one, please. And of course, the important thing that we are interested in from a renal protection, despite the fact that majority of our patients who develop renal disease die of cardiovascular endpoints, this looks at what happens to the real parameter, which is the GFR. And you will see here that in these studies, these cardiovascular safety studies, the actively treated patients demonstrated stabilization of GFR after an initial drop. Harshit, please. Now, this is a difficult slide, and let me just talk you very quickly through it because it summarizes these three trials and what happens to protein excretion. On the left, we have three categories, which is primary prevention, progression from normal to abnormal, or progression within the abnormal range. And at the bottom, we have the most important thing, which is regression of proteinuria. And essentially, as you go over to the right, you will see that there's a benefit of between 25% and 50% in all of these three categories. So proteinuria is SGLT2 stop the development of proteinuria, stop the progression of it, and increase the regression. And regression means protection. Harshit, next, please. So now let's turn to a specific renal study with SGLT2s. So the first one to look at is the Credence study. You will see here we are now in the category of reduced renal function and also increased proteinuria. Harshit, next slide, please. So Credence, type 2 diabetes, mean GFR 56 mL per minute, and an albumin excretion rate of almost a gram a day. And in these people, there was approximately 40% reduction in the relative risk of progression of renal disease. And as you see on the right here, the protection was related to both end-stage renal disease or earlier in developing doubling of serum creatinine, which are very hard renal endpoints. So in established renal disease, we have protection, and that information is corroborated by a specific dapagliflozin in CKD, DAPA-CKD trial, and again showing you a 40% relative risk reduction in people with or without diabetes who had a GFR of 43 and an albumin excretion rate of about a gram a day. So here we have renal protection as well as cardiovascular protection. And Harshit, if we move to the next one, please. And if you look specifically at the renal endpoints, a sustained GFR decrease of greater than 50%, end-stage renal disease or renal death, you actually see a 40% reduction in the relative risk. So these are huge numbers. And what we've seen so far is data in prevention, data in early renal disease, data in established renal disease, in both cardiovascular endpoints and also in renal endpoints. Next one, please, Hadi. So the important point, as we've said, is these patients don't always die of renal death. They die of cardiovascular deaths or other causes. And the DAPA-CKD study shows you that there is a halving of risk of all-cause mortality in addition to renal protection. So in people with established diabetes and nephropathy, not only is renal protection reduced, but so is the increased cardiovascular risk. Next, please. When we look at patients with heart failure, we know that many of them already have pre-existing renal disease or that our treatment results in deterioration of renal function. Both studies in established heart failure with reduced ejection fraction, so DAPA heart failure and EMPEROR reduced, showed that there was a benefit in renal terms in these studies. So the renal dysfunction seen in people with heart failure was also reduced by half by the use of an SGLT2. And the next one, please. So very quickly now, let's just move on to GLP-1 receptor agonists. Again, similar cardiovascular outcome safety trials have shown a composite benefit in GLP-1 receptor agonists with liraglutide and semaglutide. So overall, in a very broad renal endpoint, you will see a reduction of between 20 and 40%. Next one, please. But we need to look at this a little bit more carefully. When you look at the top half of this graph, you will see that if you include macroalbuminuria, Harshit, next one, please, you will see a 17% reduction in the hazard ratio. But when you make a narrow renal endpoint by removing macroalbuminuria, you find that that significance is gone. So Harshit, next one, please. So you see that the significance is predominantly related to the broader renal endpoint and the development of macroalbuminuria and later renal function. There appears to be less GLP-1 receptor agonist benefit early in renal disease, in development of renal disease and early progression. It is predominantly in the later stages of DKD in type 2 diabetes. This, of course, will raise the issue of what agent you would want to use first. For example, after metformin, in people who are at higher risk of complications, maybe SGLT2s are more specific earlier than GLP-1 receptor agonists. Next, please. So let us move on to mineralocorticoid receptor antagonism. And this is looking at data with finerenone, which has recently been published. Here we have results from the Fidelio study looking at a primary composite endpoint, which includes kidney death in patients who are age 65 with a GFR of 44, and again, an albumin creatinine ratio greater close to 1 gram a day. And in this study, patients were established on all standard of care, and this is looking at data in patients on top of standard of care, including optimal maximized renal angiotensin system blockade. And you'll see that in this composite endpoint, you get a 16% further reduction in relative risk. Next, please, Harshit. However, if you start looking a bit more carefully in the renal parts, because the topic of this presentation is nephroprotection, if you look at the right-hand panel, you will see that the risk is reduced by a third on top of standard of care. So finerenone appears to give you added benefits over and above current standard of care. Next slide, please. So this is simply to show you that we've just talked about the results of Fidelio, which is an established kidney disease. But if you look at the right-hand panel, the Figaro study, which was only recently announced with a positive endpoint, And you will see that this relates to more people who have very normal renal function. And even in them, there was a cardiovascular and renal benefit. So it appears that over standard of care, finerenone increases protection in a broad range of patients. Ashit, please. So to finish off, loads of patients still get renal disease. Renal disease increases cardiovascular events. We now have data that shows from the SGLT2 trials that the protection afforded by these agents in renal disease starts early and continues throughout the disease journey of renal disease in diabetes and also in non-diabetes. So you may wish to use this as a potential selector for when you use SGLT2. To date, GLP-1 receptor agonists appear to have a smaller in quantity nephroprotection, but mainly towards the later parts of renal journey. And we have newer data, which on top of standard of care with a non-steroidal finerenone, which offers nephroprotection over a broad range of renal function. So we now have a whole series of therapies which are predominantly either glucose-related but give you nephroprotection, or agents which are specifically nephroprotective, which we can use for patients with type 2 diabetes. I thank you for your time, and I apologize once again for the technical difficulties we experienced.
Thank you very much, Dr. Jiten. I know you had challenges, but in spite of them, you made it a very clear presentation and updated us on some of the newer concepts on nephroprotection. Thank you very much, Dr. Jiten. I will move on to the next speaker. That is Dr. Pratik Chaudhary, who is going to speak to us on update on closed loop system. We always want to know more about this closed loop system and how we use it in our future management of diabetes. So Dr. Pratik is here, who is from University of Leicester. He's currently chair of Diabetes Technology Network in the United Kingdom. And he's also a member of EASD Postgraduate Education Committee and also the Medical Advisory Panel on Diabetes to the Department of Transport in UK. May I request Dr. Pratik Chaudhary to take over this topic?
Thank you very much. Thanks for that introduction. Let me just make sure I get the right slide share going. Here we go.
We got them.
You got it? Yeah?
We got them. You need to enlarge it. Yeah.
Yeah. Hang on. Yeah. So thank you. So thanks for the invitation. Sorry, I've just managed to come to this hall because I was chairing a session in the ESC symposium in the next Alpha Hall. But pleasure to be here talking about the update on closed loop systems. These are my disclosures. And of course, closed loop system and technology, I'm very much linked in with type 1 diabetes. And I put these data up to start because this shows the gap in life expectancy between people with type 1 diabetes and if you don't have it. So you see the blue dots there. If you're diagnosed under the age of 10, you lose 15 years of life expectancy, even in the West. And if you're diagnosed over 20, you lose about 10 years. And that explores the first myth that we used to call it juvenile diabetes or childhood diabetes. But the fact is that 50% of people with type 1 diabetes are diagnosed after the age of 18 in adulthood. So the first myth to explore there is that there's lots of misdiagnosis with type 2 diabetes being diagnosed in teenagers and type 1 diabetes being diagnosed in people over 25 and 30. But there's still that gap in life expectancy. On the right here, it gives a accumulation of what the causes are for that lower life expectancy. And in these younger people, aged 20 to 30, still a big part of that is from acute emergencies, DKA, misdiagnosis, and diabetic coma. But then as we get older, you can see the proportion in red increases, which again highlights the fact that 50% of this excess mortality is because of younger onset of cardiovascular disease. And often in type 1 diabetes, we're very focused on the glucose, but there's also an element of statins and other cardiovascular risk protection that we need to be in touch of. Now, diabetes, I think for the last 20 years, we've all been promoting, we need to have better access to technology. And what you see on the left there is data from the American Type 1 Diabetes Exchange. And the the orange line is the average A1C in different year groups about when a survey was done in about 2013, 2014. And the blue line is the same survey done in 2018. And what you see there is the A1C is actually higher, despite there being almost a doubling in access to CGM. So just giving people a pump alone or sensor alone, it has some benefit, but it doesn't get people to target. And I think what I want to highlight here is that our target is 6.5%. And actually, you can see here, on average, we're a long way off. On the right, you can see databases. DPV is a German database with 40,000 people with type 1. T1D Exchange, 25,000. Swedish registry, again, another 20,000. And average A1Cs, even in these Western countries with established education, free access to insulin, free access to pumps and sensors, we don't achieve those target glucose levels. UK National Diabetes Audit, we have a much lower rate in the UK of pump and sensor use, and you can see our A1Cs are much higher. And why is the reason then? It's all very well telling the patient your target is 6.5% HbA1c. But to achieve that, if you go back to the data and see what do people have to do to achieve that, they have to measure their glucose 8 to 10 times a day. If you look at flash monitoring, they're measuring at least 20 times a day, the people who achieve that target. And then 6 to 8 doses of rapid acting insulin. Usually to do that often, you need to have insulin pump. Then you need to have adjustments for travel, attention to snacks, planning for exercise, accurate carb counting. And on top of that, you need some luck, some skill, some motivation, some support from your peer network, education every day for the rest of your life. And in the Indian scenario, where you have to pay for insulin, you have to pay for strips, the expertise in teaching carb counting and dose adjustment may be variable on access to it, and the societal influence of type 1 diabetes and the societal support is even peer support is even tougher to get. Then it tells you why there's a much higher rate of problems in different scenarios. So of course, we've always known that technology helps. And I've seen many patients who have started their diabetes career measuring urine glucose and delivering insulin using washed syringe, which they boil and clear from the 1950s and 1960s. And then, of course, the vast majority of people who we see now in the UK, they're doing finger prick monitoring. Average in the UK is probably about 4 times a day. They keep detailed diaries and they use insulin pens. And then we have some people who've moved forward now. About 5% of people in the UK use some form of CGM. We have people using insulin pumps, and we have much better data capture. And as you move from left to right, I think we are seeing progressive drops in A1C, but nowhere near target until we combine those 3 elements: the glucose sensing, the data, and the pump in a closed loop system. And so in a closed loop system, what we do is we transfer the workload from the patient and the healthcare professional onto the system. And I think one of the big advantages is that when we have people on open loop, we have people on MDI or sensor augmented pump even, the input needed by the person with diabetes and with the healthcare professional is really high. We would see this because they're having so much data, actually sometimes it increases the workload for them. And that's when we move people onto closed loop, we find it makes a huge, huge difference to them in terms of the reduction in the amount of work they're doing for the diabetes. And that in turn, we see a big change in the relationship they have with their diabetes. Before that, they were resenting their diabetes. Because of diabetes, I can't exercise, I can't do this, I can't go out with my friends. And suddenly put them on closed loop, and that quality of life benefit is really transformative. And that's really what makes it fun, moving people onto closed loop. So this is just a slide now, it's probably 1.5 years old. It's a JDRF slide looking at 39 different projects looking at closed loop therapy. And from one side, you're looking dual hormones. How do we get a soluble glucagon so we can make a dual hormone insulin? And that's Xeris on the left-hand side. You've got the big industries of Insulet, Cellnovo, Tandem, Roche, Medtronic working in phase 3 or phase 4 trials. So all the big players are looking into this. You've got companies like Lilly who've purchased closed loop companies, and lots of independents, and including lots of patient-led organizations as well. Currently in the UK, we probably have the widest choice. We've got 3 currently available systems. You've got the Medtronic 670 and 780 systems. We have the Cambridge APS system, and we have the Tandem Control IQ. In the US and the rest of Europe, it's only the Medtronic and Control IQ systems that are currently available and licensed. So I'll take the Medtronic system first. And this was the first generation Medtronic system. And what I want to highlight here is the black boxes are the run-in numbers. Okay, so if you look at the second box here, which is time in range for adults, you can see at baseline these people in the study were at 66.7%. That's already an A1C of 7.5, right? They're almost at target, and it increases a little bit to 72. But the important thing here is that the blue box, which is real world data, is exactly the same as what you see in the trial, whether that's adults time in range, adults time above range, or if you look at hypoglycemia. Actually, if you look at hypoglycemia, that's first two columns, you see in the real world, patients have even less hypoglycemia than you saw in the studies. It's down from about 1% time. So 1% of time is about 144 minutes, in a day, is about 15 minutes a day, down to 0.6 or 0.5%. That's halving that. Hardly 5 minutes a day hypoglycemia on average people are getting. And so that's the main benefit that the people living with diabetes see. But we also look at the, of course, improved A1C. And as you roll this Medtronic 670 out across all the European countries, you can see here big numbers, thousands of patients, up to 4,000 in Italy, thousands of patients across all the different countries, ranging from Austria to even South Africa. And you can see the main thing here is this system, closed loop, is agnostic to who uses it and where it's used. It does not need patient expertise or healthcare professional expertise. Whereas the outcomes, if you look at the same figure for insulin pump therapy or education or sensors, you'll find huge variation between countries, dependent on the education, socioeconomic factors, and demographic factors. What you find with closed loop is that it doesn't matter who you put it on. There's a very tight response, and you can get 70% time in range, basically whoever you put it on. So how does this work? So basically, instead of having a flat background insulin, a bit like maybe you might use Lantus in MDI, or in a pump, you've got a basal rate. You can see here this purple graph is showing this Manhattan profile, that when the glucose is dropping down, the pump is turning off the insulin, just like a normal human pancreas would do. As the glucose rises, then in response to that, it will increase. So it's doing pulsatile insulin therapy, just like the human beta cell. Now, the first generation systems, which is the Medtronic 670 and the Tandem IQ system, do this by adjusting the basal insulin, which is actually quite clunky and quite slow to work. The second generation, which is the Medtronic 780, you can see these vertical lines here. So instead of increasing the basal insulin, which is a bit slower to act, it gives sharp boluses, sharp amounts of insulin, 1-2 units, repeated small pulses. And it's far more effective at stopping those rises of glucose and preventing hypoglycemia. And certainly we see a big difference in our clinical practice between 670 and 780. And you can see here, this is just a picture from a patient of ours. You can see how the glucose is within range almost the whole time. In the morning, you can see this person it's drifting down, the insulin turns off, the patient has a meal, very limited post-meal excursion, hardly hits 200 before it comes down. And you can see here, in the evening, patients had a high-fat meal. They bolus, they've actually, for 50 grams, you can see there is no purple line there. So they have not taken a bolus for the meal. So they missed the bolus. But the pump then can do lots of micro boluses and capture that and still keep the glucose down to a reasonable level. Not perfect, but still manages it way better than any other system can do. And using these latest second generation closed loop systems, you can see here, 84% of participants achieve an A1C of under 6.5%. 84%. In a utopian world, if every person was using a closed loop for the first 10 years of their type 1 diabetes, there would be zero amputation, zero blindness, and zero renal failure, actually, because people would be at target. This is just some data that we've done from our clinic. And again, there's a lot of talk about open source closed loop systems, and I'll talk to them a little bit later, but we did a comparison in our clinic of users using the Medtronic system and the closed loop, the DIY system. And you can see that DIY system is almost 10% greater time in range with no real difference in hypoglycemia, with a big reduction in these very high readings. And that's because the open source systems are far more aggressive. You can set lower targets, and it uses those boluses, things that are now incorporated into some of the second generation closed loops. The second option on the market that's widely used, and actually is a lot of patients really like this, which is the Tandem system. And the big difference with Tandem is it uses the Dexcom sensor. And for a lot of people, that's a game changer because the Dexcom sensor doesn't need finger prick calibration, but the Medtronic system does. And often for patients choosing which device to use, that is the biggest thing. Even if the Medtronic system is slightly better, they will say, I want to go for the Dexcom because I don't want to do finger pricks. Also, the pump is slightly smaller. It's touchscreen, so it's the form factor is much nicer. And again, the way it works is very similar. It works on basal adjustments. And these are some data just published very recently, shown at the ATTD meeting last week. And these are real world use from 10,000 users of closed loop therapy. So we're used to randomized controlled trials of 100 patients here, 200 patients here. Even for big drugs like empagliflozin and GLP-1s, we might have a trial of 4,000 or 5,000 people. But with real world evidence, we can look at 10,000 users. And again, what you see is this pretty tight band of interquartile ranges. Whoever you put on it basically gets to about high 70s time in range, and it happens straight away and is sustained. There is no drop off over the year. Time in hypoglycemia, you can see here, time below 70. In this cohort was quite low at the beginning, only 1%, so it stays there, but the variability, these people with very high time in hypoglycemia is reduced down with this system. So again, it kind of, whoever you put on these systems, they do the same, and that's the magic of these systems. And once they go onto it, their need for continued support, continued help from the healthcare professional goes away, because actually the glucose is in target as soon as you start the system. If you look at these are just a little bit more detailed data. So what these are cumulative graphs going from midnight to midnight of the whole year of data. And you can see overnight when the person is not eating, you can see the increase in time in range. They almost, as the system grabs control of your glucose once you've gone to bed, the system can get you to 90% time in range overnight. As the person eats, the time in range drops because the post-meal glucose, again, the post-meal glucose excursions are dependent on the carb counting ability of the individual. But you can see here, it never drops as low as it does in open loop. What's interesting in this from this publication was that there were 10,000 people using closed loops, but about 20% of those people, so probably about almost up to 1,500 to 2,000 people, were type 2 diabetes. And you can see exactly the same response in type 2 diabetes. Now, I think this is really interesting, particularly for the Indian market, where you have lots of people on high insulin doses, young people with type 2 diabetes, where the maybe I can, if I make an assumption, probably a bit like America, the people with type 2 diabetes who are at the higher economic level, who can afford some therapies, this is a much easier way for them to get control. And the fact that it works in type 2 diabetes, this is one of the first examples of large number of patients showing benefit in type 2 diabetes. The third option is the Cambridge Diabetes System. This uses a Dana pump. This is a Korean pump that is really nice and lightweight. And it is the Dexcom sensor. But the advantage of this system, which is why some of my patients, particularly the people who are working in busy jobs, choose this, is it's completely controlled on the phone. So a lot of patients who may be working in a client-facing environment, if they're sitting with a client and the client offers them a coffee or some snacks, they don't want to take the pump out and press some buttons to give the bolus at the moment. They find it much more easy and discreet because this closed loop system runs off an app, and they can just open the app and click a button and take that, say I'm having 10 grams of carb for my coffee, I'm having 30 grams of carb for this samosa, and deliver that. And the discreteness of the system is really, really what sells it to people. It's also a bit more adaptive with what targets you can set, and it's the only system that is eligible for children under 7 years, and it's the only system that's eligible and proven in pregnancy. But again, you can see this Manhattan of basal rates. The pump is continuously changing the background insulin delivery, just like the human pancreas does, in response to glucose. And then when the meal comes, you can see these spikes here, 2.9, 2.1. These are spikes that still the person has to tell the system that they're eating. And coming soon at the ATTD, we saw some really nice data from the Omnipod Horizon system. For a lot of patients, the fact that this is a tubeless system, again, managed off a handset, is hugely beneficial and attractive. And I've got a lot of patients who are waiting for Omnipod to come out with their system before they go on closed loop. Kaleido has a system as well, which is tied in with a French group called Diabeloop. And again, these are two systems that will probably come I think the trials and the FDA approvals were delayed by COVID. So instead of a launch at the end of 2021, we're looking to sometime in 2022 for these systems to come online. Again, the Omnipod system has the flexibility of using different target levels, and you can see the time in range you achieve is really dependent on the target level you get. And that's why the early Medtronic systems, you could only use a 140 target, you used to get a lower time in range. With the newer systems, you can use a tighter target of 110 milligram per deciliter and achieve that 70% time in range that you're looking for. And finally, briefly, I'll talk a bit about these DIY closed loop systems. With the lack of availability of commercial systems in India, there are a number of patients and patient organizations who are connecting with international groups and using these loop or DIY APS systems. And basically these are, you use a commercially obtained pump, and you can use a cheaper pump like this Medtronic VO system or Paradigm system or a Kaleido system. You use a Riley link, which then is able to communicate with that and the app. And you download on the app a software that is written, it's not approved, it's written by software engineers who live with diabetes, and they use knowledge of these predictive algorithms that they use. Maybe, it's the same algorithm that traders use trading stocks. It's the same algorithm that people, one of the guys who works in closed loop therapy used to work for British Petroleum, and they manage the pressure within a refinery. The mathematics behind these closed loops is very similar and common, and people can use that, download onto apps and use that. Three main systems, Loop, OpenAPS, and Android APS, pretty much do the same thing. So how does it impact our clinical practice? I think certainly at the moment when we are advised, someone says, I want to use a pump, I think we should say, are you going to use it with a closed loop or not? Because that defines which pump you use. That's the biggest outlay. The choice of algorithm, there's not a huge amount of difference. They all achieve very good control, but we have to have patient expectations. Once you start it, we can't adjust the algorithm. If it's not delivering, we can't adjust the technical delivery. We have to adjust the patient behavior there. And the education we give people changes completely. It changes to how do we keep people in auto mode and how do we keep them safe if the sensor fails or if there's a pump problem and they come back into manual driving, as it were. So I think we're really at the cusp of this situation where we used to have sensors and pumps and injections and MDI and SMBG. And we used to say, if you want to get good diabetes control, you have to work harder. But I think now we can use the technology to work smarter. And if we have the ability to fund these systems, or people have the ability to fund the systems, then they are really, really worth it in the long terms. Thank you.
Yeah.
Dr. Ramohan, yes.
So Pratik, it's absolutely fantastic. And we being a diabetologist or endocrinologist, we always look for the better future for all the type 1 or type 2 diabetic patients, and we have to update ourselves to 2.0 so that the best technology will be delivered in the future. And we in India at the periphery hope for the best technology coming to us soon. And we were enlightened to see all these things. Thank you.
It's a great dream for all of us, including our patients, to have the technology that Dr. Pratik has mentioned. It's an interesting discussion. Interesting talk. Are there any questions in the chat box, Dr. Ramohan?
No, sir.
There are no. I think we should thank Payal for taking this program.
Thank you very much, sir.
Yeah, please take over. Thank you.
One more topic is there, sir.
So one more topic is remaining.
Yes.
I'll take.
Yeah. Next speaker is Dr. Ian Cranston from UK.
Yeah. Good evening, everybody. I welcome now Ian Cranston. He's a diabetes physician based at Portsmouth, UK. He has special responsibility for delivery of technology devices, CGM, and approximately 1% of UK population. He's a lead diabetes clinician for Wessex Renal Transplant Center. And for last 20 years, he has been in practice and with the goal of translating lessons learned from research routine clinical care consultations. And I welcome Ian Cranston for this topic, incorporating CGM data analysis into routine clinical consultations. I welcome, sir. Welcome to Diabetes India 2021.
Thank you very much, and thank you very much for the invitation to take this on. I'm hoping I can just get my screen to share properly, and hopefully you can see what's on my screen. So my talk is going to be one about actually how we use data that's becoming more and more available in our routine consultation process. So as you heard from Pratik there, in the UK, we don't necessarily use quite as much technology as some of our cousins across the pond. But I think that what we still have to work hard on is this idea about how we use the information from the technology in order to help us make better decisions. Because although I think the future of closed loop therapy is clearly very bright from the perspective of people with type 1 diabetes, the reality at the moment in the UK and in actually large parts of the world is that less than 1% of people with type 1 diabetes are actually using closed loop in any format at the moment. So it's a case of optimizing what we have right now. And I think the other issue that we need to obviously be aware of is that the diabetes consultation can be a very busy place. We often don't have as much time as we'd like to spend, and we have what seems to be an ever-increasing agenda list of things to cover. And so obviously, in talking about that in a routine consultation, I'm only going to be really talking about this idea about the glucose management aspect of a consultation and the way we use information in that. And realistically, when we do a glucose consultation, we have to recognize that what we're trying to do is really to start with a very general view and then focus in over time. And so the tools that we've had historically have been quite reasonable from the perspective of looking at these overview tests in terms of an individual's average glucose, but really give us virtually no information. And I'm thinking obviously of the hemoglobin A1C here, give us virtually no information from the perspective of the range extremes in terms of how high might it go, how low might it go, and in particular obviously then the detail around that, which is the times of day that we might see those things and the times of day in which we might see risks related to glucose variability, for example. And so a lot of our consultations around glucose control will end up in trying to help problem solve, as it were, areas of difficulty. And the tools that we've had historically just haven't allowed us to do that. So as I say, hemoglobin A1C can do the first of those things. Potentially, if it's used carefully and used well, fingerstick testing can actually give us quite a lot of information about some of the other goals that we have within the glycemic consultation. But I think the power really here is that from a perspective of the continuous glucose monitoring devices, they can give us all of that information with one investigative tool. And so with that in mind, I guess it's not really that surprising that we've seen this dramatic growth in the use of CGM. This is almost certainly probably an out-of-date slide now because it's almost impossible to keep an in-date slide around CGM use, and I apologize that it's very UK focused. But I think the important thing, and what I wanted to highlight really from the point of view of this at the moment, is that in the UK and indeed worldwide at the moment, the vast majority of continuous glucose monitoring devices that are being used and sold are actually these so-called flash glucose monitoring devices. So the Freestyle Libre device, which actually at the present time accounts for around about 3/4 of all the CGM devices that are being used. And whilst in the UK we've been with work from people like Pratik actually pushing the ever increased use of this in people with type 1 diabetes, what we also have to recognize is that it's probably 40 to 50,000 people with type 2 diabetes in the UK using these as a self-purchase process, which may parallel the use much more around other parts of the world. Because of course, as I've highlighted, I think that the important thing here is that an individual's experience of the glucose is far more than just the average. And in particular, I think we need to start bearing into mind the variability measures. And in particular, I think we tend to classify those, don't we, in terms of variability within one day and variability between days. Because these variability measures, I think, have at least as much impact on an individual's quality of life and on their likelihood of developing complications from their diabetes as the average overall. So what we can see is that CGM data is a very powerful set of data. Because we can validate it, we have to use a computer realistically to analyze glucose data from CGM devices, because there's too much data for us to be able to look at columns of figures realistically. And because it's measuring all the time, it means that we don't have any bias in the way that that data is being collected. And of course, because we have that continuous measure, it will give us the information, all of the information that we might need to try and help make people to make better decisions around the therapy for their diabetes. Now, that's an awful lot of pluses, and realistically, I don't think there's any other tool that has given us that many pluses, but it comes sadly with a price. And the price is that analyzing glucose data that's so plentiful can be quite challenging. And if we look at the different devices, we could say, if we look at the Medtronic device, there'd be over 4,000 data points in a 2-week period. So it's clear that we have to look at this data from the perspective of projected images of that data, rather than just looking at the numbers, as it were. The difficulty being, of course, that simple projected images like this that just show a trace for each day are almost impossible for us to analyze as individuals. And so there's been this, if you like, industry over the course of the last 10 to 20 years looking at how we can take these data sets and use them more clinically effectively. And obviously the winner in that respect has been this projection called the ambulatory glucose profile, which simplifies those multiple lines into effectively 5 lines. Originally, those 5 lines would have been the median line, the interquartile range line, so the 25th and the 75th centile, and the 10th and the 90th centile. And I think for most of us in the classic AGP, that still remains the process. Although we have to also be aware, I guess, that with the Libre software, we're now looking at a slightly different profile, which is not the 10th and the 90th centile any longer, but is the 5th and the 95th centile, and more of that perhaps a bit later on. My computer has frozen. No, it hasn't. There we go. So I think the key thing is that the AGP allows us to simplify these very complex data sets into things that we can use routinely and clinically in the clinic setting, because of course we have to take into account both the average glucose and the glucose variability as this part of process. And I think that idea of taking both the average and the glucose variability into account is really what's driven this concept of the so-called time in range concept. So this is an example of that, where we can see 3 individuals, all of whom have the same average glucose over a 24-hour period, but who, because of different variability across the scale, will spend a very different amount of time in this comfortable target range between 3.9 and 10 millimoles, or 70 and 180 milligrams per deciliter. And indeed, we can actually see that even though the average for this person is right in the middle of that range, they're actually spending more time high and low than they are in their comfortable range when the variability is high. So this time in range concept combines these two issues that we need to be looking at, and I think therefore has become a very straightforward process for us to start looking at in a very simplistic way. And perhaps not surprising from that perspective, we've now got a widely endorsed international consensus statement around time and range for the last 18 months or so. And I think the key thing from a UK perspective is that it's now being endorsed by all the major professional groups and patient groups for diabetes care in the UK. And of course, that this consensus is relevant for both people with type 1 and type 2 diabetes, is relevant to all glucose collection devices. So it isn't about which device someone is using, it's about all devices. And indeed, as our previous speaker Pratik has shown, that actually when people are moderately frequently using SMBG data 5 or more times a day, you can also use that the same concept of time in range to SMBG data as well as you can to CGM data. And I think importantly for us in a clinic setting, whereas I think it's entirely inappropriate for us to ask people to say in a clinic, I think you should be trying to achieve a hemoglobin A1C of 6.5%, because nobody really knows what a hemoglobin A1C of 6.5% looks like on a day-to-day basis. The time in range is something we can use for target setting. Now, I personally wouldn't necessarily say, look, the goal here is to achieve a time in range of 70% to everybody. But I think if that we take where they are now, we can use the target setting to slowly increase that time in range. And so it also allows us, if we all use the same tool, to offer consistency in an individual's care if they're seeing different healthcare professionals over time. So the detail of those goals for the time in range is very similar for type 1 and, well, identical for type 1 and type 2 diabetes in terms of general population benefit. And the idea is to try and achieve at least 70% of time in this 3.9 to 10 range and 4% less than 4% below 3.9. And although we call it a time in range goal, I think we have to, in our minds, expand that to time in range and time below range. I don't think it's about one or the other. Because of course there are those who may have specific risks relating to time below range, either because of frailty or because of comorbidity or because of the fact that they have had episodes of severe hypoglycemia or reduced awareness of hypoglycemia. And for those high risk individuals, I think the power here is that we don't need to change the target range. What we change is the percentage goals within those target ranges. So what we're looking at is for the high risk individuals, we want to see far less time in the low range. And as a result of that, we're prepared to accept less time in the target range. So, but again, it allows us to work this consistency over time. Now, one of the reasons I think this is a very powerful phenomenon, as we've seen, this is data from Libre, and a lot of my data will now come from Libre, being the commonest device out there. We know that people will look at the data with a sensor far more often than they would do finger stick tests, and that's perhaps understandable. But I think it's surprised many of the healthcare delivery populations so how much more often they will look at it. So the average we can see here is 14, 15 scans a day. And the reason for that, I think, is because people very quickly work out that the more scans they do, the better the effects they see, both in terms of time in range, in estimated hemoglobin A1C, and in hypoglycemia risk. But I think it's important for us to recognize this idea of projecting data as well, because we know that whilst these benefits from the point of view of reducing hypo risk can happen very quickly, the benefits in terms of reducing higher glucose levels happen much more slowly and often will require healthcare intervention to try and help to advise around that. And so I think what we need to conclude from that is that for have a successful outcome, we both need to have a person with diabetes who understands their data and how to manipulate their therapies to improve that. But also we need to have periods where we've got, if you like, a third party making an objective, structured planning overview of that data. And of course, that's where the routine consultation here comes in. Because actually everybody using a Freestyle Libre, if they're using their phone to scan it, already has online data which can be assessed and used in a clinic. Interestingly, when I'm in clinic and talking to people for the first time, most of my patients don't know that they actually have that data online and available to be reviewed. And very few of them have ever done so themselves. And so I think that's really the power of the process, is us making sure that we do know we've got that data and start to use it routinely. Because of course, the majority of those people, the data will be on the cloud. There are multiple clouds, and obviously the one we've been talking about is this LibreView cloud. So the individual is using the right of the skull. That information is being pushed into the cloud, and from the cloud, we can access it in our clinic computers very straightforwardly. You don't need to have your own account to do this at all. If the individual has got a login for Libre, then they've also got a login for LibreView. So you just go to the website and ask them what their login criteria are on their phone, and you can immediately see their data. However, it is much more powerful if you do have your own clinic set up for LibreView, because when you've done that, what you're then able to do is to say everybody who is chosen to share data with your clinic, you can then start to look at, so you can prioritize input and you can look in almost in real time at where individuals who are struggling may be, or individuals who are improving may be. And I think, although this is perhaps a little bit big brotherish for some of us to think about, I think it's been particularly over this last year and a half where clinical contact has often been much more difficult. This has been a really powerful tool. So I think the first absolute push is to say, try and make sure that you've got your own clinic login for LibreView, because without that, it's much more difficult for you to be able to easily assess what's going on with your patients. I think the next thing is to be able to say to be confident looking at people's data. And I'm going to spend my last 2 or 3 slides really looking at this process, because I think the time in range consensus has really pushed us towards this idea of the right of this slide, of saying what we want to be able to do is to look at some validatory metrics that include this time in range measure for all our patients. They want us to be able to look at these summative metrics, so that, I'd say, the time in range and the averages and the amount of glucose variability that we can see. But then we also want to be able to look at the idea of the information over time of day and over days of the week. So this idea of using the ambulatory glucose profile and also using the individual day profiles. And all of those are available as a single report within the Libre data, which is what I think most of us start by looking at when we're using Libre data in clinic. So a couple of don'ts before I do some do's in this data analysis process. I think it's really important to recognize that there are some really what appear to be behaviors that would be okay, but actually I think are counterproductive rather than helpful. So an individual who has a high hemoglobin A1C does not necessarily need more insulin. So I don't think we should ever be really making insulin change advices based purely on the hemoglobin A1C. I think if you don't understand data, then don't guess. I think guessing with data is a very difficult process to justify. Even if you have a 50-50 rate, I don't think that's great consultation process. Most people have got more than one thing going on, but they've got one thing that is more important than the other things going on in terms of the things that are barriers to them achieving what they would like to. And I think that it's a mistake to try and fix all of the issues in one go. And what we should look to do is to try and fix the most important thing first and then take a second bite at it down the line, this idea of Kaizen approach to care. It's really important not to be the plumber. And I suspect Indian plumbers are the same as UK plumbers who arrive in your house and the first thing they do is they suck a big breath through their teeth and go, oh dear. We mustn't do that with glucose data because it's very difficult for people to take that on. And so I think we need to be aware of what we're trying to do. And then we take these reports in a structured state. And we look at, first of all, at the time in range targets. If they're being met, my own personal practice is not to try and offer any specific additional advice at that point.
So that's 2 minutes, sorry.
Unless the person wishes to ask me something about a particular time in the day. If they're not achieving those or would like to make a difference, however, we then take the next 2 steps, which is first to look at the AGP. And when we look at the AGP, I'm tending to look at it saying, do I see predominantly a hypoglycemic risk, a hyperglycemic risk, or a variability risk on that profile? And then say, which of those things, therefore, is the one that's most important? And there's 2 ways of looking at that. One is to say, have an overall look and see what grabs your attention on the picture compared to an ideal. And then to be more systematic about it, looking through time blocks of the day, looking at all aspects of the care. Once we know that there is what the predominant issue is, we're then able to take that forward and discuss that with the patient, often using an individual day profile as an easier way of discussing a potential. And I think the key statement I would like to then say at the end is only make one change. If you make lots and lots of changes, it's very difficult for you to then work through what made the difference over time. So I'm aware this has been a real rush through this process, and I think 20 minutes is probably pushing it to try and achieve. But hopefully, it gives at least an idea. And I think this idea of it is actually very simple as long as you've set yourself up with the right tools and are prepared just to take a little bit of time to familiarize yourself with using those tools. Thank you very much.
Yeah, thank you, Ian. That was a fantastic show. I have a question for you. Next 5 years, are we going to see the change from HbA1c to time in range?
So I think realistically, once we start to see, I think within type 1 diabetes, the answer is going to be yes, to be honest, because I think that it's a matter of time before we see this technology so widely spread amongst type 1 diabetes. I think, and equally, I think because type 1 diabetes has historically and continues to be more likely to be managed through specialist services than type 2 diabetes. I think hemoglobin A1C has value, and it is a comparable, but realistically, if I had a choice, would I like to see a year's worth of someone's CGM data, or would I like to see 3 hemoglobin A1Cs? It's just not a choice, is it?
Thank you, Ian. Thank you. Thank you, Dr. Vasan sir. Thank you, Diabetes India 2021 for this opportunity. And back to the organizers. We are on time.
Thank you very much for the wonderful session. Any more questions? We have a couple of more minutes left.
I think, Payal, the last two topics on technology are really giving us the future of diabetes care, diabetes management, I must say, for us. Time for us to think about them and how we will be able to apply in the near future. Dr. Ramon was concerned about how fast can we use them, but I'm sure it's going to happen fast, and very soon we will be able to apply this technology to our own patients and give them the best results.
Absolutely.
Yeah.
Okay. Thank you very much, chairpersons and all the organizers and all the faculty members. It was a wonderful session. Thank you very much.
Thank you.
Moving on to the next session.
Thank you for this symposium, Indo-UK symposium. Thank you all the respected speakers, our rapporteur and respected chairperson for the session. So moving ahead for the next session, we are having the CODI symposium. And for this symposium, we are waiting for our chairpersons. Our chairpersons for the next symposiums are Dr. Rohit Kapoor and Dr. Rajesh Teli. Would like to invite both of them for the next session. Would also request Dr. Vasant Kumar sir, Dr. Rutul to be there for the next session, to be with our respected chairpersons.
Sure.
Well, there is some difficulty, or Dr. Rohit Kapoor has joined. So can we have the next slides for them? So would like to request Dr. Vasant Kumar sir, please, if you invite our next speaker, Dr. Ibrahim Stan, Germany.
Thank you, Dr. Dharmendra. So we are moving on to another exciting session. Our speaker, learned speaker. It's always sometimes difficult to pronounce German names, but I will anyway try. Eberhard. And he's a professor of medicine and endocrinologist, and also angiologist in the famous city of Munich, West Germany. He's with us. He's also past president of IDF Europe and also German Diabetes Association. He takes very active part in the IDF, many activities. He's going to speak to us on vicious circles of diabetes, heart failure, and renal dysfunction. 3 of them together. All over to you, sir.
Okay. Can you hear me, sir?
We can hear you. We are waiting for you, sir.
That's first of all good news.
Yes.
And you see my slides?
Not yet. Not yet.
Not yet. Okay. Okay.
Slide share.
Am I still on?
You are very much visible to us.
I can't, for some reason, I can't share in the moment. It says it's
The tech
somehow.
team, I gave him permission to.
Oh, yes, sir. Just a second. Just a second.
Yeah. Yeah.
Are we on with the slide?
Yeah, they are doing it.
You're seeing it now?
Not yet.
Oh my goodness.
Just a few seconds, sir. I think the tech team is looking at it. Sometimes they need to permit you.
Yes, we are making him co-host.
So I think that also has a benefit.
Thank you, sir.
Yes, sir. Now you can see your slide.
I can see my slide now.
Would you like to comment?
We can see that.
Your elaboration by Dr. Raj Malik.
Yeah, thank you,
Okay.
Dr. Malik, for the nice talk. Actually, I am a great fan of this corneal confocal microscopy, and I have been giving many lectures on corneal confocal microscopy in various diabetes conferences also. You see, because
So I can share my screen.
Sir, your share screen with your PPT has a sound. Some sound is there.
Do you see
Yeah,
it?
yeah, you're on, sir. The slides are visible.
Okay. Sorry for the detour. Let's go for full presentation. Okay. Okay.
It's done.
Okay. First of all, a big thank you to Banchi Sabo and Itamaras for this invitation and the honor to contribute to this important symposium, CODI symposium within Diabetes India 2021, highlighting an important practical issue, the vicious circles of diabetes, heart failure, and renal dysfunction. My disclosures, my presentation outline. First, we'll start with two ominous octets, then the crosstalks between heart and kidney, the renal impairment as risk factor for heart failure, the common background of this metabolic syndrome with low-grade inflammation, insulin resistance, driving it really all type 2 diabetes, heart failure, and chronic kidney disease. The cardiorenal worsening, often the first manifestation of any cardiovascular complication. And finally, therapeutic options deriving based on this vicious circles as outlined. So let's get started with the first ominous octet regarding heart failure. And this is caused by cardiac and cardiovascular disease lipoglucotoxicity, the cardiac fuel overload and renal glucotoxicity. And as you see, this drives the heart all the way the continuum of diabetes from ailing to failing to heart failure and related hospitalizations, cardiovascular death. And in the center, like in people without diabetes but heart failure, ischemic coronary artery disease and hypertension are central drivers also in people with diabetes. Now then on the right side, more diabetes specific factors like the cardiometabolic myopathy, cardiomyopathy, microangiopathy, response from the kidney in terms of fluid expansion, glomerular hyperfiltration, sympathetic nervous system overdrive. Now this is the heart failure ominous octet. This is for diabetic kidney disease. And again, you see central hypoxemia and hypertension, similar factors as for heart failure, but in terms of the kidney, of course, the deranged tubular glomerular feedback, tubular growth factor hypothesis, and in particular hyperglycemia driving the podocyte dropout, and additional factors like obesity and also genetics. So there is quite some similarity in those octets, And the question is how the two organs, heart and kidney, speak to each other. The heart really uses the natriuretic peptide system to the kidney, and the kidney responded by the activation of the renin-angiotensin-aldosterone system and sympathetic nervous system activation. Now, early on, this is a positive circle, as by BMP relief, there is suppression of some sympathetic nervous system activity. GFR goes up, natriuresis, diuresis, blood pressure is down. But in the chronic situation and driven by a decreased cardiac output due to structural changes of the heart, then you get activation of RAS, sodium water retention, increase of blood pressure. So one can envisage several circles between the heart on the left and the kidney on the right side. And the basic message is if there is damage to one organ, say the heart, it will be also impacting on the kidney and vice versa. Not the least because there is this common dysmetabolic background with low-grade inflammation, oxidative stress, and the factors already mentioned. Driving fibrosis, and once you have structural changes, you have diastolic and systolic dysfunction, but also at the kidney level, you have changes derived from that. And modifying factors, the load, the afterload, preload, low cardiac output, congestion, but similar also the side of the kidney after and preload, including hyperuricemia and the fluid retention, which is central. Now, we should remind ourselves the several subtypes of heart failure, also in diabetes. The far left, this is with decreased left ventricular ejection fraction below 40%. This is HFrEF, mid-range, and HFpEF with a left ventricular ejection fraction above 50%. And you see always the heart is speaking via the natriuretic peptides, and there will be structural changes. And just if you like picture, this is the diastolic dysfunction, the restriction of function, HFpEF, and this is dilation, HFrEF. No matter diabetes to any of those subgroups, either low ejection fraction or preserved ejection fraction, as you will see, is especially additive in terms of risk for cardiovascular death or hospitalization due to heart failure, but similar also for all-cause mortality. So renal impairment in patients with type 2 diabetes, increasing the risk of hospitalization for heart failure. On the left, you see the impact of estimated GFR starting around CKD3, GFR below 16. You see the increase for heart failure hospitalization. On the right side, the impact of albuminuria, starting actually with microalbuminuria. And as we have already gone through that, the potential mechanisms how the metabolic syndrome induces chronic kidney disease, this is central around the metabolic syndrome. And hyperglycemia and insulin resistance, driving factors of the manifestation of type 2 diabetes, but at the same time also doing damage to the kidney. So this all happens actually before the manifestation of type 2 diabetes. And in essence, about half of all people with type 2 diabetes worldwide.
We are not able to have the voice.
Is it difficult with the voice? No? Have diabetic kidney disease. Are we still on, sir?
So just increase your device volumes.
Okay, I will do that. Okay. So around every other person with type 2 diabetes also has diabetic kidney disease. And this happens often before manifestation of type 2 diabetes. As we have showed a little while ago, in people with recent onset type 2 diabetes, some 40% already have increased albumin excretion in conjunction with the risk factors mentioned, blood pressure, but also ischemic heart disease. So these are the central players for why we are driving this vicious circles between the kidney and heart failure. And actually also heart failure is already increased during the phase of pre-diabetes, IGT, the Reykjavik study, and you see the risk is already more or less double compared to age-matched people without diabetes in both sexes. So we have to be also early with heart failure in diabetes. And it's striking the parallelity of the increasing global prevalence of diabetes on the right side, and also for the prevalent cases of heart failure in both sexes. And one link, obviously, is that about 50% of patients with heart failure have concomitant diabetes, diagnosed or often also undiagnosed, another important fact for practice. Now, age is very important for heart failure prevalence, in blue diabetes, in red people without diabetes. And you see at age 65, which is an average age in diabetes population, 10%, 1 in 10 has manifest heart failure. And of course, in higher age ranges, it's up to 40% of the patients. We have looked at the characteristics for heart failure incidence in the TECOS trial, but similar data have been produced by various studies. And it's age, as you already saw, male sex, more prominent in whites and blacks. It's interesting, it's less in Asians, it's only half of that in TECOS. Low GFR, no surprise, and prior arteriosclerotic cardiovascular disease and heart failure, weight, and a lot of cardiovascular medication. Now, as already alluded in the outline, the cardiorenal complication is often the first manifestation of cardiovascular complications in type 2 diabetes. It's a huge database, initially free of cardiovascular and renal disease, and over a follow-up of 4 years, you see a lot of new cases, especially heart failure and renal disease occurring. And these are the blue lines exceeding stroke, exceeding myocardial infarction, and others. So this is the most prominent complication. And of course, the understanding is this vicious circles behind which are operating even before the manifestation of type 2 diabetes. And this is important in terms of risk of outcome. And for all-cause death, this is heart failure more than doubling the risk of all-cause death, kidney disease, the combination, and for cardiovascular death, very similar, up to 4-fold increase mortality from cardiovascular death. Well, so it's not surprising that early kidney disease is such an important factor when it comes to life expectancy because of, I tried to say, due to these vicious circles also involving heart failure and related complications like cardiovascular death. What about metabolic control? The good news still is and established for type 2 diabetes in UK PDS. Yes, intensifying glucose control is here to an A1C of 7 compared to 7.9, reduces albuminuria, but also other microvascular complications. And so this is still very important in those days when we want to improve prognosis. And of course, we also all know that there is also borderline effect for myocardial infarction. In fact, when it has been looked into so-called mega trials, what happens in terms of heart failure outcomes, the line is really the line of unity. There's zero effect for that. Now, the interpretation is probably we have structural changes. We have fibrosis at the heart. We have expansion of extracellular matrix, and this is not really up to changes by short-time glucose control. The other very important factor for kidney disease, as we all know, is systolic blood pressure, as evidenced, for instance, in the advanced study, but there are many studies like that. And, you know, the best risks are below 120. This is the specifics for a kidney. On the other hand, one gets into some trouble when it comes to heart failure. One has to watch out with these low factors, but no question, using tight systolic blood pressure control and using ACE inhibitors in combination with thiazide, you get 21% reduction total events, along also with significant reduction of total mortality and also cardiovascular death. Now, somewhat puzzling is when you look in observational studies, and this is at the right bottom, heart failure. Then in pink or red, you see the importance of hyperglycemia being a risk predictor for heart failure superior to blood pressure and cholesterol. This is at the low gray range there. Now, the interpretation is this is a surrogate finding. With hyperglycemia and insulin resistance, there is a shift at the heart fuel to free fatty acid usage. And very little glucose is used by that, building up again vicious circles. And as outlined here, no energy derived from glucose, but a lot by free fatty acids. And this leads to overreaction, overcontraction, inflammation, fibrosis, ceramide formation. This is really a very toxic substance. Necrosis of myocytes occur, so scarring of the heart. And these are the factors as a surrogate behind hyperglycemia. Now, putting it all together, coming close to the end of my talk in one big circle, but also in several subcircles in diabetes, where we have insulin resistance, but also the relative deficit on insulin secretion. As you know, of course, there are drugs out there helping that to prevent development of microangiopathy and on the way to left ventricular dilation, HFrEF. Advanced glycation end products, another component in this extracellular matrix and stiffening of the heart and expansion of the heart and scarring, driving inflammation there, but also related with endothelial dysfunction, left ventricular restriction, and HFpEF. And in terms of the RAS pathway sympathetic activations, there are also drugs out there. One very important fact I already alluded to, there is huge potential of undiagnosed heart failure in patients with diabetes. Beautifully done trial, Saber-Timmy, and they have actually measured NT-proBNP in all patients. Now, if you know the cutoff for NT-proBNP, where you should work up further for heart failure to further diagnostics, this is 135. So in essence, 12% gave or reported a history of heart failure, but half of the patients had increased levels. I'm not saying everyone had heart failure in that, but a lot clearly on this side. And as you also see, there were a lot of heart failure complications in these upper quartiles here, so in this upper half. So huge subgroup of 50% with suspected heart failure as compared, contrasted to 12% with known heart failure history. So this is a new paradigm. This is the role of the endocrinologist and diabetologist to really assure diagnosing heart failure in patients with diabetes. It's so common and often undiagnosed, assuring the compliance with the cardiologic therapy as outlined here. This is not the main topic of the talk. Addressing then the appropriate cardiometabolic approach, tailoring the appropriate glucose-lowering therapy to the individual patient, and we need cooperation with the cardiologist. So in ending, better understanding the various vicious circles operating between diabetes manifestation, development of heart failure, development of kidney disease, improve our capabilities to have better strategies for diagnosis, but also therapy of those patients with this vicious circle. So if you have known heart failure, you have to determine ejection fraction. At the same time, CKD assessment, albuminuria, and estimated GFR. If you have CKD, heart failure assessments, go for signs and symptoms. This is internal medicine. And if needed, also use an NT-proBNP, and this will help them the appropriate therapy. But also the combination of ischemic heart disease and risk factors such as hypertension and obesity has really the consequence for workup, heart failure assessment, CKD, and this is then really coming to the individual need of our patients. So thank you very much for your attention, and I'm looking forward for the discussion period.
Yes, Dr. Dharmender, we will take the question answers at the end of the session.
We have time. We can take a few questions if we do have.
All right.
Or else we shall move to the next session.
Dr. Eberhard, your topic was very enlightening, and you made the complicated topic a little easier for us to understand. So now we know we need to correct the metabolism, we need to correct the vascular changes, and then we can give better results to the patients from point of view of the renal as well as the cardiac outcomes. So thank you for giving us a good talk, and if there are any topics or my co-chair is there, he can make more comments.
So I think so. I would like to invite Dr. Itamar Reyes for the next topic, cardiovascular and renal benefits.
Thank you for giving us a good talk, and if there are any topics or my co-chair is there, he can make more comments.
Yeah. So I think so. I would like to invite Dr. Itamar Reyes for the next topic, cardiovascular and renal benefits.
Thank you for giving us a good talk, and if there are any topics or my co-chair is there, he can make more comments.
Yeah. So I think so. So Dr. Raz, I think you can start with the things. I mean, cardiovascular and renal benefits with SGLT2 in type 2 diabetes. I'm not finding your introductory slide. And Dr. Dharmender, have you got that introductory slide, Dr. Raz? Yeah. Please unmute yourself, Dr. Dharmender.
Yeah, now slide is there.
Do you hear me now?
Fine. Yes, we can hear you.
All right, Dr. Raz. You
yes,
can start. Yeah.
Okay, do you hear me now?
Yeah,
yes.
Yeah, you are well audible.
Okay, thank you very much. I want to thank Professor Eberhard Stander for a wonderful lecture. And actually, it's a little bit a good opening to my own lecture. And I want to discuss with you what we have learned on the last 5 years on the effect of SGLT2 on the renal, mainly on the renal, and through the renal also on the kidney. And this is my disclosure. So on the last 12 years, many studies has been done according to the FDA request. And we have quite many studies related to SGLT2 that can teach us a lot about the effect of this drug on the heart, on the kidney, and on both of them. And we are well aware that hyperglycemia by itself can affect the heart, can affect the kidney, and that there is a strong correlation between the effect on the kidney to the effect on the heart, and on the heart to the kidney. So actually, it's not really clear what's the effect of each one of these organs on the other, but altogether, it seems that there are twins, and there are two that affect each other. Now, in diabetes, we know that there is an issue of natrium retention, hypervolemia, RAS activation, neurohumoral activation, inflammation, ischemia, and altered energetics, which can all be changed or prevented by SGLT2 inhibitor. So I want to start and my talk on the main three large cardiovascular outcome studies that have looked at MACE and cardiovascular death plus hospitalization for heart failure. And as you're well aware, actually we have three studies, one that were only in patients with established cardiovascular disease, one which was mixed, and the DECLARE, which was on very large population of patients with multiple risk factors, but without established cardiovascular disease. This population was also a much healthier population, since 50% of this population had eGFR more than 90, 45% have 60 to 90. So it was a healthy, so-called healthy diabetic patient with a mean eGFR of 86% versus 74% in the CANVAS and in the EMPEROR. And with that, we could find that the same thing that were found in the EMPEROR and later on in CANVAS could be generalized to a very large population with multiple risk factors and diabetes, or population with established cardiovascular disease. So the combination of cardiovascular death and hospitalization for heart failure, hospitalization by itself, or renal specific, prevention of renal specific outcome was very, very impressive in this population. And actually it was the same whether you have established cardiovascular disease or not, whether you had prior heart failure or not, and unrelated to your eGFR, showing that this drug, that this family of drug has a very robust effect on very broad population of diabetic patients. We have also demonstrated that the main effect on both renal outcome and cardiovascular outcome were related mainly to the effect on those who were fast progressors, those who tend to reduce their eGFR by more than 3 milliliters per year, and it was 32%. And we could show that the use of dapagliflozin have reduced it to 26.8% versus 37.1% in those who were on placebo, demonstrating that the main effect of this drug is in those who tend to deteriorate with their kidney function. Now, Eberhard have talked a lot about the mechanism, and it seems to be that the main mechanism by which SGLT2 improve or prevent hospitalization for heart failure or renal deterioration is related to its increase in hemoglobin through the increase in erythropoietin. This actually adds 50 to 75% to the effect of SGLT2 on both the kidney and the heart. And this was shown in different mediation analysis of EMPA-REG and DECLARE as well. However, there is also a very important sympathoinhibition effect that has a large importance in the prevention of cardiovascular mortality and hospitalization for heart failure. Now, I want to go over you on some studies that you already know, but just to summarize the whole spectrum. So one big study beyond those that I mentioned was the study about dapagliflozin in patients with chronic heart failure with reduced ejection fraction with or without diabetes, 4,744 patients with ejection fraction of less or equal to 40, with a story of heart failure and with eGFR of more than 30, randomized to either DAPA or placebo. And the primary endpoint, time to phase occurrence of the component of composite cardiovascular death or hospitalization for heart failure or urgent heart failure visit. And just to mention, 55% of them didn't have diabetes, although most of these 55, actually 35%, 37% had prediabetes, and no diabetes or prediabetes were seen in 18% of this population. And what was shown is that there was a great reduction in the primary endpoint in the intervention group of dapagliflozin with a number needed to treat 21. When we look at worsening to heart failure or cardiovascular death, which were secondary endpoint, again, very impressive effect, which was mostly pronounced in worsening of heart failure. However, was also significant for cardiovascular death and was also significant for all-cause mortality, which was very, very impressive. Now, it's important to show that the effect was similar whether you had or you didn't have diabetes, unrelated or not strongly related to your baseline eGFR and to other important parameters that were part of this patient. Looking at safety, there was a great safety as was shown in DECLARE and other studies on SGLT2, with renal AE lower with dapagliflozin and other major hypoglycemia were similar here, although we have shown that it's lower, and diabetic ketoacidosis a little bit higher, as we well aware of. Now, a similar, more or less similar study with the empagliflozin have demonstrated again significant reduction in hospitalization for heart failure in the combination of cardiovascular death and hospitalization for heart failure, failed to show reduction of cardiovascular death by itself or of all-cause mortality. So another two important study that I would want to go over with is the DAPA-CKD, and then to talk about other studies that have actually looking at the sotagliflozin, which is a little bit other kind of SGLT2, and look at different kind of patients. So looking at the sotagliflozin, in contrast to the other SGLT2 that we have mentioned, they have both SGLT2 and SGLT1 inhibition. And the question was whether this gave an additive effect to those drugs. And two studies have been done by my very good friend Deepak Bhatt, which I will want to go over with you. One is a study that looked at 1,222 diabetic patients, and the question was patients who were acutely hospitalized for heart failure and was discharged, half of them were started with sotagliflozin, half with placebo, either during the hospitalization or within 2 days after the hospitalization, and the patients were followed not for a very long time because the study had to be stopped because of financial shortcome, but look how impressive it is, just to show you that these patients were similar between the SOTA and the placebo, and that left ventricular ejection fraction were 35, and EGFR were around 50 in both of them. So kidney disease together with severe heart failure in both groups. And what you can see is a robust effect of the sotagliflozin to reduce the primary endpoint, which was total cardiovascular death, hospitalization for heart failure, and urgent heart failure visit. And this could happen at a very shortly after this drug were started. Actually, you can see that within 3 months, it was very impressive. Sorry, within 1 month, it was very impressive. Another study is the DAPA-CKD, and the DAPA-CKD, again, was done in both diabetic and non-diabetic. The main thing was EGFR 25 to 75, proteinuria of 200 to 5,000, most of them under ACE or ARB, with or without type 2 diabetes, and again, randomized. A primary endpoint was renal specific effect, and the secondary endpoint also looked at the heart. Now, as I mentioned, about 32% of them didn't have diabetes. If you look at systolic blood pressure, it was similar between groups. EGFR, mean EGFR was 43, and proteinuria was nearly 1 gram in both of the group. Most of them were under ACE or ARB. And again, a very impressive effect on the primary composite outcome, which is a renal specific outcome that was tremendously reduced with number needed to treat of 19. And if you look at the secondary component of cardiovascular death or hospitalization for heart failure, again, very impressive effect with small number needed to treat. And if we look at chronic dialysis, kidney transplantation, or renal death, again, 34% reduction and a very impressive effect, which is highly significant. Looking at all-cause mortality, 31% reduction, very significant. So we can summarize that if you take diabetic and non-diabetic patients with chronic kidney disease, EGFR 25 to 75 with proteinuria, you can see a robust effect on both renal effect and cardiovascular effect in those patients. Looking again at side effect, you can see the diabetic ketoacidosis were not really a problem, actually was higher in the group treated with placebo. Renal related endpoint was better in dapagliflozin. It's mainly acute renal failure, which actually is most of the time lower when you add SGLT2 versus placebo. Major hypoglycemia, much lower, as we shown in DECLARE. And let's look now at the other study. And the other study, in a way, it's even more interesting. And again, very short because of financial shortcome. And what you can see, the other study have looked at patients who had EGFR of less than 60, diabetic patient with EGFR, type 2 diabetic patient with EGFR less than 60. And those patients were randomized to either placebo or sotagliflozin and were followed for a relatively short time of 16 months. And as I mentioned, type 2 diabetic patient with A1C more than 7, EGFR 25 to 60 with cardiovascular risk factor. And exclusion was patient that start SGLT2 inhibitor. Now you can see here that the left ventricular ejection fraction was relatively normal. The EGFR again was low and was similar between the group, and ratios was relatively high, and other glucose-lowering medication in most of these patients. And again, you can see that if you look at the primary, first, if you look at MACE, total cardiovascular death, non-fatal MI, or non-fatal stroke, in a population that most of it didn't have established cardiovascular disease, there was a pronounced reduction of 23%, which was highly, highly significant. If we look at the primary efficacy, which was total cardiovascular death, hospitalization for heart failure, and urgent heart failure visit, this was reduced significantly already after 95 days by 30%. And just to mention, if we look at all the studies looking at SGLT2, we know that using SGLT2 at the beginning will reduce EGFR much more than placebo. And this put physician into a worry about the reduction of EGFR in patients with low EGFR. But if we look at all the different studies, including those in which EGFR was low, 44, mean EGFR, within 1 year, there was an improvement or an increase in EGFR to the baseline, to what was the EGFR in baseline, and thereafter, much better EGFR than with placebo. So if we can summarize, we can say that SGLT2 has a great effect to reduce hospitalization for heart failure and renal deterioration. And more than this, this was shown in the past in diabetic patients, now was shown also in patients without diabetes, both when we look at heart failure or renal failure over time. Now, this has brought many groups to recommend the use of SGLT2 as a first-line therapy together with metformin at a very early stage of diabetes. And recently, we have published in Diabetes Cardiology, the Israeli guideline that actually talk about simple guidelines. And these guidelines stress that beyond the fact that you have to improve your healthy lifestyle, which is very, very important, recommended to try and start using combination therapy of either metformin and SGLT2 or metformin and GLP-1 in diabetic patients at the time when they're diagnosed. Because we know that if your A1C is below 6.5 at the first 2 years versus those who have more than 7, more than 8, or more than 9, your prognosis within 10 years to reduce microvascular disease and also cardiovascular disease is high. We mainly recommend this combination because most of our patients will have mild renal failure with EGFR of less than 90, or heart failure, which is either silent or symptomatic. So combination of these two drugs at a very early stage of the patient disease will actually prevent deterioration of diabetes, but also will promise that in some of our patients, the prognosis and the outcome over the coming years will be much, much better. So with this, I want to thank you very much for being such a good listener. And I want to thank Eberhard Standal for a wonderful lecture that opened the door for my lecture. Thank you very much.
Thank you, sir, for very lucid presentation and enlightening the usage and efficacy of SGLT2 inhibitor for cardiovascular and renal benefit. Over to Dr. Rohit Kapoor for further proceeding. Any comments or suggestion or if any questions?
So I think so, Dr. Raz, you have really elucidated really fantastic. I mean, it's about this CV and the renal benefits. And specifically, I am very happy to see how the sotagliflozin is helpful in the SOLOIST and this SCORE trial. I mean, so I just want to ask you whether sotagliflozin is available with you in Israel?
I didn't understand your question. Is it about the sotagliflozin?
Yeah, is it? So I'm just asking you, sotagliflozin is available with you in your country?
No, it's not available, but
Okay.
sotagliflozin seems to have an extra effect because of the SGLT1 inhibition, and there were several papers to show the importance of SGLT1 inhibition. So I hope we will have it, but at the moment, I have no experience with this drug. I discussed it a lot with the Deepak Bhatt, who is the expert with this drug, and we still don't know whether it's really had an advantage of SGLT2 by itself, and only head-to-head study will give us the answer to that.
That's a really nice. But however, it seems like these two trials, like SOTA is going to really overscore even other SGLT2. But however, that's really fantastic. And we would like to thank you very much, Dr. Raz, for a really fantastic lecture, and would like to invite Dr. Bloomgarden now and the next speaker. And Dr. Bloomgarden is there, Dr. Zachary. Oh yeah, that's there. So he's going to talk on place of other oral OADs in the era of SGLT2. That's a really fantastic to hear from him, which, when, and why. And he's I'm introducing him, Dr. Zachary is a clinical professor, Department of Medicine, Mount Sinai Center, New York. He's a member of editorial board, ADA, and he's editor-in-chief Journal of Diabetes, and is an ex-board member, American Association of Clinical Endocrinology. And really, I invite Dr. Zachary and for a lecture on place of other OADs. Dr. Zachary, you are there?
No, sir, is not joined yet.
He is not there. All right. Okay. So, Dr. Dharmendra, then how to proceed? I think
We can have the discussion till
so we can have then some
start the discussion, right? And till we can just take the follow-up for Dr. Zachary is there.
So we can have some questions, I mean, then if we have got time. Dr. Vasan, what do you think?
Yes.
We can have some questions, I mean. With
So let's see whether there are any questions in the chat box. I don't find any.
Yeah.
I don't find any questions. So are we expecting the next speaker, or we have no idea whether he's going to?
Dr. Dharmendra, what do you think?
Yeah, just a while. Let me just ask and we'll update.
Yeah.
Maybe I can start. I have on chat one question relating to the role of BNP measurement in a patient where the echocardiogram already has established an ejection fraction below 60. So the diagnosis of heart failure and subtype is always driven by imaging. And the echocardiogram, of course, is the gold standard in that, and that's often a problem for the endocrinologist to get enough time slots for really doing all these echocardiograms. But in that case, the diagnosis already had been made. And for subtyping, whether this is more HFpEF or more HFrEF, the BNP measurement is not useful. In my mind, there are two major things. BNP measurement in a patient with some symptoms, shortness of breath, etc. If it's normal, then you can be pretty sure it must be something else. You have to go for perhaps a coronary angiogram or something like that. And if it's elevated, then it means you really need the imaging workup for the diagnosis. The other positive aspect is it helps you guiding also the appropriate therapy. You can see if you implement new drugs, and as mentioned, there are beta blockers, ACE inhibitors, and also ARNI, this naproxen antihypertensive drugs, and they are actually working only in GFR below 50. So the cutoff, and this is why the thresholds are moving up and down. So probably if it's below 50, then there's a good reason for using also ARNI in those who don't respond properly with earlier mentioned drugs. But if it is higher than 50, then you stay away. This is no indication. This is where actually the therapy is based on imaging. But to guide further therapy, it can be useful to take in also BNP measurements to see whether you will get a reduction what you have implemented in terms of therapy.
Yeah, Eberhard, if I can add, first, thank you for your lecture. If I can add several things. One is we have shown in DECLARE and in other studies that SGLT2 has an effect also in patients with preserved ejection fraction. So we are waiting now for the studies, but most probably this drug has an effect not as robust, but also in patients with preserved ejection fraction. Now, I think with the studies that I have shown, first we have shown that if you have microalbuminuria or low eGFR, or the combination of them, you're at a very high risk that SGLT2 can diminish. This is one thing. The other thing is that what Deepak Bhatt have shown, actually, if you have eGFR less than 60, then the effect of this drug can be robust. This was shown for sotagliflozin, but I believe it's a class effect.
Yeah.
And my question is whether we should use BNP so much. We did a score that have shown that when you use BNP, you can see who are those who will mostly benefit. But if you think about it today with SGLT2, why not use this drug at the very early stage of patient disease, if this is possible, if there's no side effect, knowing that many times we have silent heart failure, and there were studies that have shown that in patients with normal ejection fraction, you can show by a more accurate measurement that they do have some heart failure, and if you follow them over several years, it will come. So there is so much that we don't have. I think that today, most of our patients, no question, those with eGFR of less than 90 or 75, or those with any sign of microalbuminuria or any other sign that they might have heart failure, should we use SGLT2 as a first-line therapy together with metformin? And I want to hear what you think about it.
Well, in terms of the indication for SGLT2 inhibitors, I wouldn't rely on the ejection fraction. I think we are going today for the cardiometabolic approach in those high-risk people, and we are trying to make really a change in the disease course by using those drugs early. Now, one point came back to me, what was quite interesting in your talk, Itamar. I enjoyed it very much. Your presentation, you're always so knowledgeable. And that is the hematocrit goes up by 4 to 5% with any of the SGLT2 inhibitors. Now, you pointed more, this would increase the oxygen transport capacity. But as you know, I'm also an angiologist, and this increase of hematocrit means you have a contraction of the circulating fluid in the blood vessels. And this relates to around 300 to 40 millimeters. So close to half a liter, you are contracting the intravascular volume. So if you're really at the brink of tipping over to developing heart failure, this is probably quite useful then to come in with an SGLT2 inhibitor, and this probably will delay the onset of frank heart failure. So in terms of ejection fraction SGLT2, I stay away to make a point only for those with a reduced fraction. And I'm not sure of the mechanism, but in my mind, it's really the volume which is the critical thing. And I try to say the heart speaks to the kidney via the volume, the preload and afterload, and also vice versa. So this is really a major difference. 300 to 400 millimeters, that's really a good number.
Right, right. Actually, mediation analysis also have shown that hyperglycemia or hemoglobin A1C has not a very significant, but has an effect on hospitalization for heart failure, for example. But the most important one was actually hematocrit, uric acid, and neurohumoral effect. I didn't mention uric acid in my talk.
I think listening to both of the professors, one thing is very obvious that there is so much of interrelation between the kidney disease and cardiac, what we call a heart failure. And both of them are directly related to the metabolic defects, the vascular abnormalities that they take place, probably the lipid abnormalities. So it comes back to the same point that the primary prevention can be done if we handle all the issues. And Professor, the one you mentioned about the role of ejection fraction, how important, how difficult it is sometimes, how much can you really correlate with an EF with the patient. Now we are talking about heart failure, we are grading it. If you're talking about the stage or grade, there can be a lot of asymptomatic heart failure patients where we still brand them as heart failure. And one of the points that always intrigues me is that should we continue to use the word heart failure? The word failure creates such a devastation to the patient. We stopped using the word renal failure now. We don't say end stage renal failure. The word, once you use the failure, it creates such a kind of a havoc to the patient, that he feels as if the heart has failed. And you are using that terminology exactly to an asymptomatic person who almost has a normal EF. And if we control well, probably look at his renal disease, I'm sure we are doing enough of advantage giving him to. So are we sometimes overplaying on these factors is my point.
Sir, may I have one comment, please?
Yeah.
I fully agree with you. And so most of the time on our side, we label it as LV systolic dysfunction or a diastolic dysfunction. I totally agree with you. And I have one question for Dr. Eberhard. Do we recommend SGLT2 inhibitors for patient having diastolic dysfunction? Because most of the data which we have is suggesting its role in patient with reduced ejection fraction. So any comment on patient who have preserved ejection fraction with diastolic dysfunction?
Well, we are still all waiting to really get the results of the ongoing outcome trial. So it's speculation what will be the outcome of several trials. I would be more optimistic to some extent that we will also see a benefit in terms of HFpEF, people with ejection fraction running up to 70 or 60, something like that. And mainly due to the reason I tried to point out, we have this fluid contraction making life easier for the heart and also making the feedback to the kidney less, so we will get less retention of sodium and fluid. So in the long run, I think those drugs are very, very useful also for HFpEF patients. But of course, pending what are the real results, we will see probably within one year from now.
Right, Eberhard, if I can add shortly, we have shown in DECLARE, although it was not very accurate, but we had 5,000 patients who had an echo. And we have shown that those patients who did not have reduced ejection fraction of less than 45, so maybe some of them had 50 or something, but most of them were normal, and had a 12% reduction of hospitalization for heart failure under the treatment of dapagliflozin. So I believe it will work in patients with diastolic dysfunction as well, although it will not be so robust or so effective. But you're right, we have to wait and we have to see it in those studies that are now going to be published very soon for both the dapagliflozin and the empagliflozin.
Well, of course, also for the EMPEREC, John Lakin has done this mediation, and he finds really the positive heart failure effects also driven by the impact on the kidney. So again, you know, this vicious circles I was trying to sketch up for you, it really works both ways. And so probably by the impact longer term to the kidney, if you don't have too much structural changes of your heart, you know, if it's really severely ischemic, and then it's very complicated. But say you have a recent circulation, then I really would expect to see benefit in HFpEF with SGLT2 inhibitors.
Right. In our case, the benefit was in spite of the fact that the patient had a mean eGFR of 86 and only 7% have less than 60, and yet we could show that. So, but let's wait. Let's wait and we'll see.
Well, it's good to have more meetings, and perhaps we can meet face to face. Why not in Israel or perhaps in Bangalore?
Professor Eberhard, a meeting with you is always a joy, and I remember a meeting together in Dubai, in Abu Dhabi, not long ago.
So one thing, Dr. Eberhard, I just want to ask you just one thing more. Out of all these three, SGLT2, AMPA, DAPA, and canagliflozin, how do you choose? I mean, that injured diabetic patient type 2 DM, and these three, they are in front on your table, and which you are going to give to your diabetic age around 60 years, type 2 DM. How you are going to choose these three out of these three, which you are going to add it? Yeah.
Is the question to me or to Eberhard?
I think any of you, because you both are specialists. Yeah, both are experts.
Okay, Eberhard, you start shortly and I'll follow you.
Yeah,
so I'm not totally sure if I got your point. What choice you're making for the drug?
Yeah.
Well, of course, it's always a matter of experience, and so we had dapagliflozin for such a long time. Also Germany, so you know, the majority of my patients, which I'm still seeing, have started with that, and there was no reason for a change. Of course, you have other people that were so impressed coming with a printout from the internet about the EMPEREC trial, so if they want Jardians, I don't really think it makes a difference. But to be honest, my largest experience is with dapagliflozin, and I think it also offers this wealth, especially the DECLARE TIMI trial, where a large proportion don't really have prior cardiovascular disease. So you are in primary prevention, so to speak. So this is the best evidence we have when we are aiming in patients for primary prevention. And again, you know, these puzzling findings with the heart failure trials, DAPA heart failure, that those without diabetes benefited to the same extent. Probably it's the same mechanisms in inflammation and this fluid contraction of course, those are working independent from diabetes. And also when you see CKD, DAPA CKD. So I think there's a good position to go for drugs where you have a large experience and also very good study evidence.
Yeah, I agree. So I don't have anything to add. I actually use both, but I also use much more dapagliflozin than I use empagliflozin. But you know, nothing to. I mean, I can explain why, but I think at the end of the day, it's a class effect. I think those drugs are similar. I think their effect is more or less similar. Also, when you look at SGLT2 inhibition, it's very similar between those two drugs, between the dapagliflozin and the empagliflozin. So the canagliflozin is a little bit different, but we don't have it in my country. So I would prefer one of the two, also because of safety, also because with the canagliflozin, there was some question that were raised about peripheral artery problem.
Amputations.
Right.
Amputations.
Right. So I would prefer, but between the two, my feeling is that at the end of the day, it's similar. And even those, for example, the DAPA heart failure was much better with dapagliflozin than it was with empagliflozin. But you know, this can really be by chance. And I mean, so I use more dapagliflozin just because of this data, but I believe it's a class effect. I believe they are more or less similar. And whenever you look at different mechanism that was looked for, it's so similar between the EMPA and the DAPA. Everything that was checked for the EMPA and for the DAPA actually came the same. So I think they are very similar.
And of course, Itamar, let's not forget, you have to believe in your wonderful declared TIMI trial where you are the principal investigator. So
right.
You know, if you're really through such a long-term process, you really gain confidence in this kind of
right. Thank you, Eberhard.
Yes, one thing is clear that the introduction of this class of drug, SGLT2 inhibitor, has changed the way we practice. And every guidelines now is putting emphasis on using after metformin either SGLT2 inhibitor or GLP-1 receptor agonist. In our criteria in India, particular Asian patient, we have seen that sometimes they are responding more in the terms of weight loss. They are losing weight around 10, 15, 20 kgs also few of the patients. Now my question is, one of the patient with diabetes who is on metformin and some SGLT2 inhibitors, he has achieved his goals. Is there any point of the time when we will think of to down titrate the patient, or what are the criteria you will look into when you think of down titrate the patient, particularly for either SGLT2 inhibitors?
Yeah, Eberhard, you want to answer or should I answer?
Oh, start.
Okay. Okay, so I think it's a very good question because, you know, patients with prediabetes are already at a higher risk for heart failure. If you look for what Eberhard mentioned before, 50 to 70% of patients with heart failure have either prediabetes or diabetes, and you've shown that also in the DAPA heart failure. So the only thing is that we've never shown that. I mean, we forgot the need. We forgot the need to prevent diabetes, or we forgot the need to treat diabetes very aggressively from the moment we diagnose it, because we know that combination therapy will be very important also to prevent deterioration of your hyperglycemia. Not to mention that in some of those patients, there are already microalbuminuria, hypertension, and other things that will put them into a higher risk for renal deterioration and maybe heart failure. So I think that, I hope that in the future there will be studies that looked at the effect of combination therapy of metformin and SGLT2 in patients with prediabetes to show the cardiovascular outcome. On the other hand, if you take patients without multiple risk factor, just with prediabetes and 1 or 2 multiple risk factor, to show an effect, we'll need a very large study, larger than DECLARE, longer than DECLARE. And I don't see the drug companies are doing it. So, Eberhard, what do you think about it?
Well, in our country, we don't have an indication for SGLT2 inhibitors preventing diabetes. That is, you know, a legal aspect. And I understand, of course, I've seen patients using it for this purpose, you know, that they have family history. One time the blood sugar was up and then they're, you know, taking this, but this is clearly off-label therapy. But what I was trying to point out during my talk is that these vicious circles are operating also during the stage of pre-diabetes. You know, I showed on one side, heart failure risk is already up 50% during pre-diabetes because of insulin resistance is a major driver for heart failure in combination with probably the shifts in fuel for the heart, which I was trying to point out. And similar also, as we showed in our Munich GP study at manifestation, we have so much already early kidney disease in terms of micro and even macro albuminuria. So this is all before we make the diagnosis. So it makes good sense for good medicine. But you know, I'm sorry to say we don't have the indication for this in pre-diabetes.
Not yet.
Yeah, let's wait. But in Germany, we always think this is a lifestyle issue, and everyone has to look into his own lifestyle. So
It's
they
true.
don't want to pay for this type.
And it's true, there are more and more studies recently on the last several years about how important lifestyle it is. And I think in a way we forget it.
No.
And we have to put it as the first thing that we do with our patient, not just talk about it, but see that it's happened.
Yeah.
Thank you. And one more clinical relevant question which I just got from the social media. It's regarding young adult patient who is having HbA1c between 7.5 to 8. Now the concern is in what case particular we will go for after metformin SGLT2 inhibitors or after metformin DPP-4 inhibitor. Is there any significant or any clinical parameters or any other parameters you will look upon to choose after metformin in some patient, young adult without any comorbidities, either going for SGLT2 inhibitors or DPP-4 inhibitors? Would like to have your expert comment from this.
Well, I will start, Eberhard, because what we have shown in DECLARE and also in other studies is the very high safety of SGLT2 in the very old people. In our case, patients with the age above 75, we have demonstrated the reduction in hypoglycemia, a very, very safe drug altogether. Now, in cases where it's not safe, in cases where your patient uses 4 injections of insulin and you cannot follow him so well, in cases where you don't want to give this drug because of its genital effect or any other thing of that, then I will take the DPP-4. But I think today, with the advantage of this drug on reduction of blood pressure, reduction in weight, and reduction of hypoglycemia, only in cases when I don't want to reduce weight, cases where there is a side effect that I'm worried about, then I will use DPP-4. But today, in 9 out of 10 patients, we will start metformin and SGLT2 and not DPP-4. And in some of the patients, we will either add the SGLT2 or replace DPP-4 by SGLT2. For example, if those patients have any other sign of renal deterioration, any sign for heart failure, any sign, even for microalbuminuria and renal, it's much more effective than DPP-4. It's true that DPP-4 also prevents microalbuminuria, but it's not as effective. So in most of the cases, I will use SGLT2 today and not DPP-4. Now, next year, DPP-4 will not cost money. So in places where budget is a big issue, and maybe we should change the way we think. The great advantage about DPP-4 is the very high safety margin and no side effects, mainly when you give it to old people. Eberhard, you want to add to that?
These are all very wise words. I will echo, yes, there's still an important role for DPP-4 inhibitors in treatment paradigms. Of course, I'm also a fellow of the European Society of Cardiology. They actually have launched guidelines to start this cardiometabolic approach even without metformin. So they go first, you make the diagnosis, established organ damage or very high risk for, then the decision, what SGLT2 or GLP-1, but they go without metformin. And my point is, we must not lose sight also on reaching recent metabolic control, which we need to define in terms of personalized A1C. And in fact, when we start already with more advanced kidney disease with an SGLT2 inhibitor, the glycemic effect of SGLT2 inhibitors is very little. So if we really got down to what we consider the right range below 7%, is you need early combination with something else. And the safety, they're very appealing in terms of the gliptins. And so I think sitagliptin, also saxagliptin, there's a little difference in terms of this heart failure aspects, but other than that, they're very useful also in this combination. And I'm still an advocate going for reasonable glycemic control in our patients. And it's interesting, I think we will hear more at the ADA. There's a publication right now in the Weekly Journal that considering the development of therapy in the US based on there is actually worsening of metabolic control in the US over the last 5 years, along with a shift to SGLT2 inhibitors and GLP-1 receptor agonists, but also along with a decrease in the use of insulin. So, we rightly emphasize this cardiometabolic therapy now, but we must not lose really the sight on the importance of metabolic control, which I tried for renal disease, but also for other microangiopathic disease. It's still very, very important.
Dr. Meena, you are muted.
I have a question. What about patients with lower urinary tract symptoms? Patients with benign prostatic hypertrophy with urgency, frequency. Is it safe to use this drug? Question number one. And second, Indian patients are more sarcopenic because we eat low proteins, basically vegetarians. Is it safe to give a drug? So it's not age, it's sarcopenia, which will, so I have patients who are sarcopenic and then there might be fall. So should I be using? And also, what about patients of lower urinary tract symptoms?
So it really depends on the patient, and I agree with you. In a sarcopenic patient or in patients with the BMI of 23 in my country, it might be 21 in your country, I would be very, very careful, and I would ask myself, do I want to give it? Benign hypertrophy of the prostate, it really depends on how severe the symptoms are and whether we can get over them with the usual drug that we use. So, and in women, many times we see genital infection that bothers them a lot. So it's medicine. I mean, in general, it's a very good drug. In general, It has a high safety, including, for example, in my country, people are afraid, doctors are afraid, when the EGFR are 35 or 40, to give this drug because they're afraid that you'll go to dialysis, and you know, primum non nocere, you don't want to do that. But in general, from the data that we have, it's a very safe drug. And as Eberhard mentioned, and I mentioned again, and we mentioned in our guidelines that were just published in diabetes cardiology, I recommend you to read them because they are simple, they are straightforward. And one of the things is that we want to keep our new diagnosed patient at A1C 6.5 or less than that. And I against the cardiologist that says don't use metformin. I think they don't understand what they're talking about, because metformin is a very good drug. Okay, I urge you to write the publication by Stefano Del Prato and the group in diabetes care in Merch. I don't remember the exact page, but look under Stefano Del Prato and the Glucophage and see what important drug it is. And we have enough data today to show that if you start with combination therapy at the very early stage of diabetes, you improve tremendously the deterioration of hyperglycemia over time. And lots of those studies were done by DiFronzo and Muhammad Abdulghani. So why not go back when we have such a good drug, such a safe drug, and the only importance is the cost. The only important to my mind, the only problem to my mind is the cost.
Doctor, we see more genital infections in India, and being a woman endocrinologist, how many times should I stop, give local application and antifungal restart? Should I do it twice in the lifetime of the diabetic women, or should I do it more often, is my question. So she develops a genital infection, I stop, give her local antifungal or an oral antifungal and restart, because she's very keen to restart because she knows her weight and other issues with sulfonylureas. So how many times? Because in India, at least in my practice, more than 10 to 15% of our patients develop genital infections in women because of the weather conditions. It's very warm and moist. And also due to, maybe related to vaginal hygiene from the rural areas. So how many times should I restart, or should I give up now? No.
Yeah, first, it's not so often. I mean, it's around, in women, it's around 3%, but there are some women who have known genital infection from antibiotic and so on. The risk is much higher. And it also depends on the women. How bad it is, how strong it is. Can it be easily cured by antifungal cream? Does it come again and again? It's also dependent on the women. Most of the time when I see it, I stop it after 1 or 2 times because I suspect. One thing that I found, that if you give a very low dose, if you have a woman who has genital infection, and she insists of taking the drug, or she likes the drug, she wants the drug, then you can give half the amount of either Jardiance or Forxiga, 5 milligrams. Many times it will do the job without causing any side effect. I see it also in type 1 diabetic patient. I don't know if you give it in type 1 diabetic patient in your country. I do give it here in Israel. And when we do that, sometimes in women, we go down to 5 milligrams and we have a much better, we have a good response without the side effect.
Well, perhaps one thing that Dr. Mina just has gone. She asked about sarcopenic heart failure patients and whether or not one can give SGLT2 inhibitors. Now, if you look at that, this is a very high-risk population, and they have high BNP, but BNP, let's forget that, stimulates also adiponectin. So the surprising thing in these end-stage sarcopenic patients, adiponectin is up very, very high, driven by the BMP release. So you can actually intervene this vicious circle when you get in with therapy with an SGLT2 inhibitor to reduce the BMP, and this should then reduce also this aspect in terms of sarcopenia. But these are critically sick people without question. But long answer, short question is yes, I would also use it in sarcopenic patients with caution. I would watch what happens, but I don't see a contraindication for that. Maybe beneficial that you get really better body weight situation, better balance with the use of the SGLT2 inhibitor.
Sir, I have one question. What should be our strategy in a perioperative management of the patients who are on SGLT2 receptors? Any precaution, or should we stop SGLT2 receptors in a patient who are undergoing major surgery?
I'm not sure if I really got your point. Can you?
Patient who is already on SGLT2 receptors,
yes,
blockers, and has to undergo any non-cardiac or any major surgery, do we discontinue SGLT2 receptors, these medications?
Well, because this is a long, deep debate. Milton Packer in the US is an expert on that. He also makes a point at the heart level, especially in heart failure patients. This should be a problem. And there are also this sodium hydrogen exchangers where you get indirect effects by using this SGLT2 inhibitors. But I think it's a lot of theoretical discussion. I'm not really the expert on that.
Okay.
Thank you, our respected speakers and respected chairpersons, for giving your esteemed time and your expert insight into the topic and making this symposium complete and fruitful. Would like to just call upon my friend Dr. Mahira for the next symposium on pediatric diabetes. Over to you, Dr. Mahira. Should we move towards the next symposium of Diabetes India, Pediatric Diabetes Symposium?
Thank you, Dharmendra bhai. Yes, we can. I guess we have both the chairpersons, so we can move towards it. So good evening, everyone. I welcome you all to the ISPAD Symposium. And without wasting much of the time, I would like to invite Dr. Anju Virmani ma'am. She's the endocrinologist from AIIMS Hospital, Delhi. And Dr. Ganesh Javalikar. He's from the Pediatric Endocrinology Department, New Delhi. So it is good to see you, ma'am. I welcome you both to the symposium.
Thank you so much, Mahira. I trained at the All India Institute of Medical Sciences. I'm no longer there, but it's a lovely feeling to be back in this group. Diabetes India has a very special place in our lives because it's doing a lot of work with type 1 diabetes, and even in this meeting, it's had a huge impact. And it's always good to work with Banshi, with whom I had co-chaired the Hyderabad meeting. So it's very nice to be able to chair the ISPAD Symposium, a great honor and a great pleasure. And we have absolutely spectacular speakers today. First of all, I would like to welcome Dr. Graham Oble from Australia, who will be talking about levels of care in type 1 diabetes in children and adolescents. Graham has headed HOPE for 19 years and then has headed LFAC, which is Life for a Child, since March 2000. LFAC's mantra, of course, is no child should die of diabetes, and Graham is a perfect example of a person who can carry that mission forward so effectively across continents, across so many families. He's also an adjunct professor at the University of Sydney. So without wasting more time, let's listen to Graham on this very important topic. Welcome, Graham.
Thank you very much, Anju. Can you hear me clearly?
Yes.
And I'll just share screen. And can you see the first slide there?
Yes, it's a lovely slide. Thank you.
Excellent. Good. Okay, thanks. Yes. Okay. So this is a picture actually from Sri Lanka as part of a competition we did with the children a couple of years ago. So greetings from Sydney, Australia. My name is Graham Ogle, as Andrew said, and I manage the Life for a Child program here. I'm delighted to join you this evening in India. I wish I could be there in person, but travel restrictions don't allow that quite at present. And I'd like to thank Abanshi and all the people in the organising committee for inviting me to speak to you tonight. And the title of my talk is Levels of Care for Type 1 Diabetes in Children and Adolescents. Now, I think we all know that managing type 1 diabetes in children and youth is not easy. And these children are constantly walking a tightrope. And I think sometimes as the parents and the clinicians feel the same way. This is a picture drawn by a young fellow in Bolivia. And we know that they need supplies. They need insulin, they need syringes and pens, they need meters and strips and lancets or CGMs and flash glucose monitors. They need ketone testing, they need glucagon, etc. And they need clinical care and monitoring. So they need HbA1c or CGM metrics and emergency care and complication screening. And I think sometimes we think it stops because we're doctors, we think it stops there. But there's a lot more that they need. They need ongoing diabetes education, which is tailored to age, comprehension, language, culture, and social situation. And they need psychosocial support. And this will be different at different ages and at different times in their life and their experiences, but they need peer support. Diabetes camps and education days are of great support. And at times they need counseling and advice. So I think the question is, how do you manage a costly, complex disease when there are limited resources available to most families who have a child with diabetes in a country like India? I realize that there's some families that are well-resourced and some services that are, but many families are not so well-resourced, or the service isn't so well-resourced. And I think this quote from a fellow in India in the same competition that I talked about expresses the challenge, the emotional and financial challenge and strain on the family for a child with diabetes. And I think as clinicians, we face a dilemma because there'll always be newer, better technologies. There'll be newer insulins. Even now, there's longer acting insulins coming out. There's shorter acting insulins coming out. Inhaled insulins there. And there'll be fancier insulin pens. There'll be newer pumps, newer models of various brands of pumps. There'll be more and more closed loop devices. There's dual hormone pumps, insulin and glucagon. There'll be newer CGMs. There'll be newer Libres, newer Dexcoms, newer Medtronic CGMs. The Eversense technology from Senseonics, where the CGM is implanted under the skin. And there'll be newer devices and methods. There'll likely be many more of these. So I think a question we have to ask ourselves when we're talking to families or talking to governments is, how much do these cost and how much do they help? Now, what is the goal? Well, I thought about this a couple of days ago when I wrote these slides, and I expressed it this way. People would express it different ways, but to me, the goal is that we provide care so that the young person with diabetes can learn to self-manage their diabetes and lead a full life without impairment of their education, recreational activities, relationships, employment, and quality of life. And we want to prevent long-term diabetes complications so that they can live a healthy and long life. So as part of our thinking with this in Life for a Child, we've developed a concept of levels of type 1 diabetes care in children and adolescents. And this was published in Pediatric Diabetes a couple of years ago. And we defined three broad levels of care. And I'll go through these in a little bit more detail, but the first of these is minimal care. The second is intermediate care. And the third, when it can be afforded, is comprehensive care or ISPAD guidelines-based care. So firstly, talking about minimal care, this is when they're on human insulin, but fixed doses each day. The blood glucose monitoring might be only at the clinic, like an example I'll show you in a second, or it might be just 1 or 2 tests in a day. A1C may or may not be available. Complication screening is not really done. There's minimal diabetes education. And you can see the outcomes are pretty dreadful. The HbA1c is high, 12 to 14, and the complications rates are high and the mortality rate is high. And this is a quote again from a boy in India a few years ago, which I think is minimal care. You can imagine this is from a child specialist, but the treatment was 7 units of Mixtard twice a day. He got his blood glucose checked once a month. So how are you possibly, who would know what his blood glucose level is doing? And what's worse is that the doctor was injecting the insulin. And so you can imagine the cost to the family of doing that. And then he moved on to another center where he got excellent care. And so we talked about minimal care. The other end of the spectrum is comprehensive care or guidelines-based care. And here you've got analog insulins and pumps and pens and moving up to a closed loop system. You've got point of care A1C testing, full complication screening, comprehensive diabetes education, and the full team with a dietitian, a social worker, and a psychologist. And here the outcomes are good. And remember, the target is less than 7.5% or even less than 7% if you have a highly resourced clinic. And the mortality with this is very low, and long-term complications are very uncommon. Now, we had to think about in Life for a Child about what we would like to encourage less resource settings to do. And we came up with the concept of intermediate care, which is human insulin or analog if you can get it. But most importantly, it's given in multiple daily injections where it's titrated to the amount of food that's eaten and the exercise and everything that's done. You have blood glucose monitoring at least 2, preferably 4 or more times a day. Point of care HbA1c testing, a simple complication screening, but picking up the things that are most important, good diabetes education. And with this care, these are sort of clinic means. You can achieve clinic means in the 8s or low 9s, depending on the setting. And mortality is much reduced, and complications, long-term complications are reduced as well. And this is a quote that I like that came from the VDOR International Study Group, which really led to the SWEET initiative. And if you look there, it says, be dogmatic about outcome and flexible in approach. Now, in other words, the outcomes are important. That's what we have to be focused on. How are these kids doing with their A1C and other metrics in their life, and also their psychosocial status? And it doesn't really matter how you do it. Different clinics do it different ways. They might have different staffing. They might have a different approach. But so the outcome, the approach might vary, but the outcomes are critical. And so we did another study where we compared the costs and outcomes of intermediate versus minimal care. And we looked at 6 countries: Azerbaijan, Bolivia, Mali, Pakistan, Sri Lanka, and Tanzania. In this study, we didn't do India, but I think you could imagine India in terms of its GDP and resources sitting a little bit higher than Pakistan, maybe around Sri Lanka's level. And we compared minimal care with an A1C of 12.5% and intermediate care with an A1C of 8.5 or 9%. And we worked with the University of Pittsburgh and looked at 30-year complications data. We put it all into a mathematical model and looked at costs and mortality and disability-adjusted life years and healthy life years. And I think this is a key slide here, that these are the results from the Pittsburgh data. And there's 6 complications listed, but I just wanted to draw your attention to 2, to blindness, which is in green, and to renal failure, which is in blue. And if you look at 12.5%, an A1C of 12.5%, which persists over 30 years, and you look at the green bar, most of them are going to be blind, and most of them are going to end up in end-stage renal disease where they need dialysis or a transplant. But if you can reduce that even to 9%, you can see that the 30-year risk of blindness and of kidney disease is much, much reduced. And it's further reduced at 8.5%. Now, yes, we want to be getting down to the targets, but there's targets and targets. In Australia, not everyone hits the target, but you certainly don't want to have kids and adolescents and young adults up here. And we modeled this with the Pittsburgh data and SMRs allowing for different countries. And we looked at survival rates. And not surprisingly, the 30-year survival rate was much improved for for intermediate care versus minimal care. And I won't go through this, but we looked at the costs. We looked at the acute complications costs and the chronic care costs, the ordinary costs, the maintenance with complications. We added all those up. And then the WHO have a metric called where you express the cost of a healthy life year using a particular treatment regimen against the GDP per capita. And anything below 100%, anything below the GDP per capita is a very effective intervention. And you can see that for Pakistan and Sri Lanka, for instance, it was substantially below the GDP per capita. In other words, this is not only a sensible thing to do, a good thing to do, a moral thing to do, but it's also a cost-effective thing to do, which is helpful when you're talking to governments. It's a good thing to do, but you can also tell the governments you're going to save money if you do it. And so how are we encouraging families to spend the limited money they have? And what should we encourage the government to provide? What helps the most? Now, is it analog insulins? Now, I know insulin's probably cheaper in India, I think, to buy over the counter than possibly any other country in the world, which is great. And that's a function of market size and the fact that you have some local insulin producers as well, which is tremendous. But analog insulins are still more expensive than human insulins. Do they improve HbA1c? Well, they don't. People have tried, people have studied this, but every systematic review that comes out says, no, they don't. Do they reduce severe nocturnal hypoglycemia in young people with type 1? Yes, they probably do. There's reasonable evidence for that. Do they improve quality of life? Well, the studies haven't shown it, but the patients do like them. And I think in the end, I believe the patients because they do like it. But there's not, considering the cost, it isn't a huge benefit. What is more important is blood glucose monitoring. And this is the data from the T1D exchange in the US. And this is the x-axis shows the frequency of self-monitoring per day from almost no testing through to 13 or more tests. And in all age groups, both for pumps, people on pumps and people on injections, the A1C improved each time as you did more blood glucose monitoring. And now, of course, we have CGM and FGM with many more readings that are possible. And they do show an added benefit on top of frequent self-monitoring of blood glucose. So the insulin's important. You've got to have the insulin to survive, but the type of the insulin, as long as it's a multiple daily injection, doesn't matter so much. It's the blood glucose monitoring, which is more important. And also diabetes education. And I'll just let you read these couple of quotes from families in Bolivia in a study that we did there. And just for how the families are scared, they're frightened, they don't know, but they go to a clinic, and this is a multidisciplinary clinic, and they learn. And then they have confidence to go on and they can encourage other families. So what is needed? As I mentioned, an insulin regimen with basal bolus or multiple daily injections is needed. Now, if the family can afford it, use pens. But remember, the cartridge insulin is more expensive. If the family can afford it, use analogs, as long as the blood glucose monitoring is adequate. If they can afford it, use a pump, but as long as the blood glucose monitoring is adequate. If I had a preference between a pump and CGM, I would go for CGM every time as in advice. For blood glucose monitoring, it's essential at least a few times a day using meters and strips. You need to do the A1C, and then CGMs and FGMs give a whole new dimension with far better metrics than A1C if they can be afforded. And diabetes education, including carb counting, so the family and the young person can learn to adjust their insulin themselves, is essential. The more, the better. And we have to remember, don't be doctor-centric. Nurses are important. Other health staff are important, like social workers and psychologists and dietitians. Don't think you know it all, because you don't. But they know. These are experts in their area, and they can add so much. Now, Life for a Child has on our website, we have education resources in many languages, including some of the Indian languages you can see here, Kannada, Marathi, and Hindu or Hindi. And we're very willing to put up more languages. If you've got resources that in any languages up there or any other languages, and India has a number of major languages, as you know much better than I, then please send them to us and we'll make them available. And if you are interested in making or producing more resources or making them more available that are in languages used in India, then please let us know. In conjunction with ISPAD, we've scaled down the ISPAD guidelines to pocketbook guidelines, which are very useful for sort of intermediate level doctors and doctors who don't see pediatric diabetes all the time. And they're readily available. Let us know if you need some copies, but they're on the internet as well. And I think in-country resources are very important. And this is a book from Haiti and another book from Bangladesh. And developing materials that the children enjoy that's tailored for them is critical. And this is a resource that we're just about to launch. It's a carb counting resource. And this has been done in conjunction with ISPAD. And Cheryl Sellis, who some of you will know, she's an amazing dietitian in Mumbai, has worked with us extensively on this. And you can see that the first edition that we're doing of this is on Indian foods from all across India. And there's many different foods in India, as you know. And so the Indian one is the first one. It'll be released most likely within about 6 weeks. And then we'll be able to do ones for other parts of the world as well. Peer support is critical. I just want to show this picture. This is the Tanzanian Diabetes Youth Alliance. They keep in touch on WhatsApp, and these groups are very important. So going back to what this statement before, be dogmatic about your outcomes. They're the important things. And so that opens up the question, what are your center's outcomes? Because good outcomes are the goal. So do you know your outcomes? What is your average HbA1c? What are and other important measures? So it's important to measure them and then compare them. And I'd like to support all Indian centers that are able to join the SWEET initiative. And many of you are involved already. This is coordinated by Mahira and Banshee and the team at DiaCare in Ahmedabad. And it's a super helpful initiative to improving care. Because remember, going back to the complications, remember you want to be down on this level or even lower, preferably, have a clinic mean in the low 8s or even lower if possible. But certainly not be up here, be getting down into this range. And this is data that we've published. Well, this blue line is American data. And you can see the Americans they're not doing it's not great data, actually. Australia is not too much better than this, actually. Some of the European countries are doing better. But I think what our centers have achieved in Bolivia and Mexico is very similar to the US results, despite it being intermediate care, which shows that if you have the right team, a dedicated team, and good education, you can achieve similar results to very high levels of care in less resource places. And this is part of the SWEET data. And each of these bars is a clinic. It's not an individual trial, it's a clinic in different countries. And if you join SWEET, you'll have a bar in there, and then you can see where you are, and you can think, well, I need to improve, and you can imitate others within your country and outside, and learn how to improve, or maybe you'll be helping others improve as you go along. And finally, I wanted to just talk about what Life for a Child's doing in concert with the 100th anniversary of the discovery of insulin. In the next 10 years, we're planning to increase the number of children and youth helped from 23,000 to 150,000, and increase the numbers of countries helped from 43 to 65. And we'll be able to expand our footprint in large countries such as India, to help in new countries, like for instance in Djibouti in Africa, we're just about to start helping there, and to deepen support in all countries help with more education, training, improving quality of care, and research and advocacy. And this expansion is being done with support from Eli Lilly and the Helmsley, I've spelled Lilly wrong there, but Eli Lilly and the Helmsley Charitable Trust, and also JDRF. And that includes insulin, including access to long-acting analog insulin for the first time, and also reusable pens. And Lilly will also cover the cost of storing and packing distribution of the insulin, and help with other projected costs over the first 2 years at least. And for India, we intend to expand the numbers of centers we're helping, as I mentioned, to support the development of and distribution of education materials, helping centers for joining SWEET. There's a study underway despite the COVID epidemic. It's almost finished actually in terms of the collection on the thermostability of insulin at the Dream Trust with the Doctors Penzi there. And other studies in India are planned with local partners on epidemiology and also the impact of flash glucose monitoring. So in conclusion, be thinking about the costs and benefits for the family and the health system. What is cost effective? It isn't just about newer insulins and delivery devices. It's all about blood glucose monitoring, education, and self-management. So be flexible about approach, but dogmatic about outcomes, and always have the goal in mind, a full, healthy, and long life for these young people. This is a boy who's now a man. You can see he's now a dentist, and I first met him when he was about 9. And he's received good care there, and he's grown up, and that's outside this dental surgery that he works in with his very proud mum. For no child should die of diabetes. Thank you very much.
Thank you, Graham, for an absolutely fabulous talk as always, highlighting the fact that money is not the crucial thing, it's education and using the best resources we have. And I'll now invite my co-chair, Dr. Ganesh Javalikar, to take over.
Namaskar, everyone, and thank you for inviting me to this wonderful meeting. For our next talk, we have Dr. Julia von Oettingen. She is a pediatric endocrinologist from Canada. And she's speaking on a very important topic, because while the awareness for type 1 diabetes has increased, children do still continue to die of diabetic ketoacidosis. It continues to be an important cause of mortality in young people with type 1 diabetes. So I'm sure we all are very eager to listen to you, Julia. Julia and me are co-working on the GPED newsletter. So it's nice to see you in person. I mean, virtually in person.
Thank you so much for the kind introduction. Is my audio okay?
Yes, it is. It's
yes.
Wonderful. Julia, how do you pronounce your surname?
Von Oettingen. Von Oettingen.
Right.
My patients just say Dr. Von. It's a German last name. So
well, I think I didn't pronounce it very badly, I think.
No, that's okay. I'm used to all versions of it, and that's fine. Okay, it's my absolute pleasure to speak to everyone about management of pediatric diabetic ketoacidosis, or DKA, today. Thank you so much for the organizing team for inviting me. I don't have any conflict of interest. My objectives are to review the concepts that underlie the management of DKA in children specifically, and review current updated DKA management guidelines in youth. I'm also going to touch on developing an approach to individualized DKA management in resource-limited settings. Many of you may have seen this poster, and I think all of you are familiar with the clinical manifestations of DKA. Maybe this specific point in pediatrics being, especially in small children, this can be difficult to recognize. You may need to look out for full diapers, diaper rashes, and really be vigilant to the symptoms. I'm showing two of the posters that are available from your region. And you can see the URL below. Life for a Child has accumulated posters in all different languages and for different regions. These have been shown to be very effective in increasing awareness of diabetic ketoacidosis, and the first that can be as frequently a first presentation of diabetes. So can be effectively used in your regions to sensitize the population and reduce the prevalence of DKA at presentation. What are risk factors? And this is a photo from Haiti where many kids are at risk for presenting in diabetic ketoacidosis at first presentation and even thereafter. And it has been shown that setting-related risk factors, such as countries where there's lower prevalence of type 1, low community awareness, and just in general, resource-limited settings or low-income countries have higher rates. So generally rates, depending on these risk factors, range from 20 to 70 or even up to 80%. In Scandinavia, where there's lots of awareness and lots of diabetes, it's closer to 20% or even lower. And then in places like Haiti, closer to the upper range. There's individual risk factors as well. So if you're from a minority ethnic group, have a lower socioeconomic status, a lower parental education level, or less favorable insurance status, that also puts you at risk. There are various definitions of DKA. They don't, in principle, really don't differ that much from adult guidelines. I listed the ISPAD guidelines here, the International Society for Pediatric and Adolescent Diabetes guidelines that are based on hyperglycemia, presence of acidosis, and ketosis. Other definitions may include blood glucose and anion gap instead of the pH, as well as ketonemia. We can classify the severity of DKA in mild, moderate, and severe, usually based on the pH and the bicarb, and that often changes management in terms of the acuity of the setting and the approach of insulin delivery. Very briefly, I'm not going to talk about hyperosmolar hyperglycemic state today, but I want to mention it briefly as there's not everybody is always aware that HHS can be a first presentation in children in type 1 as well as type 2 diabetes, and there can be a mix of these. In adult, the adult physicians among you may be much more familiar with this, but just a word of caution to watch out for this in children if you have patients who are profoundly hypovolemic with marked hyperglycemia and high osmolality, usually above 320. But no significant hyperketonemia. And again, there can be mixes. So ketonemia does not exclude HHS, but just these, the marked hyperglycemia and osmolality, as well as the hypovolemia, should be red flags. It's important to recognize it because the approach to treatment is very different. It can be difficult to manage, and the mortality rate is high. I listed references for a NICE guideline. It is not included in the current ISPAD guidelines, but the paper by Zeitler et al. Is still pretty current. So just generally, the treatment approach prioritizes rehydration before insulin, and it's usually given at a lower dose. Now, resource-limited setting specific, is it possible if you don't have a laboratory available at hand, if you're in a remote region, if labs take hours to get back, is it possible to diagnose DKA without a lab? And I think all of you are familiar with urine ketone sticks and hopefully also with bedside ketone meters. And I think I'm going to make the argument that it is possible to make the diagnosis using these if you have to. This is an older paper that demonstrated that the ketone bedside meters are actually pretty good at at measuring ketone levels in the blood, which we all know are the underlying basis for the development of ketoacidosis. And you can see on the x-axis the meter values, and on the y-axis the laboratory reference values correlate very tightly. This is a recent paper from my prior group in Boston, demonstrating that the beta-hydroxybutyrate is also tightly correlated with both the venous pH and the bicarb level. And not only that, you can really define a cutoff by which you can say if the ketone level is above 5 to 5.5 on the in the blood, you're very likely to have a child in front of you who is in DKA. And if you look at this table from that same paper, they are showing the different cutoffs. And if you see at a cutoff of 5, you have a sensitivity that's approaching 80% and a specificity approaching 95% to determine that this child is likely in DKA. So if you do not have a lab available, you could modify the definition of DKA by saying you have your clinical signs and symptoms, you have hyperglycemia, and if there's presence of ketosis or ketonemia, child is very likely to be in DKA. I'm going to transition to the management goals now. There's 5 of them, and they're kind of in order. So the first step is always to correct dehydration, and especially in pediatrics as compared to adults, the first hour only focuses on that. And then we start giving insulin to correct the acidosis and reverse ketosis. There's people providers who don't treat DKA frequently often tend to focus on the high blood sugar levels, but really these are less important at the beginning to correct. The glycemia will come down as you take care of the acidosis and ketosis and are not a priority to focus on at first. And in fact, you aim for blood sugar levels in the higher ranges between 100 and 250 milligrams per deciliter, or about 5 to 10 millimoles per liter. Sorry, 6 to 12, somewhere around there. And then along the treatment course, it's important to identify and treat any precipitating event, especially in a setting where there's still lots of infectious disease around. That can often put the kids over the edge, and that's how they present with a co-infection. Also, in terms of the clinical state of DKA that patients present in, that can be confused with things like sepsis, cerebral malaria, and other severe infections, and pneumonia, gastroenteritis. So watch out for these and treat them at present. And then, of course, follow the management guidelines so you avoid complications as much as possible. And if they do develop, detect them early. From these, follow 5 pillars of treatment. The first being resuscitation, the second being a focus on fluid management, thereafter insulin, electrolyte disturbance management, and monitoring. So this is from the most recent guidelines, and I'll always show the sort of standard guidelines and then how to adapt that to the resource-limited settings if needed. The clinical history, I think, is clear. If you have a picture that's suspicious, as well as you have clinical signs such as dehydration, Kussmaul respiration, smell of ketones, lethargy, drowsiness, and the biochemical features I mentioned in the definition, you have your confirmation of DKA and you want to contact the senior staff if that's not yourself. In a resource-limited setting, you may kind of leave out the necessity to demonstrate acidosis, electrolyte, and urea or creatinine measurements, but ideally you would. And just a note that this adapted guideline was actually spearheaded by one of your colleagues, Lina Priyambada. So once you have your diagnosis, the first thing you want to do is ABCs, just like in every very sick patient, and take care of any shock if present, and take note of any disturbed level of consciousness. If the patient is not in shock, but pretty dehydrated, acidotic, and vomiting, you would likely proceed with IV therapy and start a normal saline bolus over an hour, 10 cc's per kilo over an hour, and repeat as needed. Then you want to calculate and correct the fluid deficit, usually over 36 to 48 hours. If you have it, an ECG for abnormal T waves, and measure but based on your electrolytes, add KCl to your fluids. In patients who have minimal dehydrations and are tolerating oral fluids, you can consider starting subcutaneous insulin, and I will show some evidence for that. You could continue oral rehydration and only switch to IV therapy if there's no improvement. So in a resource-limited settings, you may not have IV fluids available. If that's the case, doing any rehydration as opposed to none because you don't have an IV is very important. So you can use liquids such as ORS or those that contain water and glucose, especially if the glucose is not that high, and use the oral route if tolerated, or else an NG tube. If the patient is not improving, you would need to refer to a center that has the availability to do so. If the patient is improving, you may need to ask yourself, do we have insulin available? Obviously, if insulin is not available, that's an urgent transfer to another facility. But if it is available yet an IV insulin infusion pump is not suitable, and by that I mean you may not have an ICU setting, you may not have the nursing staff to supervise an insulin infusion, and rather than using a drip, which some centers do, it is probably safer to use a subcutaneous or intramuscular approach. Why? An insulin drip, especially in a smaller child, that is sort of by droplet count, is imprecise. If it's not adequately supervised, you can very quickly, either if the insulin drip is a defect, you can have the child go back into DKA, or if, say, the IV infusion with the glucose is not no longer functional, or if nobody's measuring the blood glucose, you can easily get a child that gets a severe hypoglycemia. So in those cases, subcutaneous or IM insulin approaches using either rapid acting or regular insulin at the doses as prescribed here is probably safer. If you do have an insulin infusion set available, you can use the regular approach, starting with a dose of 0.05 to 0.1 units per kilo per hour. And that is 1 hour after the fluids have been initiated. A few words on some controversies and specifics to pediatrics. IV boluses at presentation. I'm sorry, I bolded this in red. So there's no insulin bolus in pediatric patients. This, even here in Canada, this is frequently done in adult-focused hospitals that don't have pediatric units. Patients get a 10 or 20 unit bolus up front. It's been associated with an increased risk of cerebral edema, and so is not done in pediatrics. In terms of fluid boluses, there's a bit of a controversy how big that fluid bolus should be, and I will show some evidence for that. As well as the estimate of deficit, and then the maintenance fluid calculation can vary based on centers. The fluid composition, do you use normal saline or half normal saline, is also debated. This PECARN study that I'm showing the sort of most essential results of was published 3 years ago, and this was kind of a landmark study to answer some of these questions. And basically they looked at, okay, do we use a big or a small bolus? How fast can we administer this bolus and the maintenance fluids thereafter, and what fluid composition should be used? So they had these 4 different groups using all these different elements and assuming actually different fluid deficits, and so a larger or a smaller replacement fluid amount, as well as a different composition. And basically what they found is that there was no difference in the outcomes. So whether you give a 10 cc per kilo bolus or a 20 cc per kilo bolus, whether you give normal saline or half normal saline, And whether you estimate a 5 or a 10% fluid deficits, the outcomes are quite similar. And that was for the primary outcomes in terms of worsening coma and cerebral edema, as well as the secondary outcomes. And they showed that maybe with the lower sodium content in the half normal saline, you may actually get a reduced rate of hyperchloremic metabolic acidosis, and so it may have some benefit from switching to that. What about the use of subcutaneous insulin DKA? This is sort of increasing evidence, again, from this resource limited setting guideline published last year. There's actually a bunch of evidence from adults that this is safe and effective to use at a minimum in mild and moderate DKA. But these two trials that I highlighted here also provide some, decent evidence that it's probably safe to use in children as well. And this is from my own lab, where we looked further back than Dr. Priyambada and her group, looking back actually to the 1970s and 80s, where there were the first trials. It was sort of the other way around. People were using subcutaneous and IM insulin as a standard approach, and we're looking into the benefits of IV insulin. And similarly here, both in terms of safety and efficacy, there's probably not a great amount of difference. And just to highlight here that this counts as well for the IM use and for patients who are in severe and not just mild and moderate DKA. So once you've started your fluid resuscitation and you're ready to start your insulin, these are the standard dose in pediatrics is 0.05 to 0.1 units per kilo per hour. Comes your time to then observe your patient critically in terms of blood glucose, ins and outs, neurological status, electrolytes, and ECG for T-wave changes or potassium if you have it. Main thing is to look out for neurological warning signs and signs of cerebral edema and treat that ASAP if you need to. And for improvement of acidosis. If it's not improving, it's important to reevaluate, is your fluid calculation correct, your insulin delivery system okay? Do you need any additional resuscitation or other complications? What you want to see is that your blood glucose falls at about a rate of 5 millimoles per liter per hour. And you want to watch out for it dropping below 17 or around 250 to 300 milligrams per deciliter, because that's the point where you would want to add glucose to your fluids. This is a simplified table of the main parameters that you want to look at while you're monitoring your patient, and you want to do that really every hour. Brief word on cerebral edema, really the most feared complication in DKA. The incidence is low, but the mortality is very high, so look out for that. Can develop during or before DKA treatment, and the decision to treat is based on clinical evaluation, so no need for head imaging or anything like that to confirm. If you have a clinical suspicion, you treat. Either with mannitol as indicated here or 3% saline, and simultaneously, you would want to decrease the fluid rate by 1/3. You want to elevate the head of the bed. And of course, reevaluate your ABCs and intubate if needed. In children, risk factors are younger age, more severe acidosis, and that goes along with a lower PCO2, more severe dehydration as indicated by a high urea, an overhydration in the first 4 hours. And just remember, this is an association. That's why this controversy about the fluid volume has been and is still a conversation. It's an association whether the fluid volumes actually induce a cerebral edema or they're just a marker of a child that is sicker and needs more fluid is still sort of a bigger question. Early administration of insulin as well, and that's why we wait an hour to start the insulin drip. And then if your sodium is dropping or not rising as the blood glucose corrects, you want to watch out for that. And then bicarbonate treatment in very severe acidosis, which is one of the reasons it's no longer really done unless the patient is in cardiac failure. Other complications of DKA that you may see more in adults Then the cerebral edema, but that can be present in children, are listed here and basically need to be watched out for during management of DKA. So in a resource limited setting, how can you adapt these guidelines? If you have a neurological deterioration, it's the same protocol as the standard guidelines. But if your blood glucose falls below 17 or is dropping rapidly, you just empirically add 5% glucose to the fluids. If you have it, you can add 10% dextrose. If you don't have that but you have D50, you can add D50 to a 5% fluid solution to make it up. If this is unavailable, actually, you only have the 5%, you may need to reduce your insulin dose, although never stop it, and or the frequency of your subcutaneous injections. If you are able to obtain electrolytes, you should adjust the sodium infusion as per usual protocol. If your DKA is not resolving, you may consider sending to a center where IV insulin can be given. However, if your patient is improving, and they're clinically well, you notice that in a child, they're awake, alert, and asking for food, and they're tolerating water, you can transition to a sub-Q insulin regimen that's sort of a daily regimen. So these slides are reversed in the standard protocol, and it's outlined here what you do exactly for neurological deterioration, and again, the cerebral edema management. And here you sort of have more precise guidelines. Once your blood glucose drops, if you haven't already done so, you want to change to half normal saline to avoid that hyperchloremic metabolic acidosis from developing. And you want to add 5 to 12.5% glucose depending on the child's needs and the rapidity of the drop of glucose, and adjust your sodium infusion. And so if they're on IV, you want to transition to sub-Q once the ketoacidosis is resolved. How do we define ketoacidosis resolution? How do we define the DKA resolution? Well, either by pH, by bicarb, or by anion gap that is closed, or by the blood ketones dropping below 1 millimole per liter. You also, of course, want to see the child tolerating PO. Importantly, when you're on an IV insulin infusion, you want to give your first subcutaneous injection about 15 to 30 minutes before you stop the insulin infusion. Now, can that be done in a setting where you don't have labs available? How do you define the resolution of diabetic ketoacidosis? And this is a nice paper from almost 15 years ago, but it shows very well, if you look at the trajectory of the blood ketones with the circles here versus the triangles, which is the venous pH. As the venous pH rises to 7.3, your blood ketones drop below 1 and stay there. So if you choose this as an endpoint, you can define resolution based on the blood ketones dropping below 1 times 2. Just a word of caution, this is still done in many settings. People wait for the urine ketones to resolve. That would be the endpoint B. That's probably not a great idea because it really takes hours, sometimes 24 to 36 hours till the ketones become negative on your ketone urine strip. So as if the ketones are dropping and are staying kind of mild to moderate and the child is clinically well and asking for food, you could probably switch to a subcutaneous regimen anyway. So if you could define modified resolution criteria by saying if the patient is well appearing, awake, alert, hungry, asking to eat, tolerating water, and blood ketones are less than 1 millimole, or urine ketones have been dropping and are staying low, but not necessarily clear completely, you can transition at that point to a routine subcutaneous regimen. And often that is 70-30 and pH plus regular insulin, or basal bolus regimen if that's available to you. And with that, I'd like to thank everybody, and I'll be open for questions in the question period.
Thank you, Julia, for that excellent overview. I think we'll be having the question and answer session at the end of the next talk. So please stay on. over to Dr. Anju for introducing the next speaker.
So it's my absolute pleasure and honor to introduce a very dear friend who's been a source of a lot of information and guidance over the years. Jill is not just a clinician and a researcher, but an educator, and her focus has been to study the impact of chronic illness on life and coping in transition to adult care. She's a professor of psychology in Chicago at the Northwestern University School of Medicine, a certified diabetes educator, and an absolutely wonderful person. Over to you, Jill.
Well, thank you so very much. I thought I'd shared my screen. Let's try it again. There we go. Okay, so thank you again very much for inviting me to participate in this talk. And today I have the pleasure of talking about family teamwork during the adolescent years. So I'm just going to start by just saying some basic facts, which is that diabetes has never been, and I don't believe even with the newest technologies, if everybody had access to it, that it would be a do-it-yourself disease. In order to thrive and do well with diabetes, you need a team. You need people that are cheerleading you and supporting you. You need a helping hand. You need the support of people that love you, because diabetes is truly cared for within a family. Why is diabetes not a do-it-yourself disease? Well, part of the reason is that it is such a complex disease. You have all kinds of things that you have to manage around blood sugar monitoring, around insulin administration, whether you are using technologies or insulin from a vial and syringes. You are trying to figure out how to use technologies. Above and beyond insulin and blood glucose checking, you have to think about whether or not you're engaging in physical exercise. And then the type of exercise, is it cardio or is it not cardio? Again, different people have different experiences. And then you have to think about the food and the quality and quantity of the food that you're eating. Above and beyond that, diabetes is incredibly demanding. People are always thinking, did I check my blood sugars? What is my blood sugar number? Why is that my blood sugar number? How much insulin do I have on board? Am I dehydrated? When did I last eat something? Is it safe for me to exercise? Do I need to eat something? Do I need to take insulin? And above and beyond that, diabetes can be very unrelenting. People will think, I can't eat without taking care of my diabetes. I can't exercise without thinking about my diabetes. I can never take a break from my diabetes. Diabetes is every single moment of every single day. Honestly, especially for teenagers, they will say some days they just suck. I'm feeling tired. Is it because of my blood sugars? I'm feeling irritable. Is it because of my blood sugars? And above and beyond that, the daily unrelenting demands of taking care of diabetes can easily lead to a variety of emotions, from feeling completely buried, from feeling exhausted, from feeling emotionally overloaded, feeling really frustrated and burdened and wanting to scream, and feeling baffled and feeling like you never have time when you can get away with it or get away from it, feeling alone and isolated and completely sad. Above and beyond that, diabetes is not a do-it-yourself disease, in part because the relationship between what you do to take care of your diabetes and the outcome that you get is not always consistent. So an example is a quote from a teenager who said, "Today I have done everything right, and still I can't get my number to go below 16. Or the sense that nobody understands what you do every day. One person said, "Everyone around me thinks I'm strong for living a full and active life with this disease. Sometimes I think I've deceived them. They don't know how many tears I've shed, how many pillows I've punched, or how much fear, frustration, and anger I feel on a regular basis." There's also the sense of shame and guilt. One person said guilt is actually the worst complication of diabetes. And then the sense that sometimes you actually have to be dishonest or overtly lie to your family or your friends or your healthcare providers. So one person said, I hide the candy bar wrappers from my dad, or I tell my doctor that I do things that I don't really do. So if we sort of agree that diabetes is not in any way, shape, or form a do-it-yourself disease, and then we add what we understand about development for young teenagers and then for older teenagers. So for developmental issues for the early adolescent years, so between ages 10 and 13, we have physical changes, puberty is beginning, and there's lots of rapid growth. I cannot begin to tell you how many families say to me that they did not know that the hormones that lead to pubertal changes also lead to higher blood sugars, and that often children need more insulin during that time. And so families begin to feel, and the teenagers feel, as if they are failures because they do not understand the role of pubertal hormones on blood sugar control. Cognitively, most children in this age, their thinking still is fairly concrete, and parents will begin to see the emergence of more sophisticated thinking at times. The problem is that that can be joyous and exhausting, right? So we will have families who think that because their child engaged in a magnificent problem-solving event, that somehow now that their children engaged in great problem-solving in that one moment, they're sort of done parenting their child, and their child will always engage in good problem-solving and judgment, and that's just not true. Emotionally, we have all different kinds of changes for children in the early adolescent years. They really need a sense of belonging, a sense of being the same as their peers, and diabetes makes them different. And there can be some teasing and bullying around diabetes in this age range. Socially, our teenagers are now really starting to form very intimate relationships with their peers. And when I say intimate, it's not necessarily a sexual intimacy, but it's more an emotional intimacy, excuse me. And then for family relationships, they're changing because as children begin to change physically, they also are starting to want more privacy and more independence, and they begin to start to think about detaching from their parents, which can be very hard when parents are worried about their children's health and safety. So for parents in their preteen, sort of the 10 to 13 or the early teenage years, one of the things that we can do as providers to support optimal relationships is to help parents match their expectations for their children's independence and responsibility in diabetes care with their children's clear ability to engage in those behaviors. At this age, it's very important that parents continue to oversee and monitor their children's diabetes care tasks and support them. It's very important, if children are doing anything independently at this age range, that parents are willing and happy to take over those responsibilities at any time when children ask for it or when it's clear that it's needed. It's important for parents to encourage their children to recruit their friends, especially during school days or school hours, to support their children and to offer reminders, for example, pre-bolusing insulin at lunch if they're on analog insulins. And to work collaboratively to develop strategies for communication. So for example, if the young teenager happens to have a smartphone, is it best to have text messages or emojis or photos of pictures of blood sugar meters to send to parents? For middle adolescent years, so the 14 to 17 year age group, physically, our teenagers, oftentimes puberty is ending, especially for girls, although for boys, their growth might just be starting. Cognitively, we're now seeing an incredible emergence of more sophisticated thinking. But that does not in any way, shape, or form mean that because teenagers have the capacity to show sophisticated thinking and spectacular problem solving, that they're able to utilize that problem solving and that judgment at the moment that it is most needed. Emotionally, children are beginning to think about who they are, who their identity is, what they're wanting in their life, how they describe themselves, and they're thinking a lot about leaving home. Socially, they're thinking more and more about their friends. They're thinking, if not engaging, in sexual activity, and they're thinking about dating. And their family relationship is changing as teenagers mature. So for parents and teenagers, the importance again is to match the expected responsibility that children have in diabetes care with their ability. It's important to promote family discussions and problem solving, at least on a weekly basis, where you're looking at and evaluating blood sugar numbers and patterns and having conversations that are not emotionally laden, but curious about what patterns are being seen and how collaboratively the family can work to address any changes that might be helpful. I always ask parents and teenagers together whether or not the parent's tone of voice changes when they are talking to their teenager about diabetes-specific content versus anything else, friends, school, chores, anything. Almost always, parents say to me, oh no, their tone of voice is the same no matter what topic they're talking about. And teenagers invariably look at their parents and say, you've got to be kidding. I know exactly the tone of voice that you use with me when you're bringing up a diabetes-specific topic. So helping bring that awareness to parents so that teenagers are not having an immediate defensive reaction to conversations that are related to diabetes, which is part of helping parents balance what teenagers might be perceiving as nagging versus supervision and monitoring. So having a clear, open conversation about what parents need to see in order to feel confident that their children are safe and healthy, and how to do that in a way that the teenagers don't perceive as invasive or intrusive or aversive. Part of that is also helping parents separate expectations for independence that have nothing to do with diabetes versus expectations for independence that are directly related to diabetes. And the reason that I'm saying that is that diabetes is not a normative experience. Not every teenager in the world has and lives with and manages diabetes, but all teenagers have to manage things like school and school responsibilities. They have to manage things like chores or getting a job. They have to manage things like hygiene. And so expecting teenagers to engage in developmentally typical independent tasks, most parents are very comfortable with what is reasonable and developmentally appropriate to expect. And I very much encourage you to talk with teenagers and their parents that independence around diabetes-specific tasks is a slower slope. It's a slower trajectory of independence because the consequences for not checking blood sugars when you have the opportunity to, and to not administer insulin when you have the opportunity to, is too great to leave it exclusively for teenagers when developmentally their lives are focused on many more things than blood sugar numbers. And so we do want to encourage success in children's friendships, in their schoolwork, in their extracurricular activities, perhaps in sports. We want to make sure that when we talk to parents and teenagers as diabetes providers, that we are giving the entire family the message that we are truly interested in the entire child and the entire family, not just their pancreas. We want to be able to normalize for parents and teenagers a sense of burnout, that it is normal and okay and expected to feel exhausted and frustrated and burdened by the everyday demands of diabetes, and facilitate the parent and the teenager engaging in some conversation about how to address those moments so that they are not fighting with each other or arguing with each other, but they're actually collaborating together and they're working as a team because diabetes is hard, as opposed to fighting each other because the teenager is being hard. We want to understand that for teenagers, they want to be the same as their peers, which means that sometimes they will choose activities that make it harder for them to engage in diabetes care. We do need to understand that while they have increased problem solving and abstract thinking skills, and they do have the ability to understand the goals of the treatment regimen, why are we asking you to monitor blood sugars? Why are we asking you to take insulin? They can answer that. They're also beginning to become incredibly frustrated that even if they do what they're being asked to do, it doesn't always lead to improved outcomes. Right? I can do what you tell me to do, doctor or nurse, so-and-so, but there are times when my blood sugars are still too high. They're over 12, they're over 16, even though I've done what you've told me to do. Or there are times when I do what you tell me to do, and I can't bring my blood sugars up over 4. And so they can be very frustrated by that. They can also be very frustrated by the fact that sometimes they don't do what we tell them to do and their blood sugar numbers look just fine. So that sense of the fact that there isn't always a one-to-one correlation can be very frustrating for teenagers. And of course, they want more independence and they want more responsibility. But as teenagers grow and they have more independence in their lives in general, they also often have less supervision from their parents. For teenagers, again, puberty can play a role in diabetes outcomes. For many teenagers, they are beginning to experiment in activities that their parents would rather that they do not get involved in. And there is definitely a sense of invulnerability in this age group. So if you ask teenagers what the risks might be for different things, like if you have an opportunity to drive a car, why is it dangerous to text and drive? Teenagers will tell you all of the reasons why texting on their phone and driving at the same time is dangerous, but then they will also tell you that they can handle it and that it's not dangerous for them. So teenagers have a good idea of what can be dangerous in general, but they don't believe it's true for them. They have that sense of invulnerability. And my favorite example of that is a study that was done where they asked adults and asked teenagers a couple of questions. And the participants in this study did not realize that the metric, the measure that was really being assessed, was how long it took for the people that were asked the questions to answer the question. So there were questions like, is it a good idea to go swimming with sharks? Is it a good idea to drink Drano, which is something that you put down plumbing to clear out the drains? Is it a good idea to set your hair on fire? And the questions were almost always everybody said no, but it was the delay in saying no. So is it a good idea to set your hair on fire? Adolescents, adults said no right away. Teenagers, it's almost like you could see them thinking, set my hair on fire. If I film that, I could be famous on TikTok. But wait a minute, I could actually die. Okay, no. And it took them that long to say no. And so there is, again, this sense of invulnerability and delayed reaction to potential dangers. Teenagers are really, really good at understanding sarcasm, which can drive parents crazy. And they are understanding and keenly aware of hypocrisy, especially in adults. And so teenagers are very quick to point out, especially to their diabetes providers, that what they say doesn't quite make sense to their own lives. So concretely, if I ask one diabetes specific question to the audience today, I could probably get easily 70 or 80 different answers to my one diabetes question. Now, as healthcare professionals, we can say, oh, but of course, diabetes is very much an art and not as much a science sometimes. And there are many ways to address a particular diabetes specific question. But teenagers will look at that variability and say, oh, you guys don't know anything, and you certainly don't know anything about me. And therefore, I am not going to attend to or listen to anything that you have to say to me because you are irrelevant to me. So there's also lots of developing brain data that supports what it is that I've been sharing with you. The functional MRI data shows that there are lots of changes to our brains as we move from childhood to adulthood, in particular in the prefrontal cortex, right? So our frontal lobes are responsible for things like planning ahead, emotion regulation, and evaluating the risks and rewards of certain behaviors. And as you can see from this slide, the more purple as opposed to green or yellow, the colors are on the brain, the more myelinated your brain is. And so as you age, your brain continues to basically be finished. And we are not done, especially in our frontal lobes, until we're close to the age of 25. And again, if the frontal lobes are the part of our brain that lets us understand risk and reward and shows judgment and allows us to delay gratification, and that is not finished in our brain until we're 25, it really developmentally makes no sense to expect 15-year-olds to show good judgment and to be able to evaluate risk and reward. Again, we've talked about pubertal changes. Teenagers are managing all kinds of mood issues. We have an increased risk for emotional distress and depression. And above and beyond that, within the family, we have this concept of miscarried helping. So if I am a parent and I am worried and concerned and afraid for my child's health and safety, and the way in which I express to my teenager that I am worried about them is that I say things like, did you check your blood sugars? When did you check your blood sugars? I don't remember the last time you checked your blood sugars. Are you sure that you ate well? When did you eat? What did you eat? How much did you eat? Did you take insulin before you ate? Did you take insulin while you were eating? The teenager is not going to hear that as their parent being worried and concerned. They're going to hear those questions as being accused, as being criticized, as being blamed, and as being perceived as incompetent. And then the teenager does not have any desire to communicate with their parent, ask their parent to help them problem solve, or have their parent collaborate with them in managing diabetes. Everybody in the family feels angry, everybody feels discouraged, everybody feels frustrated, and the cycle continues. Here's another example why nagging does not work, especially in teenagers. This is a cartoon where Hagar, who is a Viking, goes to his doctor, and the doctor says, stop overeating, stop drinking, stop staying out late, stop fighting, stop worrying, stop eating sweets, stop gambling. Hagar goes home. His wife says, what did the doctor say? And he says, I don't know. I stopped listening. And that's what we don't want. We don't want teenagers to stop attending to or listening to their parents. So teamwork, family collaboration, and teamwork is the key, because honestly, nobody is truly independent. We all do better by having people in our lives that support us, collaborate with us, and are with us on our journey. We know that if anybody feels isolated, people that feel isolated have worse psychosocial and worse medical outcomes. We want to try the best we can to minimize any perception that we are judging our teenagers or helping them or causing a sense of shame. Because truly the key to being a grown-up, to being an adult, is knowing when you need help and then asking for it. As clinicians, we can help families understand that, and we can help normalize feelings of burnout and help families plan for that, because a sense of burnout is not a sign of failure. And we want to help families feel really comfortable scheduling times when teenagers are exhausted or frustrated or irritated with diabetes to return all of the diabetes specific responsibility back to their parents for a while so they can feel like they have a little bit of a break. And then the parents can turn some of the responsibility back to teenagers when they're ready. So I think there are a couple of things that we can do as clinicians to help our families do well, and ask our families these questions, like, how is it that you guys communicate as a family? And has that changed now that your child is a teenager versus when they were younger? How do you problem solve together as a family? How do you resolve disagreements as a family? Again, how do those questions, how do those answers change as children grow and develop? And how do parents think about managing children's, teenagers' developing push for independence with both supervising their children and monitoring them in a supportive way? It's important for parents to learn to listen to their teenager. This is very easy to say, but it's actually really hard. And I challenge you as clinicians to think about this in your own lives as well. When you are having a conversation, limit distractions, which means silencing all technologies. Boy, is that hard for teenagers. It's important to pay attention to what is being said and not thinking about what you want to say. So part of doing that is to help parents repeat the last sentence of what their teenager said, because that keeps the parent's attention on everything that the teenager is saying. And it makes it harder to keep thinking about what your response is going to be. It's okay to be okay with silence. You do not always have to respond immediately. It's okay to be quiet for a minute after somebody is talking. It's important to encourage children to offer ideas and solutions before parents give their ideas and their solutions. I encourage parents to listen 80% of the time and only talk 20% of the time. It's important to restate the key points that parents have heard to ask whether or not they're accurate. So saying things like, let me see whether or not I heard you correctly. That is a really easy way to clarify confusion, because being a strong and attentive listener will help parents be more effective parents. Now, I want to underscore, understanding and listening and having an accurate understanding of what the child is saying does not mean that parents have to agree with the child's perspective, but you can never move forward as a parent if you do not understand the child's perspective and that the child feels understood. So understanding and agreeing are two completely different things. Lastly, it's very important to encourage positive behaviors in your teenager that you want to see. So praising, not punishing. For example, catching your teenager doing well with any diabetes tasks at all and commenting on it. And celebrating everyday diabetes successes is important, because the more you praise the behaviors that you want to see, the more often your teenager will engage in those behaviors. And focusing on behaviors, not numbers. Blood glucose values are data. They are not report cards. They are not good numbers. They are not bad numbers. So let's praise blood sugar checking or insulin administration or healthy meal choices and not the blood glucose values. And then finally, problem solve together, avoiding commands and encouraging collaboration, ideas, and advice. Because in the end, we don't want this to happen, which is the parents looking at their children and the dad says, your mother and I are feeling overwhelmed, so you'll have to bring yourselves up. And we'd like to avoid that. So thank you so much for your time and for your attention. And I'm happy to answer questions when we have that time.
Yes, that was an absolutely fabulous talk. And we do have some time. So let me start off by firing a question that I find very daunting, which is how easy do you find it to tell the parents to sit outside and let you talk to the child for a few moments alone?
Who are you asking that to, Anju?
You, Jill.
Oh, okay. So, you guys know that I am an American, and so I have that perspective mostly. And the American Academy of Pediatrics says in general, it is vital for all clinical encounters, starting at the age of 12, to spend at least a few minutes with that child alone to set the stage for eventually helping young children and teenagers begin to develop a sense of independence in their own medical care and to develop an independent relationship with their pediatrician. And I would suggest that us as subspecialty care providers in diabetes, it's just as important to do that. And so if you tell parents that starting at the age of 12 or 13, this is your clinic's policy that you always spend a few minutes alone, then over time, parents will become more and more comfortable with that.
Thank you, all the speakers. I think Dr. I'll just get in Dr. Mahira at this point of time, our rapporteur. So I believe she would have the access to questions that have been asked by audience. So if you can share some of the questions along with to whom they have been addressed, it will be nice.
Right now, I do not see any questions addressed, but I would like to ask Dr. Julia, as you said, it was very informative session on DK. And as you said, insulin therapy should be started, sub-Q should be started with 0.15 units per kg. So when do you prefer to start the insulin and which route do you prefer? It should be given sub-Q or intravenously?
Muted, you're muted.
No, I'm not muted. Julia, you're muted.
Julia might be.
Yes, ma'am. Meena, ma'am. Julia, please unmute your mic.
Yeah, she has.
Hold on, let me just.
Yeah, she has. You're audible now, Julia.
Can you hear me okay?
Yes, now we can.
Okay. Yeah, great question. The start of the insulin, of the subcutaneous insulin, would be at the same time as you would start IV. So after the first hour, you give your fluid bolus and then you start it. Your other question is the preference. Yeah, so we actually at our center in a high resource setting just established a protocol that mild and moderate DKA, we're going to treat them with subcutaneous insulin. The reason is that, and this is in the context of COVID and also in the context of limited intensive care unit space. And the policy that on our wards, as soon as the patient is on an insulin infusion, the wards cannot accept them to the inpatient unit, to the regular inpatient unit. And the centers that have done that quite successfully. So there's there's data coming out of Brazil, some Israeli data. So in a child that's not younger than 2, and that's a mild or moderate DKA, it's my preferred approach because it means the child can potentially go home from the emergency room. It means you could potentially avoid an admission, and it means a huge avoidance of costs because intensive care unit cost is obviously way bigger than a regular ward. So for example, a child who has a pH of 7.28, they often correct within 4 hours. To start an insulin infusion and admit them to the intensive care unit for that is a huge amount of cost and also nuisance. Yeah, so we're evaluating that on a QI perspective in our center, but to briefly answer your question, I think in mild and moderate DKA, it would be my preferred approach.
So Eunice wants to know how to stop recurrent vomiting in DKA, Jill. Sorry, Julia.
Sorry, how to?
How would you stop recurrent vomiting in DKA?
Recurrent vomiting. Well, a child who is recurrently vomiting and unwell, with regards to the IV sub-Q, that obviously needs to be taken into consideration. The vomiting stops as you correct the acidosis and ketosis. If it's really, if other than that a concern, we sometimes give anti-nausea medications, such as Zofran or Vomax, but usually the vomiting, stops as you correct the ketosis, because the ketones are what make the children vomit.
Absolutely. And once you've given them a nil oral period for a few hours, they do tend to settle down very quickly.
Yeah.
I had a question for Graham. Graham, in Life for a Child, how much of the percentage of insulin that you supply across the world is conventional, and how much of it is analog? And how much of the conventional insulin is U40 and how much of it is U100?
Yeah, thanks, Andrew. It's all U100 that we receive. This is the first year where we have access to analogs, and we're able to provide analogs for long-acting analogs for 1/3 of the children we help across the globe. Now, that will depend on particular countries and as to how much they're using analogs and whether they're on multiple daily injections or not. And so for some countries, it'll be higher. And just for India at present, we're not yet providing insulin in India, but we will be soon. We're just working out how to get it into the country and so Lydia helping with that. But we will have we will be able to provide analogs to really any child who the clinicians feel should be on analogs within India and going forward. So this is a new thing for Life for a Child to be able to do that. But it will be, and we haven't yet thought about the 40 IU and 100 IU in India because we haven't been providing insulin. So we'll cross that bridge when we come to it. In Pakistan, we're using 100 IU, even though 40 IU is available in the market there as well. But I think in India, we would be guided by the clinicians there as to which concentration to use.
But if you can push MDI at the clinicians who are often not very familiar with type 1 diabetes, and if you could push U100 at them, that would be really fantastic because it makes a huge difference, I think. But what percentage of the children that you're looking after with LFAC are being provided with glucose strips, and how many of them have to provide with the strips themselves?
We're able to provide strips for all the children that we help. And that's the intention. And it was 2 strips a day, but now we're going up to 3 to 4 strips a day. And then the families are able to buy more if they want to. But yes, yeah, every child as I'd be somewhat of a hypocrite myself if we weren't providing blood glucose strips to the young people as well as insulin. So yes, we provide those to every child. And that's what we're doing already in India. We're supporting centres with funds to purchase blood glucose strips.
3 to 4 strips a day. That's lovely.
Graham, I also had a question, or rather a point to discuss that some centers in India have reported very good results with basal bolus treatment using NPH as a basal insulin and 3 times day regular insulin. So, and this keeping the costs almost the same. So in that light, can we say, I mean, because the sad reality or the reality is that even till date, a large majority of people with type 1 diabetes continue to be on pre-mixed insulin. So what would be your, comment on this, that with the same expenditure, and thanks for highlighting the results of minimal care versus intermediate care, which is very much possible even with minimum amount of money involved.
I would completely endorse the use of NPH&R in a basal bolus regimen if analogs are unaffordable. As I mentioned in the presentation, analogs have not been shown to improve HbA1c. They do have some advantages, but when there's limited cost, and particularly when we're talking to governments, like, do we want governments to spend all the money on analog insulins, or do you want them to spend money on blood glucose strips as well and HbA1c? So I think, yes, absolutely, centres, and I'm aware that there's centres in India getting fine results from NPH&R in basal bolus and continue on.
No, I think what Ganesh is trying to say is the evil role of 30/70 versus having regular
because
insulin.
even programs like CDIC offer premixed insulin to these poor children, and invariably the long-term outcomes are not really.
I think certainly move away from premixed insulin. We still do have. In some countries where there's, India, you have all the expertise that you need, amongst the on this call and others in your country. But in countries where there's less expertise, we still do have some children on mixed insulin. But each year we're pushing them to move to NPH and R. And in many countries that are less resourced than India, every child is on NPH and R. Because as you know, fixed 70/30, and just speaking to people who might be listening, there's much less flexibility for the family and for the young person with 70/30, and it's harder for them to learn how to self-manage and to adjust their doses themselves if they're on 70/30. So it's much better to move to, you have to do it safely, but to move to a basal bolus regimen.
This is Dr. Sujata Jali, and hello, Dr. Graham.
Hello.
We lost the audio.
Sujata, you're not audible.
Am I audible now? Am I audible?
Yeah, now
yes, ma'am. Okay, so 70% of our children are on basal bolus regime in our center. But what the most of the studies say is that though we are using premixed in some of the children, but hypoglycemia is quite a bit of problem in premixed insulins. Then we have a long-acting analogs now. So I think the cost is not a big difference between these two. And I think still we can go for an regular insulin 3 times and with a long-acting analog. It's such combination instead of using the NPHs, which can have a better outcome, I feel.
Yes, I think so. If you can afford the analog or provide it through some charity means, then that's good. And the one that I would go for, I agree with you, is the long-acting analog rather than the short. If you had a choice of one, I would go for the long-acting rather than the short-acting. And that's exactly what we're doing with Life for a Child this year, that we're able to provide analog insulin, long-acting analog insulin for the first time.
The only comment that I want to make is long-acting analogs even now are almost 4 to 5 times more costly than NPH insulin. Yeah. So,
so if I could add a somewhat provocative thing to that, Graham, how possible is it for you to do some brainwashing of the providers when you give the supplies to get them to change their attitudes rather than giving whatever the providers think appropriate? Because sometimes the providers themselves are clueless.
We try and push them, and we do a bit of a carrot and a stick as well. And so if a clinic is, and I'm not talking about India, but if a country is just on mixed insulin, they're not going to get analog insulins from us until they move through that next transition. And maybe there's some patients that can flip straight from mixed insulin to analogs, but yes, it's purely just education and encouragement, and these sort of meetings, I think, where this is raised. Children, it's much better for children to be on a basal bolus regimen, whether it's with human insulin or analog insulin, than it is to be on mixed insulin.
I'm just going to add it.
Yeah, sorry, Julia.
Sorry, just a brief word from the patient and family perspective. I think in some settings, especially where there's a lot of stigma around diabetes, yes, children and families like the fact that they only have to inject once in the morning, once in the evening, and don't have to inject in school, and don't have to take out their needles more than that. And the second point is some of the adult providers are also just much more comfortable with that because it works for their type 2 diabetes patients. They have enough residual insulin production to compensate for the rest. And so, yeah, I like Graham saying, I think a lot of education is necessary, and just overcoming that change. I think we all are like this. Whenever there's a change, it's a major change, right? Because you're going from feeding the insulin approach to adjusting the insulin to what the patient and how the patient is eating. And that's much more difficult to manage and requires a lot more understanding of the pharmacology and of how the insulins work for the patient family as well, which is very difficult in subliterate populations.
Well, actually, Julia, what I find is that it's actually easier for the illiterate patient to understand that food is equal to insulin, and they don't have to do mathematically complicated Einsteinian stuff to understand how the 30-70 would work. And it's just that every time you eat, you shoot yourself and then you eat. And that's possible. And you have more food, you eat more. If you you inject more, if you have less food, you inject less. It's much easier for them to understand when they're illiterate completely or subliterate. And if I can use my chairperson's privilege to push my luck a little bit and ask Jill, how do you deal with the aspects of sexuality? How do you deal with, how do you get in a conservative society to ask a 14 or a 15-year-old whether they're sexually active or not?
We can't hear you, Jill.
Please unmute your mic.
Yeah.
No,
so Jill, you're mute. Yeah.
No. Muted.
Muted. Now it is. Now it is.
Okay, can you hear me now?
Yes, we can.
Okay, great. I'm sorry about that. I just want to comment about what Julia said, which is that from an adolescent developmental perspective, to give them the message that they have control over what they eat if they take insulin to match their food, that gives them a sense of ownership. And from a developmental perspective, that's also great. As far as your question, Anju,
what I wanted to ask Jill was, how do you deal with the matters of sexuality? So a 14 or a 15-year-old, how do you broach? I know the US would be a little different. We're very conservative, but of your conservative families, how do you deal with asking a question whether she's sexually active or he's sexually active or not? And how do you broach the parents with that?
yeah, so it's a great question. And I would suggest that most of my physician colleagues in the United States are very uncomfortable asking that. And it's only my physician colleagues that are actually specialists in adolescent medicine that are comfortable asking those questions because they've been specifically trained. So I think that, sexuality is a normal part of development. And just because you're thinking about it does not mean you're engaging in those behaviors. So I think it's important for us as clinicians to understand that having a conversation does not support sexual activity. And that asking questions does not mean that we are saying it's okay to engage in those behaviors. And in fact, if we open up the conversation and make it a safe space to be able to ask questions and understand your body and what you're feeling, it normalizes it. It takes it out of the dark. It takes it out of a sense of shame. And more likely it is children or teenagers that have no place to ask questions that are going to wind up maybe being more at risk for either sexually transmitted infections or pregnancy. So if you place it in sort of a normative developmental task and around supporting health and safety and good decision making, I think you probably be in an ethically okay place, regardless of how conservative the families are that you.
But Andrew, do you mind if I add my perspective? Because we routinely ask about that. And one way, what Jill mentioned earlier in her talk, to just make it a routine, for us it's 14, we have to, it's by law. At 14, every patient has to get the opportunity to have an encounter without their parents with the physician. So I do that at either beginning or end of the visit. And at the beginning, it's just, I tell them, you're now 14, you're starting to get, more autonomous. And so there's conversations that I want to have with you without the parents in the room, and you kind of establish the confidentiality. I don't know if that's possible in your setting, But I tell the teenager, the things that we discuss between you and I stay between you and I, without the knowledge of your parents, unless I feel there's I'm worried about your safety. And then I ask them these questions, the sensitive questions, every visit. And at the beginning, they always say, no sexual contacts, no smoking, no alcohol, none of that. But then as they get used to it, they know you're going to ask them questions, and eventually they will be comfortable saying it. And Jill's comment about normalizing it, I often add a line of, I ask all of my patients about boyfriends and girlfriends. Is that something that you've started to have an interest in? And they may say, and then you kind of, I usually ask my patients, or some of my patients do this, and sort of normalizing the context and not having the patients in the room, even the ones from the conservative backgrounds, will eventually come forward. And the key is that they come forward when there's an issue. So I think making it a routine and getting the parents in your clinic used to the fact that teenagers get alone time with the physician might be a way to start it. The parents don't like it at the beginning.
I think I'll have to ask Mahira if we are out of time now, I think.
We are not, but there's one more question for Julia. That is, please elaborate on the insulin transition from intravenous to subcutaneous.
Okay. Yeah, I did not go into the specifics of that. There's multiple ways of doing it. There's no one way. My approach is to say when the child is out of DKA, you calculate a total daily dose. And that's usually somewhere between, in a very young child who was in mild DKA, it could be a little less, but it's usually 0.5 to 1 unit per kilo per day. And then you based on that total dose, example, 30 units in a 20 kilo child, in a 30 kilo child, you divide that up. If you have a 70-30 or an NPH plus regular regimen, you would divide that into 2/3 in the morning and 1/3 in the evening, and then divide that up into your usual 60% or 2/3 NPH, 1/3 regular. If you transition to a basal bolus regimen, my preferred approach is to say 40% is basal, and 60% is divided equally initially amongst the 3 meals. It doesn't really, the precision at the beginning to me doesn't really matter. You usually underdose anyway and have to then adjust your insulin dosing from there. So again, about 0.5 to 1 units per kilo per dose. The older the child, the higher the dose you'll pick, the more severe the DKA, the more insulin resistant they will be. And so the higher dose you pick. So for example, an adolescent who was in severe DKA, minimum 1 unit per kilo per day, knowing that you will probably have to go up quickly on the doses to catch the hyperglycemia.
That's a very good point, Jill, that you've made. The chat box may not be visible to everybody. To say that when you're meeting alone with the teens, start by asking about their friend group. Do you have friends who smoke? Do you have friends who? And then you can ask them what to do. That's absolutely right. We actually have also a legal problem here. Sex below the age of 16 is rape. So we wonder how to tell a 14-year-old's parents if she's sexually active or he's sexually active. Because if you're not telling the parents, then you're breaking the law. And if you're telling the parents, you're breaking confidentiality. So it's a bit of a cleft stick there.
That's a challenge. I would have to think long and hard about an answer for that.
So if Mahira is giving us a few minutes, Julia, if you could quickly tell us what Arun is asking about fluid replacement. He wants to know how you plan fluid replacement.
Yeah, so I gave the general concept. If you go to the actual guidelines, there's a table that gives you the fluid replacement by kilo, between 10 and 20, you'll give this much. I think it's 6 cc's per kilo per hour. Then it goes down from there. My general approach, I gave the principles because that's what matters. The details you will adjust anyway as the child goes through the recovering process. My approach is usually in mild and moderate DKA, calculate 1.5 times the maintenance fluid. So you take your 20, 30, 40 kilo child, you calculate your maintenance fluids based on the 4-to-1 rule, for example, and then you multiply that by 1.5. And a child is in severe DKA, I will go up to 2 times maintenance because they're usually more dehydrated. And then you adjust the rate from there anyway. If your sodium is not coming down, if your glucose is not dropping as expected, you can increase the fluid rate. Yeah, but if you want like a straightforward, here's the kilos I have and how much do I give in terms of rate, the ISPAD guidelines have a very nice table that goes by kilo.
Hello.
Okay,
I think we can close it.
Okay, great. So Ganesh, would you like to do the honors and thank everybody?
I would like to thank all the 3 speakers and audience for all the interesting questions, and thank the organizers. Thanks, Mahira, for conducting the session so wonderfully. Okay. Good night, everyone.
Thanks,
Thank
you.
Thank
It
you.
was absolutely great
Bye.
fun.
Thanks,
Thank you.
Julia.
Thank you.
Thank you.
Thanks.
Bye, Gram.
Thank you. Bye-bye.
Bye-bye. Bye, Anju. Thanks, Ganesh.
Well, it seems it's not going to be good night yet because Banshi has things up for us.
Thank you. So for next session, Dr. Arun, you are going to take?
Sir, D-dimer is having some value.
Yes, sir. Am
With
I
the
audible?
report here for yes, you are audible.
Yeah. Good evening. Good evening.
Very well.
So this is again a very relevant question. I think Dr. Pancholia sir or Nitin can add to it later. But
Hello.
D-dimer
you have
is
to mute
now
everyone.
a test which is
Arun,
very much
should
abused.
mute
It is like
everyone.
troponin because
Hello.
many people get it done and then they ask the doctors. Sir wants to add.
Yeah, Dr. Pancholia, please.
Yes.
Hello.
When you look at
I'm unable to mute,
this
sir.
Cleveland Clinic protocol about the use of low molecular weight heparin, it is based on the D-dimer level. When the D-dimer level more than 3000 FEU, then you have to give the enoxaparin 40 milligram twice a day. If the D-dimer level is less than 3000 FEU, then you have to give once a day. That is 40 milligram once a day.
Arun, can
So
you
based
see
on
who
the
is
D-dimer
speaking?
level, they have adjusted the dose of low molecular.
Hello. Hello, sir. Am I audible?
Yes. Yes. Now you are audible.
Yeah. Sorry for the trouble. Good evening. So at the outset, let me thank dear Dr. Banshi sir for giving me an opportunity. And of course, I would like to congratulate the entire team, Diabetes India 2021, for this successful event being organized. So without wasting time, we are moving on to the prestigious session this day, that is keynote lectures. So to introduce speaker, I would like to invite our respected chairperson, Dr. Kandula Sai and Dr. Premal sir. Over to you, sir.
Hello.
Hello.
Can you listen? Dr. Premal Thakur is having some medical emergency. Dr. Kandula Sai, you please take over. And to co-chair, Dr. Mahadev Desai is there with you. So Dr. Kandula Sai, over to you.
At the outset, let me thank Banshi and team and Diabetes India for giving us the opportunity to share the session of 2 legends. Truly speaking, it is not good and bad to introduce both the speakers who are well known to the diabetes world. So without wasting any time, and let us take that buffer time for the questions and answers. I invite Sir Anup Mishra sir to speak on pre-diabetes phenotype and intricast. Sir, over to you, sir.
Thank you. First of all, thanks Banshi for giving me this opportunity to attend this wonderful conference. And the second is that it is my honor to speak along with Professor Ralph DeFranco. Can you unshare this slide, please? Yeah, thank you. My topic is something which will evoke some questions and also some doubts and some debate. But it is a topic which is very close to our heart, and I'll show you the reasons. Pre-diabetes is pathological and highly prevalent in India. That is something which is known for quite some time. Now, what is pre-diabetes? Just to recapitulate, either fasting sugar or post glucose, blood glucose is taken. A fasting blood glucose between 100 to 125 is called impaired fasting glucose, and post 75 gram glucose between 140 to 199 is called impaired glucose tolerance. Both together are called pre-diabetes. It is also classified by hemoglobin A1C between 5.7 to 6.4, which is an imperfect measure of pre-diabetes. And in all my patients, I use oral glucose tolerance test to classify people into IFG, IGT, or both together. There is no doubt that pre-diabetes leads to increased risk for cardiovascular disease. And as has been shown in this particular slide, this is an old slide, a 2002 study, which shows that risk for cardiovascular disease is already high when the person is diagnosed to be pre-diabetic, IGT here, more than normal and less than patient with newly diagnosed diabetes. Now, this is the kind of thing that we are seeing in India. This is an article, Prevalence and Trends of Diabetes Epidemic in Urban and Rural India, a pooled systematic review and meta-analysis of 1.7 million adults. Recently published, it shows rising trend of diabetes on the top panel and pre-diabetes in India. What is important to know is the rising trend. And second, it is important to know, as far as pre-diabetes is concerned, that the graph for urban area and rural area have merged together. And that rural area pre-diabetes is rising faster than urban area. Overall prevalence in 2017 was 10.3% according to ICMR India study. Now, prevention of pre-diabetes so that it does not progress to diabetes. There are a number of studies, but there is no study which comes even close to diabetes prevention program. A 4-year study of 3,234 adults where placebo was compared to metformin and lifestyle, and the cumulative incidence of diabetes was shown to be remarkably less with lifestyle intervention. This is a path-breaking study which has been followed by several other studies all throughout the world. And this study was extended subsequently to 15 years. After 4 years, the control trial was opened up, and all three arms, people in all three arms were sent back to their general practitioners. And you can see over 15 years what has happened in this extension study called DPPR study, where the lifestyle still led to best results, but metformin over years 11, 12, 13, 14, and 15 is coming closer to lifestyle. And this was published in Lancet in 2015, and I wrote the editorial for this, and which included some of the questions I'm going to raise in subsequent presentation. This is the Indian study, Dr. Ramchandran's seminal study, where the arms, lifestyle metformin and lifestyle metformin, were compared with controls, and it was shown that all three arms were similar. The dose of metformin was lower in this particular study than what has been used in DPP4. Now, emerging questions are, which factors hinder reversal from prediabetes to normal glucose regulation? What are these factors? And if we face such situation, should we be aggressive in application of lifestyle drugs? And this is very important as far as Indian population is concerned. So let's look at some of the factors. One of the first factor is ethnicity, and Asian Indians being the central point of all ethnic groups. And if you look at this excellent diagram from Sattar in Lancet in 2015, it shows the rising curve from normoglycemia to diabetes in the Asian Indians in UK and versus the white Caucasian. And this graph is so good, so separated from each other. Progression to diabetes is 12 to 18% per year in Asian Indians versus 5 to 11% in white Caucasian. And if we apply the lifestyle modification, then it is reduced by 30% in Asian Indians and by 50% in whites. So the progression is more, and reduction to normal glucose regulation is much less in Asian Indians. And so diabetes is earlier by 5 to 10 years in South Asia. And this very clearly demonstrates the differences between Asian Indians and South Asians. Age is the next factor. And this has been very, very clearly shown in the DPP4 study. If you look at the three age groups, 25 to 44, 45 to 59, and more than 60 years, and comparison of lifestyle with metformin and placebo, there are clear points which have been raised in the age group more than 60 years. One thing is that the lifestyle works better in people with more than 60 years of age, in this particular study and in this particular ethnic group. And metformin works a little less as far as this age group. So these are two lessons of this particular. So age is something we have to keep in mind whenever we are applying either lifestyle or metformin. Now, non-obese individuals are a particular subgroup of individuals that we often see in India as having diabetes. And you can see there are a number of studies. I have taken one particular study where Indians' BMI and development of diabetes has been compared to Japanese, Maltese, Europeans, and Chinese. And if we could look at the BMI between 17, 18 to 23, you see the men and women, both Indians, have a very high prevalence of diabetes as compared to the other. So in non-obese people, Indian people, diabetes is already rising. Now, what is the implication for that? In non-obese people, the beta cell mass is also less. This is an old study, but very good study. It has compared beta cell mass between the two groups of individuals, obese and lean. And you can see beta cell mass in non-diabetic people who are obese is much higher than non-diabetic people who are lean. We'll come to this beta cell mass again in subsequent discussion. So this is not the end of it. Early remission of prediabetes. Now, suppose we apply the lifestyle factors very aggressively. If somebody remits very early, this is the data, very clear data, which has been published in Lancet in 2012. The DPPO study, which I was mentioning earlier, where people who never reached normal glucose regulation versus people who reached normal glucose regulation at least once during the 4 years in DPPP were compared. The moment somebody reaches the normal glucose regulation and as early as possible, then their chances of getting diabetes is much lower. Now, a topic which is center to my heart, liver is the center of the metabolism, predicts diabetes and impedes regression to normal glucose regulation. This is our data, a very simplified form. It shows that if liver span, at that time, 2015, we did not do the MRI proton fat fraction, which we are doing now. At that time, we did the liver span, which is a fair indicator of the fat in the liver. This is the normal liver with the liver span of 11 centimeter, and this is the liver, which is full of fat, maybe grade 3 fat, with a liver span of 22.8 centimeter. We did a study where we predicted that if liver span cutoff is at 15.6, if more than that, if anybody has liver span more than that, chances of getting diabetes is at least 4 times higher. So liver is anyway is a problem as far as Indians are concerned, because liver fat is far higher in Indians than the Western population. Now, this group, Stefan, published in 2015 in Diabetologia, compared two groups of people, high-risk phenotype and low-risk phenotype. High-risk phenotype, what was it? Insulin resistance plus non-alcoholic fatty liver disease. 9 months of lifestyle intervention, and look what happened to the fat loss and post-prandial blood glucose, which is much less affected than the low-risk phenotype, meaning thereby low-risk phenotype had higher fat loss and higher decrease in PP glucose, and revert to normal glucose tolerance was much lower in high risk. So something is happening when the person has non-alcoholic fatty liver disease as well as insulin resistance. And this group has been working on this, and next 5 years, they extended their observation and published this study in Diabetologia again 2021. And they now have 6 groups. Low risk group, very low risk group, beta cell failure group, low risk obese group, high risk insulin resistant fatty liver. This was the group which I showed you in the earlier slide. And another group, high risk visceral fat nephropathy group. Now they did insulin sensitivity, insulin secretion, glycemia, and other features. This 3 groups stood out. Beta cell failure group, high risk insulin resistance fatty liver group, and high risk visceral fat nephropathy group. They had higher risk for development of diabetes. An imminent risk of development of diabetes was in these 2 groups, where insulin sensitivity was moderately low and insulin secretion was low, and fatty liver group, which I showed you. And high mortality was seen in this group. High risk all-cause mortality was seen in high-risk visceral fat nephropathy group, where fat is mostly located in the renal sinus. So these are the various phenotypes which we have to see, but any of classification requires money and equipment. Gestational diabetes is something which is important to know. And if you see this, development of diabetes after gestational diabetes, cumulative incidence is very, very fast and high during 10 years of follow-up, and after which it stabilizes. And in India, it is particularly high. A study of 267 women at median of 20 months after the delivery, dysglycemia was found in 57% of patients, diabetes in 10%, and pre-diabetes in 47%. So Indian women are at higher risk for development of gestational diabetes, and this is a particularly high group. If sugar is rising a little bit, it is going to rise to diabetes, certainly after some time. There are other factors also. Family history of diabetes, type of pre-diabetes, more difficult to regress with IFG, and conversion rate was lower in subjects with low than high BMI, which I showed you in earlier slides. There are a number of factors where not much is known. One is pancreatic fat, which we have been researching for quite some time. This is our study where you see left side a pancreatic outline, which has been shown from MRI study, and a volume is 47.6. Right side, smaller pancreas, 45. This guy is diabetic, although BMI is not much, and this guy is non-diabetic. Pancreatic fat alone may be a feature of type 2 diabetes, and if we decrease pancreatic fat, it may lead to regression. Now look at this study which was done in 2011, based on which several protocols for reversal of diabetes were developed. 11 patients, only 600 kilocalorie diet, reversal of fasting blood glucose to normal within first week of 8 weeks. Hepatic triglyceride content decreased from 12.8 to 2.9%. And pancreatic fat decreased from 8% to 6%, just 2% decrease in pancreatic fat. So all this possibly contributed to reversal of diabetes. Hence, pancreatic fat may be an important factor, and we are looking at that. Low insulin secretor genotype. Again, there are a number of studies like genetic factors associated with low insulin secretion, and a recent study in Cell Reports in 2020, where these authors metabolically phenotyped and also looked at their pancreatic cells, because pancreatectomy was done in these patients, and impaired glucose tolerance. It was seen that insulin secretion first phase was down, which is well known, but beta cell mass is not different from patients with diabetes. So we earlier showed that beta cell mass may be different in this particular study in Caucasian people. In pre-diabetes and diabetes, beta cell mass is similar. Now, there are some other fat deposition like dorsocervical and chin fat deposition. Now, look at this particular phenotype, familial partial lipodystrophy, and look at this female, where the fat is absent from arms and legs, but more fat is present under the chin. This is double chin. This is the autosomal dominant phenotype, and associated with early diabetes, and this is caused by Lemon AC mutation. Now, there are several phenotypes which we see in normal people who do not have this mutation. Double chin is seen often, and also a buffalo lung hump-like picture similar to Cushing's syndrome, HIV-associated lipodystrophy is also seen, and we previously showed that this is associated with insulin resistance, metabolic syndrome, and pre-diabetes also. This is another phenotype which needs to be discussed, which needs to be researched more. And this is another patient. You can see a patient with a marked buffalo hump, marked acanthosis nigricans. This patient has been pre-diabetes. Another factor is low muscle mass. Now, this is particularly prevalent in Indian population, along with excess body fat. Now, this sort of thing is related to, at least muscle mass is related to a mutation in the gene called myostatin. And look at this NEJM paper, a myostatin gene mutation in a newborn, where muscles are so big, like Hercules. This is the little Hercules. Look at the muscle in the thigh versus in this particular patient versus the normal newborn, double the size. Mutation increased the muscle size. We looked at myostatin mutation, and we published in PLOS One, and we found that polymorphism of myostatin mutation, polymorphism of myostatin gene led to decrease in the muscle mass and increase in the fat. Now, this phenotype again may be difficult and associated with dysglycemia, because muscle mass needs to be increased and body fat needs to be decreased. And finally, low vitamin D. Everybody is talking about vitamin D, whether it's a COVID-19 or diabetes. And Indians, 80 to 90% have low vitamin D. Is it related to glycemia? There are a number of studies. Randomized controlled trials in countries other than India. You see, most of the studies have not shown any association. This is one of the largest studies. And randomized controlled trials in India, this is our study on the top, the longest study, the largest study, and shows positive association apart from other studies also. This was published in PLOS One, 78-week randomized placebo-controlled trial. We showed that supplementation of vitamin D for 18 months led to decrease in the pre-diabetes to the significant degree, whether it's fasting blood glucose, impaired fasting glucose, or impaired glucose tolerance is concerned. So I summarize my presentation. Pre-diabetes is an important intermediate condition which identifies those at risk for diabetes and also for coronary artery disease. It is common in Asian Indians and increasingly common, and conversion to diabetes is faster than in whites. Identification of difficult phenotypes which may impede conversion of pre-diabetes to normal glucose regulation is important for application of aggressive lifestyle and medical therapy. Amongst these important are age, quick remission of pre-diabetes with lifestyle measure, and presence of non-alcoholic fatty liver disease. More research is needed on several proposed phenotypes, for example, excess pancreatic fat, low muscle mass, and other genotypes. Thank you.
Thank you very much, sir. We'll take the question and answers after second part, I think. Now I invite another legend, Professor Di Franzo. Again, I don't interfere with this introduction because very well known to world and more so with Indians. Sir is speaking on SGLT2 inhibitors, cardiorenal metabolic drugs for the ages. Sir, over to you.
Good, thank you. It's a pleasure to be here and to be here with Professor Misra. I need a second just to get my screen up here. Hopefully this will, it says you cannot start screen share while the other participant is sharing. So whoever is sharing their screen needs to unshare so I can start to share my screen. Okay, thank you. Give me a second here. Getting closer. Un momento. Okay, slideshow, play from start. Okay, now I can see the screen. Hopefully you can see the screen. Are we okay? All right, again, it's a great pleasure to be with you today, even though it's virtual. I think in the US, this COVID epidemic is starting to quiet down. I know it's still raging in India. But hopefully a year from now, things will be under control and we can get back to reality and I can come to India and do this presentation in real life. So it's a great pleasure for me to talk about SGLT2 inhibitors since I invented this class of drugs back in the late 1980s. And at that time, I actually did appreciate the metabolic and the renal benefits, but really did not have any idea of the enormous cardiovascular benefits that were going to emanate from the use of this drug in diabetic patients. So today, I am going to review with you three aspects of the SGLT2 inhibitors. I'm going to talk about their metabolic effects because, of course, we do want to make sure that glycemic control is maintained in our diabetic patients to prevent the microvascular complications. Secondly, I will talk about the cardiac benefits and the large cardiovascular prevention trials that have come out in the last 5 years. And then lastly, I will talk about the renal benefits. So let's get started. And I'd first like to just briefly review how the kidney handles glucose so that we all understand how these drugs work and why they're going to be of great benefit in our diabetic patients. So every day we filter about 180 grams of glucose. And as you can see in the bottom right, no glucose appears in the urine. So how does the kidney reabsorb all of this glucose? So early in the proximal tubule, there's a transporter, the SGLT2 transporter. I think everybody knows the S is for sodium, GL is for glucose, T is transporter. And this SGLT2 transporter takes back 90% of the filtered glucose. And if it does its job, distal to the SGLT2 transporter is the SGLT1 transporter, and it takes back the remaining 10% of the glucose. So everybody in their medical student days learned what a renal glucose titration curve was. And I'm quite certain that as you were taught this by your professor, you felt that it was of no importance and you immediately deleted it from your memory bank. But I'm going to review with you what a renal glucose titration curve is, because this is essential to understanding how these drugs work. So what I'm going to do is plot on the x-axis here the plasma glucose concentration, and then on the y-axis the amount of glucose that appears in the urine. I'm going to insert an IV, and then I'm going to raise the glucose from 100 to 120 to 150 to 180. And you can see no glucose appears in the urine. But when I get to a plasma glucose concentration of 180, this is the threshold now at which glucose starts to appear in the urine. And as I raise the glucose progressively above 180, all of that glucose is excreted in the urine. And this is a normal glucose tolerant individual with an A1C of 5. But as we showed many years ago, if you look at a person with type 2 diabetes, and please note that this is really a very mild individual, A1C is 6.5, that threshold for spilling glucose into the urine is no longer 180. It's significantly elevated to about 205 milligram per deciliter. And then paradoxically, as the diabetes worsens, if we look at an individual with an A1C of 7.5, you can see the threshold is 220. And if the A1C rises to 8.5, the threshold goes up further, and so forth. So this is exactly what we don't want to have happening in our diabetic patients. What we would like, as the blood glucose concentration goes up, for the kidney to dump that glucose into the urine. But in contrast, what the kidney is doing is holding on to the glucose, and of course, leading to a deterioration in glycemic control. So how do the SGLT2 inhibitors induce glucosuria, and how do they reverse this defect at the level of the kidney? So just to repeat what I showed in the previous slide, as we take a normal glucose tolerant individual's glucose from 100 to 180, no glucose in the urine. Now we reach the threshold, all of the glucose filtered above that appears in the urine. If we have a diabetic patient with a glucose of 220, you can see that the threshold is significantly increased. Now, if we were to take this person and put this person on an SGLT2 inhibitor, and we've done this study with both dapagliflozin, the reference for this is in the bottom. We've also done it with empagliflozin, and I'm sure if we did it with canagliflozin, we'd get the same result. So how low do we lower the threshold? Do we lower it back to 180? No. Do we take it to a normal fasting glucose of about 100? No. What we do is we lower the threshold to well below the fasting glucose in someone with normal glucose tolerance. We lower it to about 40 milligram per deciliter. So what does this mean? This means there is no such thing as a non-responder. Why? Because if I were to take anybody who's listening who has normal glucose tolerance, and I put you on an SGLT2 inhibitor, you would, over the next 24 hours, excrete 60, 70, 80 grams of glucose. Now, if you really are thinking about this, if I lowered the threshold to 40, why doesn't every person develop hypoglycemia? Well, as we've shown, and this article is published in Diabetologia, hypoglycemia does not occur because what happens as soon as the glucose appears in the urine, there's a signal that goes to the liver, and this signal is mediated by the renal nerves. And now the liver produces an amount of glucose, which is identical to the amount of glucose that's appearing in the urine. So what's the importance of this? You can use the SGLT2 inhibitor with no fear of inducing hypoglycemia, unless, of course, you're giving it to someone who has insulin on board or a sulfonylurea on board. So this is an enormous benefit for the cardiologist who doesn't like to take care of diabetes, because now the cardiologist can just view this as a cardiovascular drug. In fact, the cardiologist should view this as a drug that was invented by the cardiologist, because they don't have to worry about hypoglycemia. And the same for the nephrologist, and the same for the primary care doctor, okay? So the lack of hypoglycemia now makes it very easy for physicians, no matter what their specialty is, and for primary care physicians to use this drug safely. Now, in 1987, when I gave the Lilly lecture at the American Diabetes Association, and we're going to switch now and talk a little bit about the metabolic effects of these drugs, I called it the triumvirate. There were three problems that we had to deal with in the diabetic: insulin resistance in the liver, excess glucose production throughout the sleeping hours, cause of fasting hyperglycemia. Insulin resistance in the muscle. This is what causes post-meal, postprandial hyperglycemia, and of course, beta cell failure, which is going to exacerbate the insulin resistance in the muscle and the liver. But when I gave the Banting lecture at the American Diabetes Association in 2008, I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So 5 more players that we have to deal with. Insulin resistance in the fat cell. So how does this come into play? When you eat excess calories, you can store them in the fat cell, and as long as they stay there, they can't hurt you. But as the fat cells start to expand, they become resistant to insulin. They break down the triglycerides, they release the FFA into the bloodstream. Elevated FFA impair insulin secretion, cause insulin resistance in the liver, in the muscle. The gut at the top is a giant endocrine organ, and it secretes 2 incretin hormones, GLP-1 and GIP. And these 2 incretin hormones are critical for stimulation of insulin when you eat a meal. In fact, 70% of the insulin that's secreted in response to a meal is dependent upon GLP-1 and GIP. And what we and others have shown is that the beta cells are quite resistant to GLP-1 and GIP. We also know that the alpha cell hypersecretes glucagon, and that excess glucagon secretion drives hepatic glucose production throughout the sleeping hours. And then at the bottom, the brain also plays a very important role in the pathophysiology of type 2 diabetes, because the appetite regulation centers in the hypothalamus have become resistant to a number of appetite suppressing hormones, and in particular have become resistant to GLP-1. And that GLP-1 resistance at the level of the brain leads to weight gain. Not surprisingly, the majority of our diabetic patients are overweight. And when you gain weight, you become very resistant to insulin. And then the last of the ominous octet that we're going to talk about today is the kidney. And as I've shown you in the last couple of slides, the threshold for spilling glucose into the urine is markedly increased and plays a major role in the hyperglycemia and pathophysiology of type 2 diabetes. So if we have 8 problems to deal with, it should be very clear there's no one drug going to correct these 8 problems. And that means that we're going to need drugs that correct multiple of the problems, and we're going to have to use the drugs in combination. So let's now turn our attention to the level of the kidney, because we have the SGLT2 inhibitor class of drugs, which we shown many, many years ago, works on the kidney to promote glucosuria. So the primary effect of the SGLT2 inhibitors is to enhance glucose excretion in the urine. But as the plasma glucose now starts to come down, as a secondary benefit, we reverse glucotoxicity. And what we've shown, and we've done this actually with all 3 of the major SGLT2 inhibitors, we get about a 98% improvement in beta cell function, and in muscle, we get about a 35 to 40% improvement in insulin sensitivity. So from the metabolic standpoint, the SGLT2 inhibitors are correcting 3 of the major defects that are present in the ominous octet. And they're meeting a very important unmet need in our diabetic patients by correcting this defect at the level of the kidney. We reverse glucotoxicity. We get a very nice decline in the HbA1c. And of course, the closer to normal we can get the A1c, the less likely our patients are going to develop the microvascular complications. But as we enhance glucose excretion in the urine, we're losing calories. And within the first 6 months, people treated with SGLT2 inhibitors lose about 2.5 to 3 kilograms. And that obviously is playing a role as well in the improvement in insulin sensitivity. And to the right here, you can see because these drugs work on the kidney, they can be combined with all of the other anti-diabetic agents. These drugs block sodium reabsorption as well as glucose reabsorption at the level of the kidney. And you go into slightly negative sodium balance, and we get a nice reduction in the blood pressure of about 5 to 6 systolic. And as I pointed out to you earlier, no hypoglycemia. So the SGLT2 inhibitors improve glycemic control. And that means that we're going to reduce the risk for microvascular complications. But we're also correcting a number of cardiovascular risk factors. And in doing so, one might expect there to be some cardiovascular benefit. So let's now turn our attention to the SGLT2 inhibitors and their effect on cardiovascular disease. So the very first cardiovascular intervention trial was carried out with empagliflozin. This was a very, very large study. And the primary endpoint in this study, shown in the left panel, is the MACE endpoint. MACE stands for Major Adverse Cardiovascular Events. There are 3 of them, of course: non-fatal MI, non-fatal stroke, and cardiovascular death. You can see a hazard ratio of 0.86, a 14% reduction in the MACE endpoint. And this resulted in approval of this drug by the Food and Drug Administration in the United States. But look at this very profound effect on cardiovascular mortality. Hazard ratio of 0.62, of course, highly statistically significant, and also noted as a secondary endpoint with this big marked decrease in hospitalization for heart failure. So this was really a game changer in the treatment of people with type 2 diabetes, because now we have a drug which not only lowers glucose to prevent the microvascular complications, but has quite dramatic effects to prevent cardiovascular disease, which is accounting for 80% of the mortality in our diabetic patients. Now, I'm not going to go through each one individually of the other cardiovascular trials, but I've combined them for you here on one slide. So in purple here is the EMPA-REG trial. In green is the CANVAS program with canagliflozin. In yellow is the DECLARE program with dapagliflozin. You can see for the MACE composite endpoint, all 3 of the dots falling to the left of the line. Now, what about cardiovascular death? In looking at these points, you may first think that these drugs actually have different effects, but I have studied these drugs extensively, and I can assure you that these drugs really are all quite similar. So why do we see such big difference here in terms of cardiovascular mortality? The difference, in my opinion, is more related to the patient population than to each individual drug itself. So in the EMPA-REG outcome study, in order to get into this study, all of the people had to have a previous cardiovascular event. So they're at the highest risk for experiencing a life-ending complication. So not surprisingly, where do we see the big benefit? We see it in preventing cardiovascular mortality. On the other hand, if we take a look at the DECLARE study in yellow, 2/3 of the people in this study got in because they had risk factors, not because they had an event. So this is the least sick population, and we don't see much of an effect in mortality. On the other hand, if we look at the CANVAS program, they're intermediate in risk for cardiovascular death, and they're also intermediate in terms of the percentage of people who had a cardiovascular event. 2/3 had a cardiovascular event. So as I said, I believe that this difference that we see here is more related to the patient population. Non-fatal MI, all the points to the left, very similar. Now, what's surprising to all of us and remains surprising is that none of these drugs really affected stroke. And so why is that surprising? Well, hypertension is a major risk factor for stroke. And these drugs, as I pointed out to you, decrease the systolic blood pressure about 5 to 6 and diastolic 1 to 2. So the lack of benefit here in prevention of stroke still remains unexplained. Now, as a secondary endpoint in all of these studies was hospitalization for heart failure, hazard ratio 0.7, highly statistically significant. And then even more dramatic was this marked decrease in the composite renal outcome. Now, we'll come back to heart failure and renal disease because these were secondary endpoints. And because they're secondary endpoints, the FDA does not give approval for an indication for any secondary endpoints, okay? So let's now look at heart failure. As we are treating our diabetic patients better and they're living longer, heart failure is becoming a major problem. And we have a very nice study, DAPA Heart, that was published by Murray et al. In the New England Journal of Medicine in 2019, in which the primary endpoint was hospitalization for heart failure, cardiovascular death, or urgent care visit. The other thing that I need to point out to you is that in this study, there were both diabetics and non-diabetics, and the results that I'm going to review you were virtually identical in the diabetic and non-diabetic patients. So the benefit that you're going to see has got nothing to do with glucose lowering. So if we look at the primary outcome, which is this composite, you can see that dapagliflozin markedly decreased the hazard ratio, 0.74, 26% decrease in cardiovascular events. And I want to emphasize that these curves separate very quickly within the first 3 months. If we look for hospitalization for heart failure, exactly the same picture, hazard ratio 0.70, and importantly, cardiovascular death 0.82. The other thing that I should point out to you in this study is that if you look at the non-diabetics, there was no hypoglycemia. As I reviewed with you earlier, there should be none, and there was no incidence of DKA. So this is a very safe drug to use in your non-diabetic population as well. Now, more recently, we've had the EMPEROR reduced it, in which the primary endpoint was cardiovascular death and or hospitalization for heart failure. And you see a result which is very similar to DAPA heart failure, hazard ratio 0.75, highly statistically significant. And again, you see the curve separating very early. We'll come back to why this separation occurs very early. So what have these studies told us? So I would say the most important thing that they've told us is that these drugs are incredibly safe. Okay, you thought I was going to say cardiovascular benefit. Well, I'm going to get to that in a second, but this is an incredibly sick population, and the incidence of serious adverse events and side effects was really quite small. So is this a class effect? Well, I hope that I've convinced you by showing you the data with 3 different SGLT2 inhibitors is that this is a class effect. What about generalized ability? Okay. I think now that we have the DECLARE study, it's telling us we can move back in time, that we're going to see the cardiovascular benefits in people who have risk factors. You don't have to already have an established event. And then what about the mechanism of action of the SGLT2 inhibitors? So this is a study that Dr. Abdul-Ghani and I published about 3 years ago, and you can read it in Diabetes Care. I believe that the major mechanism of the benefit is related to the hemodynamic effects. So we get a very nice reduction in blood pressure, which decreases the afterload, and we put people into a negative salt and water balance, so we decrease the preload. And these two happening simultaneously very quickly are playing, I believe, a critical role in the benefit that we see. Now, one of the other important things that was observed in all of the cardiovascular outcome trials is no increase in heart rate. I'll come back to that in a second. a number of studies have shown that the SGLT2 inhibitors also have a pronounced effect to decrease arterial stiffness. And that's very important because we're seeing in the aorta this decrease in stiffness. And so actually the decrease in aortic pressure is much greater than the decrease in blood pressure that you are measuring in the periphery. So this is a real benefit in terms of further reduction in the afterload. Now, because there was a failure of the heart rate to go up, even though we're decreasing the blood pressure and decreasing the plasma volume, this strongly suggested an inhibition of sympathetic nervous system activity. And Dr. Abdul Ghani and our group, in fact, using norepinephrine, labeled norepinephrine, has in fact shown that this class of drugs does decrease sympathetic nervous system activity. So all of these factors together that you can see from the hemodynamic standpoint would be expected to decrease cardiovascular events and reduce problems in terms of heart failure. Now, the other factor, which I believe is playing a very important role, is a decrease in glucose, which we showed many years ago is associated with an increase in ketones. So it turns out that ketones are a preferred fuel that are taken up by the myocardium. When the heart takes up ketones, it will oxidize the ketones very efficiently, and it will generate more ATP with less oxygen consumption than with what normally happens with free fatty acids. And we now have produced data that's been presented in abstract form that raising the ketones to levels that are seen with treatment with SGLT2 inhibitors markedly increase cardiac output and improve both systolic and diastolic function. Now, there are a number of other mechanisms that have been implicated, but I don't have time to go through all of these. Insulin resistance is, of course, a risk factor for cardiovascular disease. These drugs improve insulin sensitivity. They also lower glucose. As I said, they promote weight loss. They decrease visceral fat, which is associated with atherosclerotic disease. I don't believe that uric acid plays a role in the cardiovascular disease that we see in diabetics, but these drugs also do increase uric acid excretion and reduce the plasma uric acid concentration. The SGLT2 inhibitors increase the Ang1-2 system. That's the beneficial system, so that this may be another mechanism. There are now very good data that these drugs are anti-inflammatory and decrease oxidative stress, and a lot of interest in the sodium proton exchanger, which has been shown to increase in both the heart as well as in the kidney. The SGLT2 inhibitors inhibit this pump. Let's now look at the third component that I wanted to cover, and that is the SGLT2 inhibitors and diabetic nephropathy. So as I showed you in all three of the big cardiovascular outcome trials with DAPA, CANA, and EMPA, the secondary endpoint was a composite renal outcome, and it was significantly reduced, actually quite markedly reduced. But for secondary endpoints, as I pointed out to you, the FDA does not give approval. But we have now two studies in which the composite renal outcome was the primary outcome. We have the Credence study here, 4,400 patients, and you could get into Credence because you had a reduced GFR between 30 and 90, or you had macroproteinuria. The primary composite outcome was end-stage kidney disease, meaning dialysis, transplantation, doubling of your serum creatinine, or renal cardiovascular death. So this study was published by Dr. Perkovic in the New England Journal of Medicine 2 years ago. And you can see placebo in yellow, canagliflozin in red, orange. The curves start to separate at 1 year and they progressively separate thereafter. Hazard ratio is 0.70, meaning a 30% reduction in the relative risk of the composite outcome. So let's now take a look at the renal specific outcome stratified by glomerular filtration. If we take a look at all of the subjects, the renal specific hazard ratio is 0.66. But now, people with very low GFRs, 30 to 45, 45 to 60, or 60 to 90, all benefited significantly. So it really doesn't make any difference where your GFR is. Now, an interesting part of the Credence study has to do with the subjects at the lower GFR cutoff. So in order to get into Credence, I told you that you had to have a GFR between 30 and 90. That was on screening. But when now the subjects actually were enlisted into the study, about 5% of the people actually had a GFR less than 30. Because I'm oftentimes asked, how low should we go in terms of using the SGLT2 inhibitors? So this is now studied, published by Dr. Bakris in the Clinical Journal of the American Society of Nephrology. And he looked to the left at the hazard ratio for kidney failure, meaning ending up on dialysis or transplantation, in people who had a GFR, first yellow bar, greater than 30 or less than 30, second yellow bar. Hazard ratio is identical. If we now look to the right, this is the slope of decline in GFR in people with a GFR above 30 in yellow or less than 30 in orange, virtually identical. So even in those people, it's about 5% of the people who had a GFR less than 30, you see the benefit. So in my opinion, these people should be continued on the SGLT2 inhibitor until they end up ending up in dialysis or having a renal transplant. We also have a second study, DAPA-CKD with dapagliflozin in patients with chronic kidney disease, which showed data very, very similar to Credence. But it takes us a step further because in DAPA-CKD, 37% of these, 33% of these people were non-diabetic. And the data that I'm going to show you, the non-diabetics did as well in renal protection as did the diabetics. So very large study, 4,300 people treated with dapagliflozin, 10 milligram per day, duration of follow-up 2.4 years. And you can see that this curve looks very, very similar to the Credence study. So the curves start to separate here at about 10 to 12 months, and they separate progressively thereafter. And look at this striking hazard ratio, 0.56, 44% reduction in the renal specific composite outcome. Now, what about the slope of decline? This is very, very important, and this has to do with the 30% rule, which I'll come back to explain to you in a second. Now, what we know is that in people with diabetic kidney disease, as well as non-diabetic kidney disease, there's an increase in intraglomerular pressure. And that gives you a false sense of security because it's maintaining the GFR initially. But on a long-term basis, that increase in intraglomerular pressure damages the kidney. So when you put the person on the SGLT2 inhibitor, what you're going to see is a small drop in the GFR. And clinicians get nervous about this drop. You should get nervous if there's no drop, because the fact that there's a drop in the GFR means you've decreased the intraglomerular pressure. And on a long-term basis, you're going to preserve renal function. And you can see that within 12 months, these curves cross. And now the slope for the rate of decline with dapagliflozin is significantly slower than that with placebo. So how much of a drop in eGFR can you tolerate? Okay, that's the 30% rule. And it's not so much by measuring the GFR, it's by measuring the serum creatinine. So as long as the rise in serum creatinine does not exceed 30%, you're okay. If it exceeds 30 to 35%, you need to bring the person back in 1 to 2 weeks and to repeat the serum creatinine to make sure that everything has stabilized. Now, what is the standard dogma to explain the renal benefit? So we know that people with diabetes, whether they're type 1 or type 2, they're hyperglycemic, they filter more glucose. And in the proximal tubule, and you just can read along with me here, they're going to reabsorb more sodium in glucose, thereby decreasing the delivery of sodium to the macula densa cells of the juxtaglomerular apparatus. So the kidney perceives this as a decrease in the circulating volume, and it sends two signals. It sends a signal to the afferent arteriole to vasodilate, and it sends a signal to the efferent arteriole to vasoconstrict, and this increases the intraglomerular pressure. This is what's causing the damage to the kidney on a long-term basis, but it also, early in the natural history of diabetic kidney disease, is associated with hyperfiltration in large kidneys. Now, this is sort of the standard mechanism, the action that's put forward. However, I should point out to you that these data are primarily generated from people with type 1 diabetes and type 2 diabetes, very different disease. So type 1 diabetes, these are usually younger people with very vasoreactive blood vessels. People with type 2 diabetes are much older. There's an age-related decline in GFR. They have sclerotic arterioles within the kidney. They're less responsive to neurohormonal stimuli. And recent data, particularly from a Dutch group, has shown, contrary to what most of us have been told, is that the major effect of the SGLT2 inhibitors is on the efferent arteriole to cause vasoconstriction. This Dutch paper in type 2s strongly suggests that the major effect is on the efferent arteriole to cause reverse the vasoconstriction. Now, in addition, this idea that tubular glomerular feedback is the primary and only problem is really taking a very myopic view of diabetic nephropathy. So just as in my Banting lecture, I put forward there's an ominous octet for pathophysiology and glycemic control, there's an ominous octet for diabetic nephropathy. And I have published just last month an extensive review on this if you want to read about it in more detail in Nature Nephrology Review. So yes, no doubt deranged tubular glomerular feedback plays an important role. But if you want to prevent diabetic kidney disease completely, just control the glucose. If the A1C stays less than 6.5, you aren't going to develop diabetic kidney disease. We also know, and this is very clear from studies carried out by Hans-Hendrik Parving some 40 years ago, the most important factor that accelerates the decline in renal function is hypertension. So we need meticulous blood pressure control. That means less than 120/80. We also know that the kidney is hypoxic. Okay, so all that sodium that's reabsorbed in the proximal tubule with glucose needs to be pumped out of the proximal tubule cell, and that's done by the sodium potassium ATPase pump. That pump requires energy in the form and it requires oxygen. And it turns out that the increase in renal plasma flow is not sufficient to meet the oxygen demand, and so the kidney itself is hypoxic. And the hypoxic kidney now leads to the activation of a whole host of inflammatory pathways. It leads to an increase in oxidative stress. We also know that the podocytes play a very important role in the development of diabetic kidney disease. So if you don't remember, those podocytes sit on the glomerular basement membrane, and with the foot processes prevent albumin from getting into the Bowman space. So hyperglycemia damages the podocytes, albumin leaks into the glomerulus, and this promotes glomerulosclerosis. The great majority of our diabetic patients are overweight. And we now recognize that if you look at the diabetic kidney, there's fat everywhere in the kidney. There's fat in the mesangial cells, and the glomerular cells, and the tubular cells. And this fat causes glomerulosclerosis and incites interstitial disease as well. If we look at the kidney, in addition to the glomeruli hypertrophy, the tubules hypertrophy, and they release growth factors which cause the glomeruli to hypertrophy. The pressure within the glomeruli is proportional to the radius. So now once the glomeruli hypertrophy, this is a self-fulfilling cause of the increase in intraglomerular pressure. And then lastly, we know that there are genes is a strong genetic background, although we have yet to identify these genes. So we have at least 8 problems to deal with. So no one drug is going to correct 8 problems. But look at the SGLT2 inhibitors here. They correct 6 of the ominous octet for diabetic kidney disease. So they are going to be a critical tool in preventing diabetic kidney disease. But as I said, we're not going to correct and prevent diabetic kidney disease with one drug. So we have the ACEs and the ARBs. They work on the efferent arteriole to block the vasoconstriction and decrease intraglomerular pressure. We have the SGLT2 inhibitors, which probably work both on the efferent and afferent arteriole. And then just recently, we have a very nice paper with feninerone, which is a mineralocorticoid receptor antagonist published in the New England Journal of Medicine, which has both renal as well as cardiovascular protective effect. There is suggestive evidence that the GLP-1 receptor agonist may also play a role here, but we're going to have to wait to see the results of the FLOW study. Now, as we come to the end here, these cardiovascular and renal studies have finally forced the American and European Diabetes Association to change their algorithm for the treatment of type 2 diabetes, which in my opinion has been outdated and in certain ways still remains outdated. So they still recommend, if you have atherosclerotic cardiovascular disease, heart failure, or renal disease, metformin as first-line therapy. Well, I like metformin. I single-handedly brought it to the United States in 1995, but metformin has no demonstrated cardiovascular protective effect. It has no renal protective effect. In my opinion, should not be first-line therapy in people who have atherosclerotic cardiovascular disease. What the ADA says, metformin first-line therapy, next drug on board, GLP-1 receptor agonist, which I haven't talked about, or SGLT2 inhibitor. These should be the first-line drugs for these patients. If you have heart failure, the first-line drug on board should be an SGLT2 inhibitor. Or if you have renal disease, the first-line drug on board should be an SGLT2 inhibitor. Well, if you want to start the metformin with the SGLT2 inhibitor, that's okay. But I wouldn't be starting the metformin and then waiting to later start the SGLT2 inhibitor. So in conclusion, the SGLT2 inhibitors have many, many benefits. They lower the A1C, they reduce blood pressure, they promote weight loss, and importantly, they don't cause hypoglycemia. They can be used in combination with all of the other anti-diabetic drugs because they work by a different mechanism on the kidney. We have very, very strong and impressive data that they reduce cardiovascular events and prevent heart failure and people with type 2 diabetes with or without a previous event. They slow and prevent the progression of diabetic kidney disease in diabetic as well as non-diabetic individuals. In my opinion, these drugs should be considered as first-line therapy in all type 2 diabetic patients, whether they have cardiovascular disease or renal disease. And these drugs should be used by cardiologists. They should be used by nephrologists and primary care docs. These are just not drugs for endocrinologists. Everybody has to use them. So in ending, I thank you very much for your presentation, and I hope I can be with you in person next year to be at your annual meeting.
Preferably, yes, sir. Next year also will come. Any questions regarding to both the speakers? Sir, can I ask one question?
Go ahead.
What about the role in EMPA vision trial?
I'm sorry, what about?
In retinopathy. Retinopathy.
Retinopathy. Yeah. They're actually, it's interesting. That was not looked at in any of the SGLT2 inhibitor studies. But actually, there is a recent publication showing, in fact, that the SGLT2 inhibitors actually slow the progression of diabetic retinopathy. And that actually is not so surprising because there is hyperemia in the retina and the SGLT2 inhibitors reduce retinal blood flow and improve oxygenation. So there's also, remember, with the SGLT2 inhibitors, I didn't get into this, there's an increase in erythropoietin, and the hematocrit actually goes up by about 2 to 3%. So this provides more oxygen to the kidneys and also more oxygen to the retina. So I actually am surprised that it's taken so long for someone to actually do a study looking at diabetic retinopathy, but the study actually showed quite a benefit.
Dr. Sai, can I ask a question, Dr. Sai, or Dr. Ashok Das here?
Please,
Difronjo, it was a very, very important lecture. Just wanted to add the beautiful that euphoria, cardiovascular euphoria who showed SGLT2. Can we also add the improve in the hematocrit value that also contributes to a heart failure benefit?
Absolutely. So Silvio and Zucchi, and Ellie Ferranini published a paper on this. And, again, these are sort of kind of statistical analyses, but what they said was that about 50% of the cardiovascular benefit was associated with the improvement in hematocrit. Now, that's not causality, it's an association, but I do believe, as I think you believe, that this increase in hematocrit by enhancing oxygen delivery to the heart, into the retina, to the kidney, is playing an important role in protecting all of these organs.
Thank you, sir. Thank you.
Good point. Thanks for bringing that
sir,
up. Yeah.
Sir, we have to be very aggressive in managing the glucose control. So should we not combine DPP4 inhibitors and SGLT2 inhibitors to begin with?
Oh, yes, that's my favorite therapy. Now, the third, so we lead life with triple therapy. And I think the triple therapy, you may be surprised, those of you who know me, the third agent is actually not metformin. All of my diabetic patients get started on pioglitazone along with a GLP-1 receptor agonist and an SGLT2 inhibitor. And I might also say, I think that this is a major deficiency of the ADA-ESD algorithm. This stepwise therapy, really is not an efficient way of getting the glucose under control. And I also think that the drugs that are recommended or listed in the ADA algorithm as being equivalent are certainly not equivalent. I would not put sulfonylureas and DPP4 inhibitors in the same category as SGLT2 inhibitors or GLP-1 receptor agonists or pioglitazone.
May I discussion with whom?
I have a question, Dr. Sir. My question is that if my patient develops urinary tract infection or genital infection with SGLT2, I will stop, treat, and restart. If this happens again, can I again stop and restart, or do I write it off?
Well, this is a problem that we all deal with because the most significant side effect is vaginal mycotic infections in females, and I might also say in uncircumcised males, a penile mycotic infection. Once you get a vaginal mycotic infection, the likelihood of getting a second one is increased. Now, if you have a very nice drop in the A1C, say it drops from 8.2 to 6.7, now you have to say, look, this is a great benefit. Now, you have to discuss with your patient and tell them the likelihood of having another vaginal infection is increased, but you've got an enormous benefit in terms of glycemic control. So even though there's an increased risk, my suggestion is that we put you back on the drug and then we see how things go. She may say, no, I don't want to go back on the drug. But from my standpoint, I would definitely try to convince the patient that they should stay on the drug, just because we know the enormous cardiovascular and renal benefit. But again, this is a decision that needs to be made between you and the patient. Now, in terms of urinary tract infection, it's interesting that even though in the label that there says that there's an increased incidence of UTIs, if you look at every single cardiovascular outcome trial done with DAPA, Cana, EMFA, there is zero increase at UTIs. The percentage of people getting UTI on the SGLT2 inhibitor is identical. And when I say identical, it is identical, okay, to the placebo group. So we have in our mind this concept, there's an increase in UTIs, but the data don't support that. Now, if you have an increase in UTI, again, I would say same thing as with the vaginal mycotic infection in females. Is something you need to discuss with the patient.
I just have a question for Dr. Anup Mishra. Anup,
Yeah.
are you there? Anup?
Yeah, can you hear me?
Anup, yes, I can listen to you. We're not able to see you. But Anup, I have a very important question to ask. It is a wonderful presentation, Anup. I wanted to ask you that there is talk about the brain insulin resistance as a factor for the obesity and as the factor for the pre-diabetes, making the various sort of phenotypes.
Alzheimer's also, sir. Alzheimer's. Okay.
So,
You may not be able to see the video.
To see you, yes, exactly.
Yeah. But you can hear me. So a couple of points from the previous question. There are a couple of reports where after the SGLT2 inhibitors, the macular edema has shown to be decreased. And these are not series, but these are a couple of case reports. So as Professor DiFranco has said, that definitely it is going to affect diabetic retinopathy as well, and specifically macular edema. And number two, as far as the hematocrit is concerned, sometimes it does too well on that, and we have seen at least 10 cases of polycythemia, 2 of which we have reported. 18 or 19 hemoglobin with high hematocrit, and we had to do phlebotomy in some of those patients. As far as Dr. Das' question is concerned, I think, again, Dr. DiFranco will be in better position to answer, but Dr. Das, Dr. Bajaj, Professor J.S. Bajaj started this particular question almost 35 years back when he said hypothalamic pituitary and beta cell axis, and with the satiety receptors, the various centers in the brain, and then subsequently connection with the vagus nerve, and then to the beta cells. He did some studies in the primates also, and showed that stimulating a particular centers of the brain leads to increase or decrease in this insulin secretion. Those were the initial days, and subsequently this hypothesis did reach a couple of people, other people who did some studies. It remains a plausible hypothesis as far as the diabetes is concerned. But what we are looking at now is more of run-of-the-mill obesity and the fatty liver and pancreatic fat, which is fueling the insulin resistance and also leading to further beta cell failures.
A small sub-question, Anup. You also wrote about futin. What is the protein called? Fetuin. How do you pronounce it? That hepatokine? Fetuin, which Satyanarayana was you on both were discovering that particular protein. What's its role nowadays? Is it still valid as a hepatokine for the obesity? That futin or fetuin, whatever you call it?
Yes, sir. Again, there are a couple of groups who have written a lot about it, and especially German group, and they have written a major review in 2019 on fatty liver and fetuin, and they think that there's a crosstalk between this and beta cells, and so the crosstalk between this beta cells and hepatic macrophages and inflammation is something they have highlighted earlier. So I suppose it is an important protein, but the thing is that this is the only group which is talking about. Many others have not talked about this, so we'll have to wait for some more studies before we actually conclude anything about
Thank you, Anup. Thank you very much. Thank you
Thank you, sir. Thank you.
Mishra, sir, I have a question for you.
Right.
Is our diets in some way related? Because we consume less fish, so we consume more of vegetable oils. And is our diet somewhere related to ectopic fat in the liver and the pancreas, even at much lower BMIs? We see fatty liver in thin people also, who may have some abdominal obesity, but if you see their BMIs, they are normal. So is it related to some way to our diet?
Oh, absolutely. There is no doubt about it. Contribution of diet, apart from other macronutrients, which we often talk about, carbohydrate. If you look at the components of diet which has been researched as far as the fatty liver is concerned, monounsaturated fatty acids have been very well researched. Sugar has been very well researched. Sugar, simple sugar, and carbohydrates. In one of the studies, it was clearly shown that the diets which are high in sugar actually leads to fatty deposition in the liver, but more of a de novo fat deposition in the liver, and the carbohydrate leads to external fat deposition. But as far as monounsaturated fat is concerned, multiple groups have shown that the diet high in monounsaturated fatty acid leads to amelioration of fatty liver. And one of the studies from a Swedish group where they have randomized to a high monounsaturated fatty acid diet, and some of the oils which are available in India have high monounsaturated fatty acid, as well as nuts have high MUFA. So if you look at the oils available in India, simple oils like mustard oil or canola or olive oil have a high MUFA content. And I strongly believe that if we use that oil, and we have shown that earlier also in one of the study where ultrasound-based fatty liver evaluation was there, that high monounsaturated fatty acid oil, if you make a single change in your diet and increase your MUFA, your fat in the liver will certainly go down. And so this is one good strategy where Indians actually can have betterment of a fatty liver and then insulin resistance.
And what about PUFA, sir, ratio of omega-3 to omega-6?
That is also important, but not as important as MUFA. And if you look at the Indian, blood analysis in Indian population, then the RBC, omega-3 fatty acid, phospholipids in the cell membrane is lower than the whites. There are a number of studies which have been done, intervention studies, where omega-3 fatty acid intervention has been done, and the studies are not very conclusive. Some showed some decrease in insulin resistance, others did not. So I'm not too sure about that, but it is always, to my mind, always a good combination, because PUFA ultimately will lead to decrease in the cardiovascular risks, and so we must increase PUFA otherwise. And if it further leads to benefit in the insulin resistance and fatty liver in Indians, well, that's a bonus point. But I don't think we can equate it to MUFA, high MUFA. Right.
So Dr. Dipranjo, nice, excellent talk, sir. I'm your fan. I'm hearing from Banting lecture and I'm learning every time I hear you. I want to know what is the implications of DARE study they did with dapagliflozin. DARE study.
Which study?
DARE. They tried dapagliflozin in COVID.
DARE.
DARE.
Yes, sir.
Yeah. Tell me specifically what your concern is.
Are there any useful information? Is there any useful information from that study? I'm asking. It's a negative study, I know.
Yeah. In my opinion, none. I personally would not have anticipated that SGLT2 inhibitors would have had any effect in COVID whatsoever. If you ask me which drug is going to have a benefit, the drug is going to be pioglitazone. So why pioglitazone? For a number of reasons. When COVID hits the lungs, there's a marked accumulation of fat in the lungs that interferes with oxygenation. Pioglitazone markedly mobilizes fat out of the lungs. That's number one. Number two, in people who have pulmonary, complications, they have this hormonal storm where TNF alpha, MCP1, all of these cytokines are released. Pioglitazone markedly inhibits the release of all of those inflammatory cytokines. when you develop COVID infection, you become markedly insulin resistant. And that also exacerbates the lung disease. And pioglitazone is actually the strongest insulin sensitizer. So if you ask me which of the quote anti-diabetic drugs is going to work, it would be pioglitazone. And in fact, we're about to start a study right now. We've already started one in Kuwait with Dr. Abdul Ghani, and we have one that's about to start here in San Antonio. But I never felt that there was any reason why the SGLT2 inhibitors would be protective, other than the fact that we know that the higher the glucose when you come in, the worse is the outcome. So in general, any drug that lowers glucose might be expected to have some benefit, but I think it's more related to how you lower the glucose, i.e. with an insulin sensitizing drug, than lowering the glucose per se.
Thank you, sir.
Arun, let us conclude the session. Any remarks on this?
Yeah, actually, it was really interesting session, being the last one. But I told in the beginning itself, it was the prestigious session of this day. And of course, we had our renowned speaker, dear Anup Mishra sir, and Diffronso. And to the point which he ended with Diffronso, like whenever possible, I think in diabetes management, we have to think of starting or adding SGLT2 inhibitor, which has so many advantages while we manage diabetes. So
And
that
that is the
I would
only
like to
molecule.
thank-
That is the only molecule takes away the glucose from the body.
Yeah.
Apart from other any sort of the oral drugs.
Yeah.
The only molecule.
And actually, I would like to thank our dear Ashok Kumar Das sir, Hadev sir, Meena ma'am, Ram Kumar sir, and of course, Chairperson Kandula Sai sir. Thank you. Thank you all.
Thank you.
Good night.
See you next year,
Okay.
sir.
Good night to everybody. See you next year in India.
Good night. Good night. Good night.
Okay.
Joe.
Bye-bye.
Great. Thank you. Delightful to see you, sir. Thank you. Anup, bye, Anup.
Bye, sir.
Bye.
Bye.
Sir, భోజనాలు ఇక్కడేనా సార్? భోజనాలు.
Bye, sir. Bye. Arun, bye.
Bye,
love
sir.
you and
Last.
your entire
Good
team.
night. Good night.
Bye.
Take
Meena,
care. Stay
bye.
safe.
Bye.
Stay safe.
Your point was very, very, very important point. I was about to ask the same thing, and no other person than Anup can answer this question. Very, very pertinent question about the diet and the oil. And Ram, you have started a new chapter, laughter in diabetes, and I don't know how. No. See, I stay in Pondicherry, and Pondicherry Sri Aurobindo used to say, it must be in God's will that you used to be able to laugh. You know, many people have a constipated faces. To have a laugh, and laughter, I strongly believe, is the best medicine. So we'll all take it to next level, Ram. Thank you.
Thank you, sir.
Hadev.
After that,
Thank you.
good night.
Good night. Good night. Take care. Stay safe.
Keep
Bye.
laughing, sir.
I'm just leaving.